يسعدنا البدء بأول جلساتنا لهذا المؤتمر. فلتتفضل دكتورة أبرار ثابت.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أيها الحضور الكريم، نشكركم على حضوركم منذ الصباح الباكر في أول أيام مؤتمر IHOP، رؤى مبتكرة في ممارسة صيدلة المستشفيات. نتمنى للجميع إن شاء الله الفائدة الكبرى من هذا المؤتمر. وأفضل شيء نبدأ فيه المؤتمر to start our first session with one of the two of the best speakers, one of the strongest speakers that you may listen to during this conference. The first session we're starting with is about COVID-19 pandemic. Our first presentation will be about COVID-19 vaccines, and will be presented by Professor Ahmed Al-Jidea. Professor Ahmed Al-Jidea is an Assistant Deputy Minister for Therapeutic Affairs at the Ministry of Health. He is the founding president of the Saudi Society of Clinical Pharmacists. He is also a professor at Al Faisal University in Riyadh. He is also a fellow of the American College of Chest Physicians. He is also a senior transplant clinical pharmacist at King Faisal Specialist Hospital. He obtained his doctorate of pharmacy degree from St. Louis College of Pharmacy in the United States. So let's welcome Professor Jidea.
بسم الله الرحمن الرحيم. السلام عليكم، أسعد الله صباحكم جميعا. How much time do I have, دكتورة? 30 minutes? طيب 30 minutes 20 minutes? Oh, okay. ما في واسطة أبو أحمد؟ طيب أسعد الله صباحكم. Good morning everybody. And I would like to start with the disclosure of conflict of interest. I don't have anything to disclose regarding this presentation, and I will not be discussing off-label use of medications today. I'll be discussing COVID-19 vaccines, but I'll focus on the approved indications and age population. These are the objectives of my talk today. So we'll go over the COVID-19 pandemic overview quickly, and then talk about the different COVID-19 vaccines. 2 slides about the administration and different dosing, and then talk about the global vaccination status, and then move to the Saudi vaccination status, and finally talk about the vaccination certificate program. So starting with the global outlook of COVID-19. As you all know, the first case was identified in December 2019 in Wuhan, in China. By March 2020, it was declared as a pandemic by the WHO. And then the number of cases as we are talking about now, by the way, we had our first case in March 2020 here in Saudi Arabia. And currently we're talking about around 260 million infected patients worldwide. Around 235 million of them recovered, and 5.18 million have already passed away, and the rest are still either receiving care or recovering. In Saudi Arabia, we had about 550,000 cases, 538,000 recovered. We had about 8,800 cases of death, averaging as a case fatality rate of about 1.6, which is below the average, global average. So really quick, COVID-19 infection has actually impacted the healthcare system worldwide like no other disease in the history, I would say. The closest history in terms of the impact was the Spanish flu in 1918. And at that time, we didn't have vaccines. However, now we do, and despite this, the impact was really huge. It was really, there was unprecedented efforts from all governments in the world to fight the coronavirus 19 battle. And our government was in the lead by offering free health care to all COVID-19 infected patients, regardless of their nationality, race, gender. Okay, sorry. I wasn't paying attention. The second thing is it offered treatment, as I said, to everybody, including Saudis, non-Saudis, and even including illegal residents and immigrants. At this time, we're talking about dozens of vaccines that were developed in a very short period of time, in a very or in an unprecedented time frame for approval of any therapy whatsoever, including vaccines. Can't see the slides yet, ya Jama'ah. Okay. Let's talk about the okay. It's flickering, ya Jama'ah. Tech support. Okay, so let's continue and talk about how it impacted the healthcare. First of all, there was huge pressure on all types of healthcare at all levels of healthcare, starting from the primary, secondary, and even tertiary care was really affected. We're talking about treating patients in the ambulatory care, but at the same time, we had cases where it reached very advanced stages and required ICU stay. Excuse me. Not only ICU stay, but we reached an end-stage organ failure, leading to lung transplant in very few cases. It was a huge impact on public health, where the need for technology, need for awareness, education of the public in terms of the precautionary measures and how to deal with such an important pandemic that is affecting all aspects of life, social, economic, let alone the health aspects. It affected the healthcare budget, where governments had to pour a lot of money in identification of the infection, diagnosis, and management of this COVID-19 pandemic. It affected supply chain throughout the world. We've seen how the PPPs, gloves, masks, and protective clothes were really in severe shortage in many countries. We've seen videos of nurses in North America wearing plastic to cover themselves and to protect themselves and their patients instead of proper PPPs. We've seen gloves used over and over for the same patient. We've seen masks used for more than a week, washed by nurses, physicians, and other healthcare providers so they can be reused. This also affected medications. We've seen huge shortage in active pharmaceutical ingredients. Many medications were in back order. Thankfully, alhamdulillah, in Saudi Arabia, we didn't really feel this much. Early on, we started working with the help of all government agencies, with the leadership of Ministry of Health, Saudi FDA, NOPCO, Ministry of Industry, and others, to manufacture these PPEs and disinfectants gels here in Saudi Arabia, so that we don't become in severe shortage or reach a severe shortage status. It affected the practice of healthcare. When we saw pharmacists in the community playing a major role in educating patients, offering therapy, and we've seen unmatched research efforts all over the world in terms of developing treatment for COVID-19 vaccine and development of vaccines. It was really something unique. We've seen the involvement of patients, not like any other disease. I can't remember in my lifetime a disease where patients and the public were really following the advancement about a particular disease similar to the situation of COVID-19. Now it stopped here even, ya Jama'ah. Okay, so let's talk about what the government of Saudi Arabia has done. So early on, it started a very transparent process to inform the public. We created an online platform where we share the number of cases and the number of ICU patients, critically ill patients, the number of deaths. We also started having daily conferences to update the public about the current situation, about the new strains that develops with time. We talked about multiple aspects regarding to the precautionary measures in terms of social distancing, in terms of wearing masks, washing hands. This was really a fully engaged public health efforts by our Ministry of Health. We also had an online interactive dashboard that tells patients where to seek therapy. Primary health care with geographic locations were available. We created apps so that people can utilize the app to get inside shops, malls, restaurants, to demonstrate the status of their infectivity, whether they are infected or not. And also, we added to the app later on the vaccine's status as we went by. So let's talk about the COVID-19 vaccines. There are multiple COVID-19 vaccines with different technologies. Some of them were totally new to the health care, something that hasn't been used before. It went through very fast track review and approval. The clinical research that was established and developed was unmatched by We cannot fix it, Jama'ah? If we cannot fix it, let me just see where I'm at least. We also started talking about involvement and engagement of patients in these clinical researches. Regulatory bodies like US FDA, okay, good, started a fast-track approach in order to review the data in a status or in a methodology called rollout approval process, where companies would send data as they become available to the regulator so that regulators can review them in a timely manner and make a decision about them. So in terms of COVID-19 vaccines, we have multiple technologies. The first one, as you all know, in all different vaccines, we're used to what we call the live attenuated vaccines. And then we have the killed vaccines. And then we have the particles vaccines, or what we call viral particles vaccines. And then we have newer technologies like the viral vector vaccines. And for the first time ever in COVID-19, we started hearing about, and we had the protein vaccine in the past. And then for the first time ever, we started talking about the mRNA-based vaccines and the DNA-based vaccines. So, really quick questions about vaccination. First is, how much does a vaccine reduce the risk of COVID-19 infection and its complication? And there has been multiple guidances. One of them was issued by Ministry of Health here in Saudi Arabia about how it affects the transmissibility, how it affects the severity of the disease, and how it affects the death rates. And we can say, after we have known more now about the vaccines that we have in hand, that most vaccines would reduce COVID-19 infection significantly. They reduce death very significantly. So we're talking about more than 99% reduction in mortality, more than 95% reduction of getting COVID-19 disease, not really the infection, but the disease. So you still can be infected, but the impact in terms of the development of respiratory symptoms, viral pneumonia, and others would be reduced by about 95%. One of the questions that was raised early on about the safety of vaccines, and now we can also say with great certainty that the vaccines that are available currently are very safe in most patients, with a very rare adverse side effects affecting, I'm talking about the serious side effects affecting very small number of patients who received these vaccines. Now, the general flu-like symptoms, fever, pain in the injection site is a common thing, and this is part of the development of the immunity, which needs to be looked at as a good thing, not a bad thing. However, severe side effects such as bleeding disorders or thromboembolic events, things like myocarditis, are extremely rare, ranging between 5 to 12 in a million patients vaccinated, and only in high-risk patients. Okay, so what are the current vaccines available in Saudi Arabia? We have 4 approved vaccines. We have the first one was the Oxford AstraZeneca vaccine, followed by the Pfizer BioNTech vaccine, followed by the Janssen or Johnson & Johnson vaccine, and then lately Moderna was approved. I have very extensive slides for those who would like to read about every single one of them. However, I'll try to summarize the differences between these vaccines. So let's start with the first one. I would like also to refer you to a review article that we published in the Saudi Pharmaceutical Journal early on in August 2020, even before we knew a lot about vaccines, reviewing the current efforts of vaccines development for COVID-19 and talking about the vaccination strategy in Saudi Arabia. So the first one that we have is the Pfizer COVID-19 vaccine. It's an mRNA vaccine. It's this. Oh no, it's up, but it's not synchronized. Let's go to the. It doesn't move. Okay. So I have to use 2 clicks. So I have to move to many slides. So these are the 4 vaccines that we talked about. As I said, I have comprehensive slides on the differences, the approval of each vaccine, the different technology used in each one of them, and I would refer you to our publication, even though it needs updates now since it's almost a year since it was updated or published. These are the different vaccine subtypes. We talked about the protein, the virus-like, the DNA-based, RNA-based, non-replicating viral vector, and this is what Oxford, AstraZeneca, and Johnson & Johnson vaccines are. We have also the the killed vaccine, which we don't currently have any approved in Saudi Arabia, but they are available somewhere else, like the Chinese Sinopharm. These are the different vaccines as per their mechanism of action. So starting with Pfizer vaccine, as we said, it's an mRNA-based vaccine. One of the advantages of such vaccine is it boosts the immunity significantly, so it actually gives a strong immune response with also effect on B cells and T cells. As you all know, we need the antibodies that are released by mature B cells for immediate or the short-term protection, but we also need the long-term immunogenicity that is usually carried by T cell and memory cells. However, this vaccine is less effective in people who have already a pre-existing antibodies against the viral vector, especially if given only in one dose. This vaccine provides about 95% protection against COVID-19 infection with 2 doses. We're talking about 55 to 60% protection with a single dose. We're talking also about a different type of vaccine called the whole virus or the inactivated, and we talked about the Chinese Sinovac vaccine. However, it's not yet approved here in Saudi Arabia, and it provides less protection, around 50% protection with 2 vaccines, with 2 doses. The live attenuated, we're not going to talk about it. The inactivated vaccines, The protein-based Novavax is one of the vaccines that uses the protein subunit platform. It also provides around 90+% protection against COVID-19 vaccine. The viral like particles, currently we don't have any approved here in Saudi Arabia. And then we have the split virus vaccine. And then we have something very new called the mRNA induced antibody. It's more of an antibody rather than a vaccine, so it provides passive immunity rather than active immunity. It's different than the monoclonal antibodies that are available now for treatment, because this one, you give the vaccine and you ask your body, it encodes, it's an mRNA-based vaccine. The mRNA has coding to release antibodies immediately against the vaccine itself. So it's more of a passive vaccine. This is how we give the vaccine usually in the deltoid muscles. Oh, sorry. Until you will move it? طيب, sorry. طيب. طيب لازم نشوف slide حقتي. طيب, why do we need two doses? We need 2 doses for 2 reasons. One, antibodies fades away. Remember, this is something that we have never been exposed to. So usually with so many vaccines, we really need 2 or more series. So we're talking about hepatitis B vaccine, for example. We're talking about MMR. We're talking about influenza vaccine. If it's given for the first time ever in young infants or neonates, we need actually 2 doses. So it's very important to activate the B and T cells. And with the first dose, you really don't activate T cells enough, and you don't activate B cells enough to produce enough antibodies. Antibodies fades with time. What we know currently is that within 6 months from the administration of the second dose, you still have protective antibodies against COVID-19. So initially here in Saudi Arabia, because of the severe shortage of the COVID-19 vaccines and the competition that we had from all countries for COVID-19 vaccines, we started giving vaccines to vulnerable patients, or vulnerable subjects, I would say, not patients. We started with essential workers, with all the technical difficulties. Okay. So we gave it to healthcare workers. We gave it to high-risk with medical conditions, elderly above 65. And then we moved on and we offered it to adults. And now we're offering it to even adolescents, 12 years and above. And very soon we're going to be offering it for patients who are 5 years and above. Not only this, we started providing what we called a booster dose. And there is very important difference between the third dose, or what we call the booster dose, and the third dose for patients who have immunity-related disorders. The difference is that for normal people, the immunization series is only 2 doses. And then we get a third dose as a booster dose, as we said, because the antibodies wanes off after some time. However, for certain individuals like organ transplant patients, oncology patients, patients with primary immunodeficiency, they actually need 3 doses as part of their series, okay, not 2 doses. And then there is a possibility, because we know in those patients, at least from the literature, that after 2 doses with the mRNA vaccine, you are getting about 46-47% protection rate, which is very low. With the third dose, we are talking about 68%. And now we're talking about a 4th dose for those patients in order to boost their immunity. Global status, really quick. So currently we have about 54% of the global population have been vaccinated with at least one dose. About 7.8 billion doses have been already given, and only 5.4% of patients or people in low-income countries have received at least one dose. So there is huge disparity between the vaccination status in developed countries versus developing countries. We have only 3.3 billion individuals who have been fully vaccinated in the world. Saudi Arabia ranks among the top highest 10 countries in terms of vaccination. Not only this, but we offer vaccination free of charge for all individuals, those who are insured and those who are not insured. Currently, we have given more than 47 million doses of vaccine. 22.3 million people have been fully vaccinated, so are doing really good compared to other countries. If you look at the vaccination progress in Saudi Arabia, is actually comparable to developed countries like Europe and North America. We're actually working to offer more vaccination with better access, those of you who have received the vaccine. So how organize the vaccination centers? You get in and out within less than 5-10 minutes, and everything gets automatically uploaded in your phone app. We have developed a robust immunization strategy to quickly cover the entire population. Finally, I'll finish with this. For pharmacists, we have worked in the Ministry of Health with the Saudi Society of Clinical Pharmacy to develop an immunization certification program for the first time in the kingdom. And this certification program offers an immunization certified practitioner to those who have completed the practical and the theoretical aspects of the program and passed the examination. As of now, we have trained more than 300 pharmacists. Most of them are in the community pharmacy. We have given already more than 250,000 doses of vaccines in Saudi Arabia by community pharmacists. The certification program is available online through the SSAP learning module. You can actually go and register and get the online didactic reading, do the theoretical exam, and then schedule yourself for a practical exam where you can actually be offered the certification, immunization certification program thereafter. With this, I end my talk, and I thank you again.
Okay, thank you very much, Professor Al-Jadair, and definitely apologies for the technical issues. We added actually 10 minutes extra to your presentation because of the technical issues. Okay, our next speaker, with whom we are kickstarting our conference today, is Dr. Thamer Al-Shammari. Dr. Thamer Al-Shammari is an associate professor of health outcomes at Riyadh Al-Ilm University. He is a pharmacoepidemiology and pharmacoeconomics consultant. He completed a postdoctoral fellowship at the Office of Surveillance and Epidemiology at the United States Food and Drug Administration, and was actually the first Saudi to do so. He obtained his PhD degree in pharmacoepidemiology and pharmacoeconomics from the University of Rhode Island. He also obtained a master's degree in clinical pharmacy from King Saud University and his bachelor's degree in pharmaceutical sciences from King Saud University. Dr. Thamer Al-Shammari will talk to us about COVID-19, the Saudi experience.
السلام عليكم ورحمة الله وبركاته جميعا. صبحكم الله بالخير. بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. I'm so honored and glad to be here today with you in IHOP. We welcome all in IHOP. I consider myself as part of IHOP. I would like to thank the organizing committee or scientific committee to invite me to talk today in a very important topic about our effort, Saudi Arabia effort in facing this and fighting this pandemic. I would like to thank also Dr. Abrar for her introduction. So while they're having the things fixed, I would like to ask you, all of you, how many of you has Tawakkalna application with you now? All? I see some people, so I would like to ask Mr. Majid, anyone who has no Tawakkalna, take them out of the audience. Tawakkalna was one of the success stories that we have, that we face in this pandemic. So the pandemic, as Dr. Ahmed mentioned, started in late December, exactly 31st. And when they started, the first report sent by the Chinese authority to the WHO, they were thinking it's just a flu. However, later on, like within a week, they started to get more cases of the COVID-19. And then the WHO, almost like January 7th, they thought, this is something weird. We need to investigate and more. Later on, when they found that the number of cases are really increasing, and the first case that's happened in Thailand, they believed this is something weird, and we need to investigate. Then they investigate the virus, and they found this is a unique virus. This is another type of the 2001 virus, which is called SARS, if everyone remember, especially the older people here. This is called SARS-CoV-1. This is one than 2002. Oh, we start. Okay, thank you. This is the next. Okay. Yeah. So the WHO thought it's really just simple, either flu, and later on they believe it's MERS. However, because the infection was only in China, similar here in Saudi Arabia, in the area. However, they found it's really not that's the way. I will tell you later why. But in March 11th, they found, or they declare actually, this virus is considered as a pandemic worldwide. So it's just an example of the process of the virus, where how it happened, and what the consequences or the time frame for the virus. I'm not going to talk about it in details, but if you see January 13, the WHO report the first case outside the Thailand. This was alarming to them because the pattern of how this virus is spreading outside China. And February 26, the National Institute of Health, which is the biggest institution for funding and also conduct the research in the US, to test some of the medication that early used for different type of viruses, for yellow fever virus, which is remdesivir, which is now is used here in Saudi Arabia. And in April, we reached up to 100,000 death rate due to COVID-19. So it's all these sequences is really giving us a hint how big this one. This was also presented by Dr. Ahmed. However, this, I believe it's more updated. We have almost over 60 million people infected worldwide with COVID-19, over 5 million death cases, which is a really huge number of cases. And this is why we really need to focus, we need to monitor. I'm sure most of you saw this picture in Italy, in Spain, and with a lot of disaster picture because of the death due to COVID-19. Since I witnessed this pandemic since the start, and I attended several webinars, a lot of physicians from Italy and Spain were crying, as Dr. Ahmed mentioned earlier, because they don't have mechanical ventilator to help their patient. They were seeing the patient die because of the virus, because of lack of the equipment. Luckily, alhamdulillah, we did not all have all of these because we started earlier, we started ready. And even if the leaders in these countries, and we remember when President Trump, he was always critiquing the virus, and even though he doesn't call it COVID-19, do you know what he called it? Any idea? What President Trump called the COVID-19? He called it China virus. So, and he thought that it will go away. It will not stay a long time. However, we still have the COVID-19 and with this new variant. Boris Johnson, the Prime Minister of the UK, he went in the TV. People were happy that he wanted to talk. But what he said, be ready, you will lose more people. Be ready, your lovers might die because of COVID-19. So this is the situation in different countries. And President Bolsonaro, who is the president of the Brasilia, he was like the people of Brazil were trying to tell him, we need to do a precautionary measure. We need to apply what's happening outside to prevent the death. He says, stop screaming, stop whining. Nothing will happen. And unfortunately, the result of his action led to over 600,000 deaths in Brazil, considered from the top countries who have higher mortality rate due to COVID-19. And this is what really happened in South Latin America. Another example in Sweden, which is considered one of the highest or the top for the good healthcare system. They don't believe in the lockdown, and they believe that we don't just have to live our life. Unfortunately, they have the higher death rate 10 times compared to other countries. So there are many countries where against the lockdown, many countries where they thought there is no need for masks, no need for the social distances, and they thought the vaccine is just a flaw. However, in Saudi Arabia, the situation is totally different. And we remember the speech by the top leader in the country, King Salman, when he came to the TV and he was calming the people, and he said one word: your health is our top priority. This is a difficult time, but we will pass it. We will go over it, all of us. We're supporting you, and we'll try to do everything to protect our people. So this is just to compare between other countries compared to our country. So what Saudi Arabia did, actually, 20 minutes won't be enough even to talk about a part of the activity that done, at least by Ministry of Health, of all the effort that have been done. So we'll need days and talk about all the action that done by Saudi Arabia. So because it was taken really seriously from the first days of the pandemic, and the first. So the king is supporting this, and the first decree was released on January 16 to establish the higher committee as phase 1. And this committee was led by the Minister of Health and by the Minister of Health at that time, Dr. Tawfiq Rabi'a, and was part with the Ministry of Interior, Ministry of Foreign Affairs, the Ministry of Finance, Ministry of Media, and also the Saudi Center for Disease, Saudi Control for Disease Prevention, Saudi Center for Disease Prevention and Control, and also General Authority for Civil Aviation. And this was the first phase. They were trying to make sure to limit the spread of the virus. Later on, the second phase include all of government agency that's related, that have a rule in limiting the viruses. And also it's led by the Ministry of Health. So this is the paper that we have published to measure, to assess the importance of the measure that's done by Saudi Arabia. And I will explain this later in details, but just to show you the impact, like day by day, we're monitoring all the activities of the development of the virus, the number of cases, and take measure day by day. And this project, I'm proudly that I have worked with two colleagues from the Ministry of Health, Dr. Ranizi, Dr. Anson, Dr. Benawi, for publishing this paper. So this is the timeline. I'm not going to talk about this in details because all of you would know all of this part. But in a week after the starting of the decree, the activity of command control with the Ministry of Health started to work. And later on, some of the action needed to be done. For example, like holding Umrah for citizens of Saudi Arabia, also the suspend of the visas, also the make sure the disinfected of the mosque, of the holy mosque. And unfortunately, the first case of COVID-19 was come to Saudi Arabia in March 2nd. So this is the, go back. This is the also timeline when there was suspending of the flights, domestic and internationals. Also the traveling from some countries that have epidemic cases of COVID-19, namely here the Emirates, Kuwait, Bahrain, Lebanon, Syria, Egypt, and Iraq. Also the suspending all international flights. The closing the mall and the curfew that was started, that needed to be done to limit the spread of the virus, and also the having the G20 summit, which was very important to us as Saudi Arabia, to be virtual and not cancel it, and also in March 16, suspend or to start people to work from home, and I'm sure all of you remember this part. Also, when they started to like not spraying in the mosque, and also they start the curfews in some cities to be 24 hours. Riyadh was one of them, and in addition to Mecca and in Medina. And also, the 24 hours during Eid al-Fitr curfew all over the kingdom cities to limit the spread of the virus, and etc. And later December 2020, there was establishing or the creation of the vaccine, and luckily we were from the first countries who had this vaccine, and with the massive campaign to vaccinate people. And this is just an example until the releasing a lot of the restriction that was mentioned yesterday during the opening ceremony. So this is another paper that we were comparing almost 175 countries worldwide for the precaution. And we see that there's a lot of spaces that many countries that are not really applying these precaution, which they were the first line to prevent the spreading of the disease. Saudi Arabia was one of the countries that's applying all the international measure or precautionary measure. This just compare the Asian, Europe, and Africa countries. Again, the slide is here, so please feel free to go back to look at them. So as resources, as I mentioned earlier, the custodian of two holy mosques, King Salman and his crown prince, Prince Mohammed bin Salman, provide all support, including the monetary support. First, they start to support of 120 billion Saudi riyal to fight this pandemic. Later, they provide the Ministry of Health of 15 Saudi billion riyal, and later also they provide 47 billion Saudi riyal. And also they think of the private company on all the government, and also support with 50 Saudi million riyal. So this is a huge amount of money. This is a budget of many countries. This is was made only for COVID-19. And alhamdulillah, we got the results from all these supports. This is the press conference was led by Minister of Health and Minister of Finance, and also the Saudi also signed a contract to do a massive or mass testing to limit the spread, trying to find the cases. This was with countries in the China, US, to build 6 regional laboratory, also to do over 15 million testing and like 50,000 testing daily and this was done through NIPCO, and this is the photo of the signature, the contract. So when they start early January, they combine all the related stakeholders, find them how we limit this virus. So this is just an example, the working together, the chemistry that was done at that time. And this one of the examples within the Ministry of Health, how the departments were working together, the supply, the therapeutics, the public health, all of these were working together to limit the spread of the virus. Last night, I was really lucky to be here. I was impressed of the number of the activity that was done by the pharmaceutical care by the Ministry of Health, having over 100 million prescription, having over 700,000 delivering of the medication, over 300 counseling. This is a huge effort that's been done by our colleagues at the Ministry of Health, and I'm sure by other health sector. Also proudly, by Saudi people, we develop a lot of publication. If you go to the UK or the US, you will see them, they get the appointment by paper. All of our dealing with the virus is done through this application. I'm sure you know توكلنا, you know صحتي, موعد, تباعد, and Saha. So all these applications available to you, Saudi, non-Saudi, even illegally people of that. So the massive testing, as mentioned earlier by Dr. Ahmed, that's everyone can go and do test and through your application. Actually, I did it myself, and I just went to the application. You can go there within a minute. You could take your application appointment from the application, and you can do your testing if you need to do a testing. So the resources, once they started, and this is one of the really important measures in public health, and this is also again done here in Saudi Arabia. They have a specific plan. If there is a number of cases exceed this number, we need to, for example, to treat, to focus on our patient, to focus on COVID-19 patient. Sometimes we need to evacuate some of the hospital and make them to be for treatment of COVID-19. And this has happened for like short period of time because there was a need in some cities that have epidemic with the virus. And this is the Ministry of Health that makes sure that all of the resources will be available, all the supply chain will be made here in Saudi Arabia, including the medication and including the vaccine. And this was in November, and within less than a month, we got the vaccine. The first one was mRNA vaccine, Pfizer vaccine. And also, a lot of communication. This is a really good sources to get more information about COVID-19. And this is just an example. If you go to the website of the Ministry of Health, you will find it. The protocol that was published, or they were published within the pandemic. Let me ask you a question. Do you know how many protocols we have for COVID-19? I'm not talking by Minister of Health, but I'm talking in general. Anyone know? Any idea? As a number? Guess? 20 or more? 30? We actually have over 60 protocols that were released by different government agencies, protocol how to go to the malls, protocol how to work inside your workplace, and etc. So these all also available if you can access them. And this is one of the also a very great example, which is the therapeutic.
1 minute.
Sure. The therapeutic guideline that started from the early phases of the pandemic, and it was daily. It was like updated based on the science, on the information of that's were available. We know that at the time we do not have exact treatment for the COVID-19, but there was a need to have a therapeutic guidelines to help to treat our patient. And this guideline, when I go outside, people were using this guideline in their treatment of the COVID-19. And it's just an example of the statistics that we have. We have over 100 million an appointment in Maw'id application. And this is a really huge number. We have over 31 massive testing, and as Dr. Ahmed mentioned, we have over 47 million doses of vaccine, which is really a good number, and we're looking for more. Communication, it really was more important, and again, the first communication was done by the top leader, King Salman, when he said, your health is our top priority. And of course, Dr. Mohammed Abdel Ali was with us yesterday, and he was come to us. He was also, we all, as Nawaf mentioned last night, we consider him as part of our families. He come every day to us and tell us about clearly and transparent what is happening, what you need to do, how to protect yourself. And this was really important to be done by the Ministry of Health. Lastly, in California, in the U.S., they don't believe in the precaution. They don't believe in the lockdown. They don't believe on all of these things. What they have done later on, because they have a huge number of cases, they're using Saudi Arabia as example of the facing or fighting the COVID-19. And this is a message that we can do a lot. And myself, someone who's really witnessed this pandemic, I consider our experience as the best experience in facing and fighting COVID-19 pandemic. Lastly, I would like to congratulate the Ministry of Health for getting the best agency or the ministry in digitalization, and this really was clearly if you go to their website. So, in summary, usually when I summarize things, I summarize what I have said. But instead, I would like to say thanks for all effort that's been done. First, thanks to Allah subhanahu wa ta'ala for helping us, supporting us. Second, I would like to thank our leaders, King Salman, his crown prince, of what they really did support compared to other countries. And this is a real situation. When you hear a physician crying because he cannot do anything, you will believe that you are really in one of the best countries. I would like to thank also all the government agencies of all efforts that have been done in this pandemic. I would like to thank the Ministry of Health of their leadership of taking us from this pandemic to having less affected countries worldwide with that. So please, I would like you to applaud the effort by the Ministry of Health of what they have done for us. And lastly, I would like أسأل الله أن يترحم جميع من توفى في هذه الجائحة سواء من الموجودين عندنا في السعودية المواطنين أو المقيمين، أيضا من زملائنا العاملين في الصحة في جميع القطاعات. أسأل الله لهم الرحمة، وفي النهاية أشكركم جميعا، والسلام عليكم ورحمة الله وبركاته.
Prof. Ahmed, تفضل for the discussion. Okay, before we start the discussion, we first would like to thank our distinguished speakers, Professor Ahmed Al-Judai and Dr. Thamer, for these great presentations. that showed us that how we stand out in the crowd and how we have, alhamdulillah, one of the perfect examples in the world in terms of availability of the vaccines as well as the experience of the country in dealing with this difficult pandemic. So now we will open the floor for questions. So if anyone has any questions to Professor Ahmed Al-Jadeh about COVID-19 vaccines or to Dr. Thamer Al-Shammari about the Saudi experience in dealing with COVID. Doesn't look like there's any questions from the crowd. I actually do have one question. Both of you presented a map of the current vaccination status in the world. And many of us may have noticed that the lightest shading was in Africa and the darkest was in the rest of the world. Do you think that this could be theoretically the reason behind the emergence of the latest variant, Omicron?
I was expecting this question from you, Dr. Abran, and I warned you yesterday not to ask difficult questions, but you insist on putting me on the spot. So nobody knows, to be honest with you. First of all, we didn't know how vaccines would, or the efficacy of vaccines against Omicron strain. We don't know much about its infectivity. We don't know much about, when I say infectivity, I mean the transmissibility of the virus compared to other strains. We don't know much about with the pathogenicity, whether it's more severe than others. However, early signs doesn't indicate that it's more severe than the Delta variant. Now, vaccination, we know what we know so far. And WHO actually yesterday, the expert group published their, not published, but they announced their initial recommendations or findings. What we know is that most of infected patients in these African countries were not vaccinated. Now, whether this is a result of the status of vaccination status in Africa, because we know it's not that good, it's one of the lowest in the world, or it's because it's more of a mutation that happened in those who were not vaccinated. So it could be the cause or the result. Currently, we don't know much about it. Hopefully, this is not going to be much different in terms of its pathogenicity and infectivity. We know that nobody has died so far from Omicron up until last night from the WHO findings. Now, the question that is very important is we know that there have been multiple mutations, unlike the previous variants. And we are worried about this because it could affect the response to vaccines. What we know for sure is it doesn't affect the diagnosis. So the diagnosis in terms of PCR is still as sensitive as the previous variants. Hopefully within the next, if you ask me this question again next week, I might give you a different answer because it's very rapidly evolving. Lots of information are being gathered currently, and I hope we learn more about the Omicron. But in short answer, it could be the cause, and it could be the result of low vaccination status.
Thank you very much. Any other question from the audience? Okay, I think I have a question to Dr. Thamer. Do you anticipate with the new formulation of the Pfizer vaccine for the children from 5 to 11 years, do you anticipate it to be mandatory for the children in Saudi Arabia?
This is a difficult question as well. So, again, as this will be dependent on the situation of the infection itself. Do we need to have this based on the infection rate that we have here in Saudi Arabia, especially in the children? We know that, at least based on the research that's been done in pediatrics, that the infection rate in pediatric is less than the elderly or even the adult. However, where it's going to be mandatory or not, this is totally up to the leaders here, especially the Ministry of Health, contact with the Ministry of Education to decide if this is going to be mandatory or not. I just want to go back to the question that you asked earlier. I totally second Dr. Ahmed what he mentioned. I believe, just to add to that, I don't think this virus, again, we don't know a lot about this virus, and we cannot judge anything, but just like expecting that it won't affect a lot, hopefully, on us. For two reasons. First, hopefully the vaccines will have impact. And second, we have some promising medication that might help, especially in early cases of detection of the virus. Thanks.
Thank you very much. Last chance, if anyone has any question from the audience to our speakers. Okay, I think with that we can close our first session. Thank you again to our distinguished speaker, Dr. Thamer and Dr. Ahmed.
Thank you.
يسعدنا الآن تكريم المتحدثين الكرام. بروف أحمد الجديع. الدكتور ثامر الشمري. الدكتور أبرار ثابت. والآن يسعدنا البدء في الجلسة الثانية بتقديم الدكتور عبد الله الحماد.
Now we will shift and talk about pharmacy and emergencies. So our first talk will be about disaster planning. I'm not sure if some of you have dealt with Code Yellow or whatever the color that's being defined in your institution that related to dealing with disaster planning that comes from outside usually. So for this talk, we will have Dr. Amal Baghalib. She is the head of Medication Safety Unit at King Saud Medical City. She obtained her bachelor degree in pharmaceutical science from King Saud University in 2001. She is passionate about improving quality of pharmacy services, and patient safety is always her priorities. She has participated in many campaigns and webinar and conference locally and internationally. So please join me to welcome Dr. Amal to the stage. Thank you.
Thank you for the introduction. Good morning, and let me start by saying it's an honor to be here today, and I would like to thank the organizing committee for giving me this chance to be present the topics. The good luck is the result of good planning. A few next minutes we will be talking about the important topics that we have already shown and witnessed the importance recently, which is disaster planning. The definition, the objective of the learning objective today is to start by definition of disaster, types of disaster, and disaster management cycle, rule of the hospital during disaster. And at the end of the lecture, we're talking about our experience, KSMC experience for the managing of the disaster planning during pandemic COVID. WHO, this definition, the World Health Organization, disaster, it's a sudden phenomenon of sufficient magnitude to overwhelm the resources, to overwhelm the sources of a hospital, region, or location requiring extreme. Any occurrence that cause damage or ecological disruption, loss of human, loss of or deterioration of the health and health service. Actually, the disaster have many types, two types, natural types and man-made types. The natural disaster types is related to the earthquakes, volcanic eruption, floods, drought, and pandemic of disease, and snowstorms. For the man-made disaster, as conventional warfare, nuclear, biological, chemical warfare, vehicle, drawing, collapse of building, and explosion gas, nuclear and fire. If we talk the impact of the disaster for the community, it's seriously damaged and destroyed the community, and it can be affect to the business communities and the function of the life. So the impact of disaster is depending on many factors, such as type of disaster and the density and the distribution of the population, condition of the environment, degree of preparedness, and opportunity of warning, and what's happened globally as the immunization level of the population. This is the Disaster International Database in Saudi Arabia since 2000. We are going to the main part of our lecture today, which is the disaster planning in hospital. The disaster planning in the hospital. Any failure for the hospital emergency to facing or to managing the disaster will be impact to the society and to the community and to the business, which can be damaging and destroy or weakness for the health capital. The disaster planning appear to be from the importance as the standards of Sabahi. There is a lot of standards that not only for FMS but only for the others domains like medication management and nursing. The role of the hospital in disaster, hospitals playing an important rules for the managing the disaster, which is suffering the life of the patient, and avoid to be separate the disasters and the risks of the disaster to all the community. The role of the hospital disaster is to ensure the effectiveness healthcare response during disaster and the safety of the patient, collecting and analyze data on illness to detect and prevent potential outbreak, also providing immunization service to prevent outbreaks disease. Disaster, we have a classification for disaster. It could be internally, external, and both. Internal, that's mean within the wall of the hospital. For example, the radiation exposure or power outage. External, that's outside of the hospital, or and other means occur at the location separated from the hospital. For example, the industrial accident or the transportation incident. Internal, external can be affected. It can be put together, such as some disaster cause mass casualties as well as damage of hospital structure. Now we are talking about the reducing the risk of disaster. Before talking to reduce disaster, we should take a brief about the about the disaster management cycle, which is ongoing process which by government and defense, civil defense, to minimize and to reduce the effect of impact of disaster by act immediately and following after the disaster, and take steps to make rapid response and come back to the normal life. The disaster management cycle have two phases: pre-disaster and post-disaster. The pre-disaster, it's related to the preparedness, planning, and avoid. This is the preparedness planning. That means make a planning for everything, like supply, planning for logistics, planning for manpower, planning for the space. If the hospital already have a good place to receive this the patient inside, also planning for evacuation of the patient, planning for training of our staff. Also training, not our staff, we have a volunteer should be included in this training. The disaster planning, disaster preparedness plan also related to activate the codes, emergency codes, and make a plan, disaster plan inside the department by identify all the people or the person inside the department, what's the job or what's the already function during the rule or during the disaster. The response, it means the action that already taken during an emergency to save lives and property and the environment. Response means the action, the phase. This is the action. What we are planning in the previous stage, this is now, it should be activated. After that, we go to the recovery. Recovery means action taken after on emergency to restore and resume normal operation. That means go back to the normal life, try to make it planning and to act directly to be and rapidly to go the institution and hospital to go normally situation. The mitigation to offer to reduce effect or risks associated with hazardous. Medication management cycle should be continuous. That means after finish the last phase should be make plans for or updated the plans for the next disaster by setting the commands and the emergency committee to show what's happened in the previous disaster, which the weakness and the mistakes that was happened to be avoided in the next planning in the future. So should be continuously and updated and with the training of the staff for the learning and the mistakes in before. We are now going to talking about our experience of King Saud Medical City during pandemic. King Saud Medical City is a tertiary hospital, maximum bed capacity around 1,400. And they have carrying more than 23% inpatient discharge per year. Average, the KSMC receive annually more than 265% OPD and 190,000 ER visits performance, more than 10,000 surgery per year. And it will aiming to become a regional center excellence in trauma, Saudi Arabia. We will start the first phase of the command center timeline. At March 2, 2020, we reported the first case in Riyadh. 9th March, they start formulation the central command center in the KSMC and make it and the planning for all the plans of the COVID surge plan, pathway transfer to the COVID positive, also the preparedness plan, risk assessment, also training the staff, all this done. During this phase, there is many challenges done because our aim and the goal to be expand the ICU from 127 bed capacity to be 338 bed capacity. That means will act as a manpower and to be increasing more than 20% of the source. For the managing of manpower, we have acting to training the non-staff ICU from nurses, physicians, clinical pharmacists, IT to be performance and to be ready for any surge of the patient. Also acting to adjust the requirement during the surge of the patient. For the isolation capacity, increase isolation bed capacity to be 385. Increase in negative pressure from 7 to 29 beds, increase the opening medical tower 2. For the medical gas challenge, we have facing a medical challenge for the main building and for the tower 2, and they act to be upgrade the gases system installation, which to be avoid any low oxygen or any risk could be happen for the patient. For the maintenance initiative, they have setting up mobile tents and providing permanent emergency power. New glass panel and sliding door were also installed to isolation each bed and also along the hallway. Also, during the first phase of the command, we're facing, due to expand of the ICU, that the second floor of the patient in the general hospital, they have some alarm about the gases pressure. So this is the decision take to make evacuation of the positive cases patient. Around 80 patients transfer to the tower, medical tower 1 within 2 hours without, alhamdulillah, any risk for the patient. For the pharmaceutical service administration rule during the pandemic COVID-19, in the home delivery pharmacy service, the aim to make a service for the inpatient, for the outpatient, the Riyadh, and inside patient Riyadh. The total shipment for total inside Riyadh around 20,500 and outside Riyadh around 4,138. During the quaternium, we have challenges for the pharmaceutical administration, which was accumulation of some medication of the patient, and because our priority to receive the medication to the patient at the same time without delaying the service. So there is starting the initiative as a volunteer campaign for medication delivery from our pharmacy staff. We have 4 groups, group A, B, C, D. The first group to verification and check the list of the patient that was appointment from the virtual, checking the drug history. After that, the group 2 communicate with the patient who has already have some shortage of medication, non-availability, some query of the patient. Group 4 to arrangement and preparation the prescription. Group 4 to send the shipment. Each pharmacist, they take the order and shipment of the patient inside his neighbor. Also, for this steps, they have expanded the staff during to be extra shift, evening and night. For the drive-through, we have some patients, they receive narcotic and control medication, and we didn't need to be come back or the patient come back inside the hospital for the safe of the patient. So they opened the drive-through as a total to serve the patient around 971 patient has been contacted to send by SMS a message and then come to pick up this medication. For drug shortage, they have management for the drug shortage, especially some critical items because we have suffering for limited quantity of the neuromuscular blocker sedation. So we make a direct purchase for around 96 items raised to compensate for any shortage during the pandemic period. Also design overall most evidence-based treatment guidelines. Any shortage of medication report to the Saudi FDA. About the drug utilization, modifying the standard IV dilution preparation to decrease any possible waste in those drugs, modify prescribing process to be daily and even twice daily for some critical drugs. This is the effort with our clinical pharmacists. The automatic dispense cabinet, we have hold the fingerprint of access to automated dispense cabinet in all hospitals under the to be control perception, infection control perception. For the owners in the pediatric and the maternity hospital have granted additional access to Bix's machine. Also, relocation of automatic dispense cabinet serve COVID-19 patient in the isolation ward, include additional of new items, medication in different wards. This is the disaster plan and the pharmacy, as I mentioned previously, it's focused to the medication refill and the backup, unavailable medication, patient query. In addition, every area that was expand in the ward for the ICU, we should prepare the medication floor stock, prepared and checking the situation of the rooms, is it suitable for the storage or not, and prepare the crash card, emergency medication, facilitate and accelerate the approval of floor stock addition to the wards to, from the BT committee to be within 2 days. This is the command center timelines too. At August 2019, they have recovery phase after first wave. Then we have reopened the OPD gradually inside KSMC and outside KSMC in the Iman Hospital, Al Murabba Primary Health Care, and start to be a full capacity of elective surgery in OR at September 10th, 2020. The command center timeline phase 3. This is starting because some cases for the second wave, prepared the Tower 2 to be received this COVID patient. After that, try to be continuous the activity and the OPD. Then we have opening the KSMC vaccination center. At the end of this stage, we close the vaccines center to be totally around 9,631 vaccinated employees. Our conclusion for the disaster planning for our lecture today, the most basic measures of a plan is effective in how quickly it gets an organization back to the normal operation in case of major emergency. Plans should evolve as a new lessons are planned, information is obtained, and the priority is updated. Thank you, and inshallah, everything is be okay because we have full, inshallah, around 70% of our population was immunization. For more information, you can scan our manual King Saud Medical City during COVID. Thank you.
يعطيك العافية دكتورة آمل على هذا التوك المتعلق في disaster planning. Shall we'll have room for questions after we complete the session. Now we will move to the next session with Dr. Sultan Al-Ghadir to talk about the role of pharmacists in emergency department. So my colleague Dr. Sultan, he is an associate professor at clinical pharmacy department in King Saud University. He's holding a position now as a Vice Dean of Postgraduate Study and Scientific Research, as well as a Director of Research in Prince Sultan College of Emergency Medical Supplies or Services. In addition to that, he's an active emergency clinical pharmacist and also supervising investigational drug and research center at King Saud University Medical City. So please welcome Dr. Sultan to the stage.
السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله وصحبه أجمعين. First of all, I would like to thank the organizing committee to give me this opportunity to talk about the pharmacist role in codes. During the talk in 20 minutes, I will briefly talk about the need of pharmacists in the code. Just briefly, while the most of the time I will talk about the role and the impact of pharmacists in different codes in the hospital. So there is nothing to disclose regarding this presentation. First question may come to your mind or any mind or any clinician's mind is there a need for pharmacists in codes? What are the driving factors that necessitate the presence of pharmacists in the code? There are several factors that necessitate the presence of pharmacists in the code. The first factor is the environment. If you are present in the code or any different code, if we are looked at any code, you will find the environment of code is a stressful environment with, and it's fast-paced environments with many interruptions. And there are many teams involved, and sometimes you will hear different interpretations. So this makes the environments of code is a risk for drug errors. And you see in the picture, there are many teams, and I have been in many codes, and you hear one word from here, another word from here, and you need to be focused because the chance of medical error is high if you're not focused and you're not thinking your feet. So the presence of pharmacists in this situation might decrease the medication error. The second factor that is driving the need for pharmacists in the code is the clinical support. As you know, globally and locally, we have a shortage in recruiting skilled nurses in critical care and emergency. And according to many studies published in Saudi Arabia, they mentioned that recruiting skilled nurses in critical care or emergency is a serious challenge. So if there is a pharmacist as medication expert in the code, that means you will freedom the nurse to do their work and to deal with the medications, and you will give them the need of the medication that they need during the code. The third factor and the most important factor is the medication that is administered during the code. If you have been in the code, you will see most of the medication ordered during the code are a verbal order. It's not computer-based, it's not hard copy. And most of the time for highly risk medications, and you have to be given within a specific time or in timely manner. So this put also a chance for medication error or an adverse effect. If you look to the medication use processes in patient or in ward, you will see it pass through multiple phases, starting from prescribing, transcribing, dispensing, administration, and monitoring. However, during the code, there is no transcribing or dispensing phases because they will order it verbally and they will administer it right away. So you as a pharmacist in the code, you will make sure that this medication is the right form medication, which is the phase of transcribing, and also will give all the need information they need regarding the dose, rate, and everything. And this is the dispensing phase. So by this one, you will decrease the chance of medication error. According to one study, and they indicated that medication error during the code it's 39 times more likely to harm and 51 times more likely to cause the death compared to the medication order in non-coded area. So in general, the prescription pharmacist will optimize the medication administration and selection and reduce medication error. So since the need of pharmacists is essential in the code, what are the role of pharmacists? So I'm going to talk about different codes and the role of pharmacists in each code. The codes that I'm going to talk about today is cardiac arrest or code blue, stroke code, sepsis code, call of rapid response team, and trauma code. There are other codes such as acute agitation code, rapid sequence intubation code, and other coded, but these are the most common coded. So the cold blue or cardiac arrest code, which is the most common code I know most of you or all of you know about this code. It's the most common code, and the pharmacist participation has been for many years. Because of that, there are some rules before the codes and rules during the codes. So before code blue, the pharmacist should make sure that he is or she is stocking and restocking all the code medications in the area that he knows or an area close to the coded area. Also to have all the medication ready to go on the cart or box in all coded area. You know, the onset of cardiac arrest and the provision of care is fundamental. So shortening the time is really important. So having the box or the cart in the area, it can shorten the time and prevent death or decrease complication. The third thing is to suggest all the medication that's given. And you may suggest to give or to have the medication in ready-to-use syringes or pre-mixed solutions. As I mentioned before, sometimes the environment of coded is a stressful environment, so there is a chance of miscalculating the dose. So if you have the pre-filled syringe or pre-mix, you can give it all, and this is the adult dose, and you don't put your self in the chance of miscalculating the dose. During the code, the pharmacist will locate, obtain, or necessary medication they need. They calculate the dose rate and concentration. Yes, we have sometimes the ready-made syringes, but in many times we have shortage, and we have some we have some medication different strength that we need to prepare during the code and to give advice regarding even sometimes the rate and concentration. When the patient sometimes returns to spontaneous circulation, we may need to prepare some of the infusions, such as norepinephrine, epinephrine. So we need to prepare it, give him the rate, and label it, just because there are many medication on the table to make sure this is the medication, this is for the right patients. Also to give some information about the IV compatibility. For example, sodium bicarbonate, you cannot go in line with the norepinephrine. Sometimes during the code, this information is missing. So your availability in that code can prevent some IV incompatibility. Also to make some recommendations if you know the patient and the history or you read the patient profile. According to a large national study in the United States that is conducted over the years, they found that in hospital where pharmacist is part of CPR resuscitations, they found that there are 12,880 fewer deaths if the pharmacist is part of the CPR team. However, in hospital where the pharmacist is not part of the CPR team, the occurrence of adverse drug reaction significantly increased by 2.25%. So this is telling you the importance of having the pharmacist during the code blue. Also, another study just to investigate the compliance with the ACLS guidelines during the code, they found that when the pharmacists are available with the team, there are significant higher compliance to the ACLS guidelines with 71.9% versus 42.4%. Beside the code blue, there are essential rule of pharmacists in stroke code. And I have been in stroke code, and I can telling you, the stroke code is a time-sensitive code that you have to act fast to save the patient. So because, for example, medications such as thrombolytic alteplase have to be given within the specific window, 3 hours or 4 hours, 0.5. So if you are available there, you will shorten the time with the doses, with the recommendation, and even if you can prepare it, or you can begin it from the inpatient pharmacy. So your role during the code is to assist with medication history and medication. Sometimes if the patient on or he take or she just took recent anticoagulant, the patient will be, for example, excluded from thrombolytic agent. If the patient taking anticoagulant in window between 3 hours and 4 hours 0.5, this will be included. So this information telling you which is the patient is candidate for the treatment or not. Also to review inclusion and exclusion criteria with thrombolytic agents, with the neuro team and emergency team or the team that with you. Also to give dosing of TBA dosing thrombolytic alteplase and prepare it, and sometimes to give recommendation about the administration, because this medication is a weight-based and very specific. So you need to get the actual weight to give the patient, to give that medication, because the first dose is bolus dose and second dose 10% of its bolus dose, and the others is infusion, and the maximum dose is 90 milligrams. So how to distract the amount that you don't need, how to take the 10%, and how to make the infusions after that. Also to treat the associated conditions such as hypoglycemia, hypotension. And if you have hemorrhagic stroke, which is, of course, the patient not subject for TBA, the patient will be subject for, if it's warfarin toxicity, or if it's hemorrhagic stroke secondary to warfarin toxicity, you will give anti-reversal agent. And I brought here 3 pictures of the same product or the same active ingredient. However, each one you have to deal with it in different way. For example, the last one, Kcentra, it has something called 4-factor BCC. However, when you dose it, it's different from the other tools. So the presence of the pharmacist during the code can telling you more what the doses that you need and what product that we have in the hospital to give the actual and the appropriate dosing. Also to monitor the patient, especially if the patient taking thrombolytic, and during the transition care, your role is huge, because you were recommended not to give anti-blood thinners during the 24 to 48 hours, and to give summary if you have co-liquid clinical pharmacists in the ward about what happened during the code. According to a cohort retrospective study that conducted in hospital, where the pharmacist is available during the stroke code or not available, and they assess if the pharmacist is available, is there a reduction for door to time needle or not? As I told you, the time is really essential for a stroke code. So they wanted to see if the pharmacist is available, is the door to time needle is shorter when the pharmacist is not available or not. What they found, the median time door to needle time is shorter, significantly shorter, when the pharmacist is present in the stroke code with 48 minutes versus 73 minutes when the pharmacist is not available. And the goal of door to needle, less than 60, as is established by some guidelines, are met in case of presence of pharmacists in the code was 72%, where the pharmacist is not available, it's only met in 29%. Beside the code blue stroke code, also there are a role of pharmacists in sepsis code. And as you know, sepsis is one of the conditions that you need to give specific medication and fluid in the timely manner. Sometimes within 1 hour, sometimes within 3 hours. But with the new guidelines now, if the patient with the shock and septic shock, you need to give the medication within 1 hour, fluid to resuscitate the patient with fluid within 1 hour, to give antibiotic within 1 hour. So the presence of pharmacists will help to choose the fluids and to choose the antibiotic, because sometimes you go to the patient profile and check the resistance of specific medication to see the history of microbiology and to give recommendations. Sometimes you can give double coverage, sometimes you give one double. Also you calculate sometimes the renal function and you give the appropriate dose. So the role of pharmacists in general to ensure the adequate fluid resuscitations, to determine the appropriate vasoactive. So as guideline says, it's norepinephrine. However, sometimes you may give norepinephrine plus vasopressin, and sometimes you give norepinephrine plus dopamine. This is based on the patient condition. Also determine the need for inotropic. So if you have cardiac shock, besides septic shock or cardiac shock, or septic shocks or sepsis secondary to cardiac shock, you will give, for example, butamine. So what's the need, what's the dose, how to give it, is it can be given with the other for other vasopressors or not. Also to confirm the antibiotic selection and dosing. As I mentioned, this is the big part, the pharmacist to choose the antibiotic. What's the dose, what's the agent, how to dose it, how to monitor it, how to do pharmacokinetic, and so on. Also assess the need for preventive therapy, such as DVT prophylaxis or stress or ulcer stress prophylaxis. And also to communicate with the team regarding the recommendation. According to a descriptive study over 2 years in the United States, just to describe the role of pharmacists when the patient comes to the emergency with sepsis, severe sepsis, or septic shock. They do it over 2 years, and there were around 600 consultations done by pharmacists for 130 patients. The most common consultation provided were the dose recommendation, followed by antibiotic recommendation or adding, and by the drug preparation. The most common medication classes that informed consultation was antimicrobial for around 80-85%, followed by vasopressors. The antibiotic that involved and give consultation about for pharmacists were vancomycin, aminoglycoside, glycoside, tazocine. All these medications, if you don't dose it appropriately, you might send the patient to nephrotoxicity, and even sometimes with aminoglycoside, glycoside, ototoxicity, and nephrotoxicity. Also, there is a role for pharmacists in RRT, which is Rapid Response Team. So in large hospitals, they have sometimes what they call it RRT, or Rapid Response Team. So usually this team is based in the ICU. Sometimes is led by ICU trainee or ICU fellow with ICU nurse and respiratory therapist. However, some hospitals, they added pharmacists as a part of RRT. So the focus of RRT is to give care to deteriorating patient by early recognition and prompt treatment. So by giving early recognition and giving prompt treatment, you will decrease the proof of the patient condition and decrease the risk of cardiac arrest. And RRT are not specified to cardiac arrest. It's included all toxicities such as respiratory, endocrine, and so on. So the role of pharmacists to give medication dosing, medication procurement, and preparation, because as you know, it covers many emergencies conditions. So you will have to be more trained and know the medication that they need. Also, you can assist in contributing factor by adding or removing medication in some cases. According to 1 month pilot study with pharmacists as part of RRT, they responded to 32 RRT alerts. 65.6% of patients required more than one medication intervention. Pharmacists made 49 intervention in 21 patients, and the number of medication were 45 medication. And the responsibility varies from dose recommendation, medication recommendation, and adding or removing some medications. The role of pharmacist trauma code, I will go fast because they are giving me a hint. There are 4 minutes left. So there are a big role of pharmacist on the trauma code. So trauma code, when you think about primary survey and secondary survey. So you'll go with the team, and for each step, you will think in your feet. Is the patient risk for example, or cannot maintain the airway? Is there a chance to do the rapid sequence intubation? What are the medications you will administer? So you will prepare yourself. If you check the breathing and there is risk for pneumothorax, are they going to do tubing? The patient need for analgesic, local or systemic. Also with circulation, hypotension, and so on. Also with the disability, when there is risk for traumatic brain injury, is there a need for hypertonic solution or not, and so on. So this is how to think, and this is how to add your value as a pharmacist. And because of the value of pharmacist in the trauma code, a study or survey was conducted in the United States, and they found the number of pharmacists that were included in trauma code increased from 23% in 2007 to 70% in 2017. So over 10 years, there are increased by around 50% of number of pharmacists that are participating in trauma code in trauma centers. This study was conducted in 110 trauma centers in the United States. And they responded in the survey, they said 79%, they said the involvement of pharmacists were valuable or extremely valuable. And 75% where they don't have pharmacists, they said they will consider pharmacists in the future. And the responsibility is the same with the calculated dosing, preparing medication, and providing information. So, finally, I would say that your value as a pharmacist is recognized, and the literature telling you that you have valuable role. So the professional agency give you the support and emphasize to be part of the code. For example, the American Society of Hospital Pharmacy, they publish guidelines on emergency medication, and they emphasize to participate in all resuscitative efforts, not only CPR resuscitation effort or cardiac arrest. Also, there are a position paper that is published by 3 agencies: American Society of Hospital Pharmacy, American College of Clinical Pharmacy, and Society of Critical Care Medicine, which is for physicians, the last one. It's not for pharmacists. They published 82 recommendations in 5 domains. One of the domains for patient care. And they mentioned number 14 and 15 that any pharmacist, regardless if it's emergency pharmacist or critical care pharmacist, who are certified with ACLS have to be on the Code Blue or in the ORS station, and 24 hours for a day and 7 days for a week. And to have the pharmacy should respond to all ORS station activity, not only to the CPR. Finally, I would say, as a pharmacist, that the literature telling you your valuable role, the professional agency supporting you, the practice need you, so be confident and go to the all coded and show them your valuable effort. Thank you.
Thank you for the speakers about this informative talk about the pharmacy and emergencies. So we will open the floor for questions. We have 5 minutes to ask our esteemed speakers about anything related to their talk. Until we have any question from the audience, I will start with the question for Dr. أمل. يعني بحكم أن الشميسي هو يمكن المكان اللي ولد فيه وحاليا يسمى كينج سعود ميديكال سيتي. سؤالي لما يجي على موضوع disaster planning, you mentioned a lot of things about يعني what pharmacy services can provide in terms of managing the medication. Can you please يعني inform the audience about the technicality inside the operation of pharmacy? يعني when they call for the code for the disaster, how will pharmacy manage their staff in terms of leadership, in terms of frontliner staff, in terms of technician, in terms of pharmacists, and etc. If you have ever had an experience with Shmesi or in general from your experience.
Okay. Actually, there is internal disaster for the pharmacy in our pharmacy that include all the card job and the responsibility for each person. We have also the name and the number of the patient of our staff. For the disaster planning, we have already seasonal disaster, as you know, in the sometimes the rain and the dust. We prepared also for the asthmatic disaster. So this is should be first of all, as I mentioned in the presentation, to be educate our staff about what can we do when we have start the disaster. Should be started from who? The group 1 or group B or 2, even in the morning shift or night shift. For also the medication, how you can bring from the, if not available in our hospital, from where you can also bring or make it contact with which hospital, because we have a list of medications, hospitals, pharmacies among the Riyadh to bring any shortage and covering any shortage medication. As I mentioned, planning without training of the staff, it's cannot be do nothing. Should be start with the planning, educate, and make a drill, even fire drill or disaster drill, to know and to be make it our staff to be ready in there is any disaster happened.
يعطيك العافية دكتور أمل. Do you have any question from the audience? طيب. Yes, go ahead دكتور.
Assalamu alaikum, Shtiyaq Bajnaid from King Abdullah Medical City. Actually, my questions to both of the speakers regarding the required training and education that you should provide to the pharmacists who are going to participate in either disaster planning or codes. Is there any kind of, rather than just, in spite, you know, we have the BLS and ALS, and if you have pediatric BLS, but I mean, if there is something special for the pharmacy regarding, you know, medication preparation, or is there any some kind of courses that are there for us to, for example, if I want to prepare my staff? And regarding the codes, is it only clinical pharmacists, like the critical care clinical pharmacists, who are gonna attend those codes, or we can even, you know, make other clinical pharmacists participate in these in all the wards? Thank you.
Thank you for your questions. So the first question, you have two questions. I'm not going to answer the disaster, Dr. Amar, but regarding the codes, what are the, or how can I send my staff to the code? This is the first question. The second question, is it specified to the clinical pharmacist or not? So the first question is how to pharmacists participate or have a valuable participation in the codes. The best practice is to demonstrate and to watch and to practice actually. So there is some residency programs that it's telling put the patient or put the pharmacist in spot. However, if you don't have this opportunity, you can like set a guidelines for them. For example, to attend 1, 2, 3 stroke code before you are going independently, to prepare TBA on bedsides, to do CPR or to attend CPR and to prepare medication. So I remember some organization, for example, in the United States, they set numbers and they call it KPI for each skill. So if you want to go to the specific codes that you pass, you need to pass this KPI numbers to be like independent person or independent pharmacist to participate in the code, regardless of sometimes of some training. However, the residency program sometimes specified area can summarize the way to that. This is the first part. For the second part regarding is it specified to the clinical pharmacist? No. The last slide regarding the position paper that I bought, which is from 3 societies, they didn't specify as a clinical pharmacist, but they specify to be a pharmacist. But again, goes back to the first part. You don't want to send pharmacists who are not well trained, because this will fire back on you. And this is the answer to the question.
Thank you, Dr. Sultan. I would add, يمكن Dr. Sultan, from my exposure talk with many people from different organizations, I think pharmacy involvement in codes is variable. Some institution, even large institution, they don't have any role responding to code. I believe when we invest in simulation, it is something good also to prepare the pharmacy staff to respond to the code. So there are some organizations also who have some simulation using the mannequin, to simulate scenarios related to the codes. I think this is very essential to prepare and make your staff ready to respond to the code. Yes, by attending simulation courses, not the ACLS. ACLS is mandatory, but doesn't mean if you have ACLS, you will be able to respond to the code well. But having simulation in some centers, there are some centers in Riyadh that provide simulation training for that. I think it would be very helpful. Do you have any additional question from? Yes, Dr. Amel, if you want to comment
for
about
the addition regarding for the training, it's sometimes the training should be with the multidisciplinary teams, even inside the pharmacy or outside the pharmacy, according on the situation of disaster. Also, for the training for the pharmacy staff should be make it a manual training for everything that's not even OGT or pharmacy OGT or any pharmacist, and this is training should be annually to give and provide how to be handling any problem, any disaster. And I think in your pharmacy you have a team for the training, and you can sit with him and as a leadership and give what you can make it the steps by the of the this is training. For example, evacuated disaster plan. For example, what can we do it? You can make it drill for any time to measure evening, morning, what to measure what's how we can the response of our staff and to be ready. I think the training is one of the strong basic to the response of the patient of our staff to get any covering of disaster.
الله يعطيكم العافية. في الختام يعني أتقدم بجزيل الشكر للجنة المنظمة وللمتحدثين الدكتورة أمل والدكتور سلطان. يعني تعلمنا صراحة كثير منكم واستفدنا وكانت معلومات جدا قيمة. الله يعطيكم العافية وإن شاء الله نلتقيكم قريبا بإذن الله.
والآن راح يتفضل دكتور عبد الرحمن المسعودي بتكريم المتحدثين. الدكتورة أمل باقل. الدكتور سلطان الغدير. الدكتور عبد الله الحماد. بإذن الله الآن راح ننتقل للاستراحة لمدة 10 دقائق وبعدها راح نكتمل. شكرا، يعطيكم العافية.
أسعد الله صباحكم. I will be the moderator for the third health new medication initiative. As stated in the agenda, we have different great speakers talking about excellent initiative in pharmacy practice. The first presentation will be held by Dr. Center, Ministry of Health. She graduated from King Saud University, Bachelor Degree of Pharmacy at 2005, and she graduated from King Saud University as well, Clinical Pharmacy, in 2014. Dr. Hajar, the floor is yours, Dr.
صباح الخير. Thank you for the great introduction. I'm really pleased. I'm very pleased to share with you our experience at the Ministry of Health with the new era of real-world evidence generation. And today we are going to reflect on some active registries across the MOH. So I have nothing to disclose on this topic. What we are going to reflect is what is the definition of these registries, the scope that differs from our drug disease registries from the original registries, and what is the value that we are going to get from these drug disease registries, and definitely our MOH experience. So let's just go and understand more or define what are these registries. So the registry is a platform that collects information about individual that are usually focused around a specific diagnosis or condition. And it reflects the outcomes and the quality improvement. And usually these drug registries or the registries is focused on the monitoring prevalence and incidence. So as I said, that the drug disease registry is usually and I think this mic is not working, so okay. And I'll have an overview on the effectiveness and outcomes of a new treatment, safety, efficacy, and tolerability of new medications. Thank you. And what we usually look at is the economic burden and healthcare and the utilization of the medications or even the resources in different diseases. And the reflection on our population, that is the most important thing, or the unmet needs in our data sets. So registries are, again, beneficial for various stakeholders and can help in achieving value-based healthcare, and this is what the aim in 2030 vision. So who are the stakeholders? Patients, physicians, providers, the industry as well, and the healthcare system as a whole system. And definitely this is all linked in the economic burden of these diseases. So for the patient, we make sure that the insights is being captured from the patient, give access to new medications to those patients, and we make sure that these registries will put Saudi in the landmark of clinical trials by identifying the subset of these patients, what age group are they, what stage of disease they are in, and what are different or other comorbidities that they have. For the physician, we make sure to accelerate the access of new medications, and we make sure that the clinical pathways is being met, and we standardize the practice as well. For the providers, we make sure that the allocation of the resources is being covered according to what reflection we are getting from these registries, whether the high prevalence of different regions or hospitals at that time. With the industry, we need to make sure, and we have an open mind, that it is a win-win situation for both. So for them to understand how to improve or understand the market and their portfolio positioning and the disease challenges with different health sectors, and to understand more on the unmet needs from different sites. And improve patient experience as well, and patient journey. So as a whole, for health system, we make sure that we identify or have a reflection on the utilization, on the medications being used, the resources as well, and we are going to get a reflection of these aspects or utilization of the services across the journey. Eventually, it will all fall into the economic burden. We all know that we have constraints in regards to the budget, and the medication is not coming cheap anymore. We are having a really new innovative medication that costs millions, and this is what we are going to come in a few slides. So again, what is the most important thing that we really look at when we generate these registries and get these data is we are going to identify our patients. We understand what subset of patients that we have and what are the, as I said, the age group, the comorbidities. So we go treating physician a clinical trial that assures 100% adherence. So we give this range and make sure that it is not only the medication availability or the supply of medication, but it's different services that make sure that the patient is getting the benefit of these highly expensive medications. The second case is the FH registry. Now, FH registry, we have more than 2,500 patients enrolled in this program. And this is just a dashboard on what variables we added into these registries and what are the needed reports. We had more than 80 plus trainers, 61 active users. We had 30 training sessions across the last year. The most important thing from this registry is to make sure that there is an adherence of the clinical guidelines we had, make sure to standardize the practice as well. So from these preliminary results will show you that about 23% are approved or are candidate for this medication, while we still have 14% were getting this medication and they are not really candidate of, and this was prior the launch of this registry, and we are now going with the different evaluation of these patients. And the third one is the psoriasis. This is a new one. We just launched it last month, and since the population is much lower than different drug diseases, so we reached about 200 plus patients now, and this is one of a kind because we have two lines of medication, the first line and second line, and there is different evaluation and different time points of these evaluations. So I cannot speak more on the amount of work is being given for these registries and the follow-up and the meetings, and we are like 24/7 with the team, having our phones open with all the communication from the treating physicians, from the clusters, from the hospitals, from everyone, from the pharmacy, just to make sure that this information or these communications being met. We also have weekly newsletters that is being received for all hospitals to understand what is the status of the registry, the enrollment rate, and the percentage or the KPIs for each region. And eventually, these registries or these reports would reflect on the P&T committee while we revise. So we go into the clinical effectiveness and safety, and we review the published evidence, but we go back now to our registries to understand what is the prevalence of this disease, the incidence of these diseases, and what are the set of these patients that we can cover, or we know that this medication will give benefit for these patients, rather than just adding the medications for all the patients with this diagnosis, knowing that what will reflect, eventually we have only one budget, so whenever we added one, definitely we cannot add the other, or we are going to delete other medications. So by that, we can assure an access of different medications with selection of the right population. By this, I end my talk. Thank you so much.
Thank you, Dr. Hajar, for your great presentation. The second presentation will be by Dr. Amr Khardali. The presentation will be non-formulary medication in Kingdom of Saudi Arabia. Dr. Amr Khardali is Drug Policy and Regulation Deputyship of Therapeutic Affairs, Ministry of Health. He is graduated from School of Pharmacy, King Khalid University, 2010. And he had a master's degree in clinical pharmacy from Al Qasim University, and he has a certificate of health economics and outcome research from University of Washington at 2021. Dr. Amr, the floor is yours.
Thank you, Dr. Amir, for this introduction. Thank you, Dr. Hajar, for your presentation, and thank you for IHOP for your inviting me and having me here in this conference. have no conflict of interest in regard to this presentation. My objectives will be introduction and Ministry of Health experience in non-formulary medication. Then I will talk about the updated or recently updated process for non-formulary medication. All of you know the ASHB definition for formulary as a continually updated list of medications and related information representing the clinical review of experts in the management of disease and promotion the health. Formularies have evolved in its interest from a simple drug list to a complex, updated and live databases with a guidelines. It's become an essential tool for healthcare payers to enhance the patient safety and ensuring the evidence-based practice to improve the outcome and ensure the proper application or implementation of the guidelines. Since medication consists a large containment of the healthcare sector budget, especially the governmental healthcare sectors or public healthcare systems, like what we have here in Saudi by Ministry of Health and other healthcare providers, the medication constitutes a very large and pose a huge challenge on the budget. For non-formulary medications, I think all of his sectors in Saudi Arabia defined it as or having their own system for reviewing the non-formulary medication, which almost same in all sectors. We have a special request. Some institution call it non-formulary request, where other they call it Form A or Form B, and some institution called patient special request. Many studies have demonstrated a highly association between the formulary restriction or prior authorization and the National Drug Regulatory formulary strategy and the ensuring the healthcare resource utilization. And many countries as well, several countries implement a different strategy and level of restriction at all the levels of decision makers to assess the policymakers in taking their decisions. I represent the Ministry of Health experience. Ministry of Health in Saudi is the major national healthcare providers, almost 60% of healthcare services, with more than 2,300 primary healthcare centers and almost 300 hospitals with a total capacity exceeded 43,000 beds. It's keeping its services abreast with the increasing in the demand by accelerating multiple specialized training programs for physicians, for pharmacists, and for nurses, and for all other specialties, launching centers of excellence for oncology. Patient unfortunately. Affairs with a fully and detailed clinical review conducted by a clinical pharmacist, by a physician, and according to standardized process governed by Central BNT Committee in Ministry of Health. At that time, started by circulars for having the non-formulary and the process of requesting the non-formulary and direct purchase medications. And then it was an electronic circular Minister of Health for the regulation of non-formulary medication. At that time, the requests were done through handwritten or the pre-printed form. We are pharmacists and all having challenges with the hand-prescribed or handwritten prescriptions. The same thing we face with the non-formulary request, especially when we're reviewing the request. We doesn't have a clear clinical explanation or the diagnosis or the justification behind requesting the non-formulary medication. After that, we moved to a pre-printed and editable PDF file to go over that issue with handwritten prescriptions. Then we do an assessment for our new national process to assess whether we are going on the right way or we have to improve or to stop even that process. Our objectives for that assessment were to explore the approval rate, turnaround times for submission and decision, and the justifications behind the disapproval of non-formulary request, and finally calculating the potential cost savings it could be offered by the national review process. We follow this methodology. It was a retrospective, cross-sectional, and observational study. We conducted through a SAHL system, and for Minister of Health, they are familiar with SAHL, and for who's non-MOH, SAHL system as electronic administrative communication system between the regions and the ministries and overall the country. We include all non-formulary requests received from hospitals and primary health care centers starting by January 1st in 2018 to the end of 2020. We excluded requests came from 5 institutions: King Fahd Medical City, King Khalid Eye Specialist Hospital, and King Abdullah Medical City Mecca, and King Fahd Specialized Hospital Dammam, as those hospitals have their own budget and their own policy for reviewing non-formulary medication, so they considered as they excluded from our review. For the source of data, we get the requesting hospital, the department, and the section, in addition to Regional Health Directorate. For the dates, we have 3 dates collected: the submission date, and we define it the first issuing date on the SAHL system, whether it's from pharmacy department or from the hospital. And for receiving date, it's the time or the date of official receiving the form by the reviewing committee and the completed form. If the form came and there is some missed data at the beginning, we return it to the hospital, and we didn't consider it as a receiving date. And the response date, we take the date of official response came from MOH to the Regional Health Directorate with the decision whether approved or disapproved, and in case of disapproved, we mention the justifications behind the disapproval. For the medication, we collect medication name and indications, strengths, and doses requested. For the quantities, we calculate it based on the course cycle for some medications given or as a cycles, and for the annual quantity for medication given for a chronic use. We take in consideration the diagnosis and the indication. For the cost, we calculate it based on the lowest available prices on NIPCO marketplace. Then, if we didn't find it in NIPCO, we follow the Saudi FDA registry. Saudi FDA registered and market on the local market respectively. Then we end up with this diagram. We have 2,591 submitted requests. 203 were excluded due to 59 and 35 were either before or after the time frame of the study. 39 requests were excluded due to the lack of dates record. 38 was excluded as there was off-label use for its request for off-label, but is submitted through the non-formulary request. 7 requests were redirected to the high expensive medication subcommittee, like Spinraza. And 25 requests were for formulary medication and requested as a non-formulary. So 2,388 requests were involved in the review. The term of results, we have 2,388 requests for 126 different medication. the approval rate was 74% versus 26% as non-approval, knowing that in the first 6 months of implementing this process, the disapproval rate was 47%. So with time, we improve in the percentage of approval rate. For the submission turnaround time, it was the median of submission was 7 working days with interquartile range of 4 to 17 days. In the term of a decision turnaround time, it was shorter by 6 days, one day, and the interquartile range was more closer than the submission. We also do a sub-analysis for the decision based on the type of response, and we find that for approved response was shorter than the disapproved response, and that explained by further communication usually needed before rejecting the request. We have some communication with the pharmacy department or with a treating physician to ensure the decision of the committee before sending the response. And here the distribution of the total request versus the approval rate for the specialties. And as we know, as we see here, the oncology and hematology is the highest specialty in request. Taking in consideration the hematology, we consider here the benign and the malignant hematology. Then neurology, pulmonology, dermatology come later with the same number of requests. Different requests come from all over the countries. Jeddah and Mecca represented the highest two regions by submitting more than 44.4% of the non-formulary requests, while Taif has the lowest number of requests over the 3 years. We recognize that 20% of the healthcare of regional healthcare directorates have 0 non-formulary requests submitted. Those was Bisha, Hafr al-Batin, Hail, and Northern Border. The reasons behind the disapproval of non-formulary requests, we modified it to one of those 5 reasons: the formulary alternative availability. So the physician sent a request for non-formulary medication while we still have other formulary alternative, or needed for further information or further clinical information regarding the labs, regarding the diagnosis, and etc. And incomplete patient information, we defined that for the eligibility criteria, patient is not eligible, and missing in some patient data not related to the clinical situation. Some requests were disapproved due to it wasn't according to the therapeutic guidelines, and the request is not following the requested medication. It wasn't appropriate for the special case as per mentioned report, or not registered, or the medication requested is not registered by Saudi of the FDA. Taken in consideration at that time, we wasn't reject any medication due to just for it's not registered in Saudi. So the last reason is not no one request rejected for a solo as a medication is not registered. And we found that 83% of the disapproved requests were requests for only one reason, and 16% disapproved for 2 reasons, while we have only 1% for a request disapproved for 3 reasons. And here is just the reasons and distribution. I will not go through. I just have one question for the potential cost savings. Anyone can give just a rough number for the potential cost savings behind the reviewing of non-formulary requests? Any number? كم تتوقعون السيفنجز كانت معنا من الريفيوينج للنون فورمولاري؟ No numbers. طيب. We have 55.6 million Saudi riyal potential cost savings by reviewing the national review of the medication, with an average of 1.5 million Saudi riyal. Dr. Khalid, they didn't give us even one. Okay. 20% of the savings came by only 10 medications. They was representing 29.1 million Saudi riyal. The result of this study give us some insights for further investigation and further study for the updated process. The reasons for disapproval, the request were 2/3 of disapproved requests was whether further clinical information needed or the availability of other formulary alternatives. And with Ministry of Health during those 3 years from 2018 to 2020, the direct purchase budget was almost 1,943,000,000 Saudi riyal for whether medications and non-medications. The potential cost savings by the national review of non-formulary medication was countered to about 6% with a safe cost reduction. We faced some challenges. The financial transaction, it wasn't done through Sahel system, it done through a separate system. We doesn't have any idea regarding the issuing of the BO or the acquisition date. So our end user patient, when he or when she received the medication, and we calculated only the direct cost for the medication. We didn't include other medical and non-medical direct and non-direct costs. We came up with some recommendation to having an electronic system that's mandate all field of non-formulary requests to be filled by the treating physician, decrease the steps of non-formulary request steps, and accelerating the reviewing process, and integrating the requesting system or HIS system with the ERB system in the Ministry of Health. After that, we try to implement that recommendation at 2020, but unfortunately, due to the COVID crisis, we postponed that project to 2021, and we start at Q1 in 2021 by this updated process. We update first our policy for requesting a non-formulary medication, then a circular by Deputy for Therapeutic Affairs was issued and sent to regions. Then the Assistant Deputy for Therapeutic Affairs sent a follow-up circulars, whether for a regional health directorate or for cluster health clusters. And we start electronization our request through the MyMOH platform, and we do it in a survey base which mandate all the fields to be filled by treating physician before submitting the request, and we do several rounds of workshops and virtual training. I do some analysis or preliminary data analysis. We have a reduction in submission turnaround time. We already we reach 4 working days, and we're looking, inshallah, for more to get the time frame, which is 3 working days. Our plan to standardize the process, and we did it, alhamdulillah. Before, when I was tracking the non-formulary request, يعني حرفيا كنت أشوف المعاملة مرت على كل مكاتب التموين الطبي. And those administration was not involved in the process of non-formulary request. Once it's submitted, colleague there and say what their challenges, what they are facing in challenges, and to improve it. In conclusion, ensure the evidence-based practice they are won by this process. The cost savings was noticeable, and the turnaround time was encouraging achievement. Even we still looking for more improvement in the requesting of non-formulary. It was about to have a process to acquiring non-formulary and continually evaluation and improvement. Thank you.
Thank Thank you, Dr. Hajar. Thank you, Dr. Amar, for your informative presentation. Thank you for highlighting these important topics in pharmacy practice. And now the opportunity for the speakers. If you have any questions, any comments, you are more than welcome to ask.
Assalamu alaikum. Thank you for this extensive review. Actually, the process of non-formulary in Saudi Arabia is different than the international definition of non-formulary. As we know, and it's especially unique process since we have public procurement and we have Saudi FDA and we have NIPCO and we have so many platforms that are involved in the decision making of bringing or procuring non-formulary. So I'm from King Abdullah Medical City, so it's a medical city. It's different, has different rule or different processes. But I think we shared similar concepts and similar challenges. So my question is about you, Dr. Amri. You presented the non-formulary turnaround for the process of just approval from maybe pharmaceutical services or administration point of view. But what I'm looking for more is when the patient get the medication and did that affected his life after that? Did we have registries, drug registries for non-formulary when the patient received, and how was the adherence? For example, especially in patients who have chronic illnesses. So they will take, or for example, even maintenance therapy for oncology. So the patient will have a medication for 6 months, for example, non-formulary drug for 6 months, and then the renewal process will take even similar process, similar time, maybe delay. So is there an effort to make connection between non-formulary medication and the therapeutic outcome, whether it's drug registries or because I'm struggling in my institution to make some kind of stance with the physician to tell them that we cannot order that medication because the process itself, it's gonna make it useless for us.
Thank you, Dr. Ishtiaq, for this question. Actually, we do that. In our updated process implemented in Q1 in 2021, we connected through the ERP system, or we call it Mawarid, to connect the financial transactions. And we have the budget department in our request process. Yes, we start to get the date of acquisition or the PO issuing. Later on, we have a plan to expand in this service. I think Dr. Hajar can elaborate more, to engage the time of patient receiving their medication. Our target is the patient. There's no that much benefit if we have a shorter submission time and shorter decision time while patient receives medication as before. So yes, we start doing that. We take this step. But for the further steps, I think Dr. Hajar can elaborate.
Thank you, Dr. Amr. Now, we have one task, or let's say one exercise that we are going now. Currently, we are working with the oncology subcommittee to review all the previous last year or the 2 years back requests of non-formulary medication. We wanted to understand the impact of having this medication, whether the patient really get the benefit of this, what is the time that the patient really received this in the hospital itself. So this is all will really reflect on the importance of accelerating, or at least give us a back view reflection or the impact of this process into the patient life, quality of life. So we understand more on what is the benefits. So this is currently is working with the oncology subcommittee, and we are now exploring another ways that would really get us, not only oncology, I mean the whole process. Did the patient really get the outcomes needed from this medication? For the obesity medication, let's say, for example. So we need to understand, we know we don't have these units yet up and running. So these medications need for us to know that the patient really reduced his weight. Okay, for how long and when did he reduce and what is the follow-up? So this is all will have, let's say, a different view from the pharmacy perspective in order to really for the, let's say, for the refill of these medications. So this is one point of touch points that we are going to see, inshallah, in the coming future, very soon, inshallah. Thank you for the question.
Any other additional question?
Bismillah ar-Rahman ar-Rahim. Thank you for this informative lectures. Crowd from King Abdullah Medical City. Being the former head of oncology pharmacy department, I came across many challenges regarding the time frame for providing the medications. On the other side, I am also a Sibahi surveyor. I visited around 20 hospitals from MOH. None of these hospitals have a standardized process for the approval and time frame for providing the medications. What is your plan to do this? My point is the classification of providing the medication regarding emergency and emergent medications, time frame for providing it from inside the region or the cluster or outside the kingdom. Do you have time frame for these processes? And unifying the procedure for approving the medication for exactly. Thank you.
Thank you, Doctor. For the time frame, yes, we have 3 working days for submission and 3 working days for the decision. For the acquisition, actually, we can't ensure because it's different from medication to medication, whether it's available, whether it's registered in Saudi or not, whether it's available in the stocks of the company or not. There is other procurement and supply chain issues. We can't put a fixed time even from our side, but I don't know if our colleague in the supply chain, they can ensure that. And for the life-saving or emergency medications, I faced this question several times. Also, our colleague, they communicate me, we have this life-saving medication, and it's emergency, we need the urgent approval. I'll say if it's a life-saving, we know it will not be offered within 7 days. So why you didn't submit a request for added to our formulary?
Correct.
So we received this comment, it's a life-saving medication, why we have 0 request to add it to our formulary? Send a request for adding to the formulary and let the committee review it. If it's a really life-saving medication and emergency, let's have it in our formulary. Why you are waiting to tell the approval, to submission and approval and procurement process? Thank you, Doctor.
Other questions? I have a question for Dr. Hajar. Dr. Hajar, as you mentioned, you have started the registry in 2019.
Yes.
And mashallah, you accomplished like 10 registries.
Correct.
My question, are these registries national registries or
Sure.
all of these registries?
Okay, so we do have 2 of them are national. The SMA is national program and the MS is national. So these 2 registries are national. We usually tend to have it, the MS, multiple sclerosis, was intentionally for MOH, but we get the requests from different institutions that they want to be a part of this. So we are more than welcome to expand it. Actually, we did the build-up of these registries when we adopted or finalized the guidelines, the national guidelines. So we make sure that the reflection of all the required information is being met according to the national guidelines. So these 2 are national. The others is for MOH, because what we wanted to get from these disease registries, so it's not epidemiological registries, rather it is to check and monitor the outcomes of these medications on our subset of patients. So we are getting the outcomes of introduction or introduced of these new innovative medication into the formulary and how they are translated in a way to monitor their outcomes, to monitor on the patient side, and the quality of life as well.
Thank you.
Thank you.
10 registries in 2
10
years
registries,
is
yes.
very challenging, I guess. No,
I
it
know.
wasn't easy task. Can you highlight what is the most challenges you have faced?
So, most challenges, it's very, I mean, everyone has, whenever we have a new system, the communication with the hospitals, with the training physicians, they might not understand why we are doing this, because they are adding into these registries and then they are requesting from their system, they are duplicating somehow in the entrance. But this is being managed because we have our IT team as well, and we are trying to integrate these registries with our HIS systems. But this is the main, the main point that I know that they are very busy. And for us, we are only like 5 team members that we're trying to cover here and there and communicate with it's not only hospital, but rather it's regions and directorates and clusters. So you have different layers of communications. This what really take let's say the hardest point. After this communication being cleared and viewed, it's only the process of having the training sessions and identifying the treating sites, identifying the case coordinators. So from my view, selecting the right case coordinators for the sites is the most important part of making sure that these registries is being well controlled and well managed.
Thank you so much.
Thank you.
I have a question for Dr. Amar. Do you recommend periodically review the list of non-formulary requests institutionally or?
Yes, I do. And we do that in Ministry of Health. Now the Central Beta Committee, they ask a frequent or continual report in terms of non-formulary requests. When they are reviewing any addition or deletion, they asking that. It's become an integral part of the reviewing the medication in the Central Beta Committee. So that's good help. But I want also to deliver this message. Frequent requesting doesn't mean including in the formulary.
Thank you so much. Thank you, Dr. Hajar. Thank you, Dr. Amar, for your informative presentation.
والآن راح تتفضل دكتورة آلاء مطلق بتكريم المتحدثين. الدكتورة هاجر المديحة. الدكتور عمر خردلي. الدكتورة إيمان الغامدي. And now, let me welcome Professor Abdelmajid Al-Ajlan from Novartis Company to talk about ahead of a new era in atopic dermatitis management.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I think I am from AbbVie company, not from Novartis. So it doesn't matter actually. We're gonna to speak about a topic regarding the dermatology skin disease called atopic dermatitis. First of all, I would like to thank the organizing committee and the scientific committee for inviting me to speak in front of you. I'm going to speak just briefly over like 15 minutes, not more inshallah. I'm going to talk about a burden and management theme of atopic dermatitis. So this is just, I want to show you what atopic dermatitis means. It is one of the skin disease. Yes.
أعتذر للتصحيح الدكتور من شركة أبفي الدوائية. شكرا لكم.
حياك الله. Thank you very much. Anyway, the more important is we're going to talk about this disease, which is atopic dermatitis. As you can see here, the patient really suffer from this disease. However, when compared to other disease, probably people that will see it more in other disease, but in atopic dermatitis, patients suffer big time. And we can see here, it can affect the face, affect the body surface, body areas, mainly flexures, but any part of our skin can be affected. So the big burden in those patients is the itch. It's not necessarily what we can see by our eyes, but how much they itch. So if we go to the prevalence of the disease, how many of our population suffer from this disease, whether mild, moderate, or severe? In children, I don't know, do we have a pointer? I don't know if we have a pointer here. Yeah, okay. Okay, this is the, okay. We can see here, in children, up to 20% of them, they might have the disease, which is a really huge number of our kids. They might have this disease. In adult, different between racial groups, but between 2 to 10% of adults, they do have this disease, which is very common. And with time, studies showed that there is an increment incidence of the disease over time, like compared to the previous decades. So it's a common disease that really affects a good number of our population. 1/3 of the patient, they have a moderate to severe disease. That means they suffer big time. Let's say the mild disease probably can be controlled by topical therapy, but there's a good number of patients complaining of a severe disease. This is the same thing we just talked about, which is the increment in the burden of the prevalence of the disease, and also age-related incidence. There's an increase in the incidence of the disease in children and also in adults, as you can see here. Like there's an onset. The onset of the disease mainly in the children, but there's 25% might started only at adult age. This is one of the important slides which shows you how big the burden of the disease, although the itch, which is the more signifying symptoms in those patients, still there's a lot of things happen as a consequence of this disease. When the patients start to itch and start to suffer, plus the rash, there will be consequences on the patient hospitalized. This will be patient disturbance of sleep, patient depression. Like I have a patient, which is probably a week ago, when she told me, "Doctor, although you can't understand how big this disease affects me, I refrain from marriage. I will not marry till this has been cleared from my skin. Although when I see it, it's not so bad." But she said, "I'm itching all the time. As someone told me, you have scabies, jarab. So I will not get to that very important social events or social tasks till I get rid of that. So depression is a major factor, health consequences on those patients. Again, there's not only that will affect the health care. When those patients get hospitalized or leave the work, there will be an effect on the overall economic of the country, because there will be a burden on the healthcare cost to treating these consequences with hospitalization or depression or other consequences. There's a lot of things will affect it: work productivity, reduced sport, and that will affect again the health of that patient. So if I show you this picture, this is not atopic dermatitis, it's one of my patients who suffer from psoriasis. Everyone in this room will just be compassionate with the patient, because there's severe skin disease that we can see. And if I show you how they get improved after that treatment, everyone will say this medicine is great because it helps that patient. But when it comes to atopic dermatitis, doctors even will not appreciate, because they don't see much of these skin manifestation, but patients still suffer. As you can see here, if this graph, to make it easy, patient itch, the itch of the patients, 80%, 85%, or 87%, they said it is a lot. It is a lot of itch, a lot of complaint. The blue bar means the percentage of that symptoms affecting the patient. And if you go over all these symptoms, you'll find those patients really suffer, but probably some doctors, they could not appreciate, or other health stakeholders probably did not appreciate how much those patients suffer. Again, those patients in the mild disease, they might just go for topical steroids. If not responding, phototherapy. If not, we'll go to the systemic therapy, like cyclosporine, one of the medicine that's very effective. However, we cannot continue for a long time because affection of the kidney. So we are limited of the time. Methotrexate, the same thing of the liver. If we go to the steroids, probably all of you know that. At the end of the day, in atopic dermatitis, till recently, the last 5 years, or let's say probably 6 years or 7 years, we don't have much of systemic therapy to help those patients. As I told you, probably we talk about these topicals where they're not effective in many of our patients. Then we go for phototherapy, where it's very difficult for patient to come to the hospital, and it's not so effective and has some side effects because of the color of the patient and tanning. So there's a lot of limitation. And this is an important slide. See, this slide told us how many of our patients receive systemic therapy. Only 8% in moderate disease and 7% in severe disease, they receive systemic therapy. You know why? Because doctors probably could not appreciate those patients are suffering. So, and probably there's no much of safe medicine that can fulfill the safety and efficacy profile. And this just to tell you the complexity of this disease. It just worked through many of these cytokines, from interleukin 4 till interleukin 31 and interleukin 20 and interferon gamma. So these cytokines work through one or two receptors, or to one pathway, which is a JAK1 and JAK3 and JAK2 pathway. All of these cytokines go through one or two or three pathways. Actually, it is mainly Chinese kinase pathway to induce the pro-inflammatory of that disease. So before we have a medicine which is effective, which is the biological therapy, which is the dupilumab, working through interleukin 4 antagonizing the interleukin 4, which is bring a good results. And nowadays we have a medicine which is a small molecule, which is not biological therapy, working through the more important also pathway, which is JAK inhibitors. So if we can see here, these JAK inhibitors pathways has been worked through many scientific research, and they could find different medicine blocking the Chinese kinase pathway. One of them is this medication, which is abatacitinib, which is blocking JAK1 and 2. And as you can see from this study, there's the population in this study, which is patient with systemic, this is atopic dermatitis, needs systemic therapy. So if you can see, there's a good number of patients has been involved in this study and has been compared to placebo medications. And we have, in this study, have been utilized different dosages, 15 and 30 milligram, and the endpoint is clearance of the disease by 75% or 90%, which was not available before these medications. Our target before only 50% response, but nowadays we could help those patients up to 75% to 90% response. And if we can see in this diagram, again, I wish that we have these, we have the mark. I can see it in the screen. Anyway, so if what we can see here, it does not appear. It doesn't appear on this, so I can just explain it for them. Okay, that's great, yes. Yeah, that's good. If we can see here, this medication, this is the placebo, the gray bar, while the blue bar, the light blue and dark blue, where it says the abatacitinib with 15 or 30 milligram. It's clearly through all these studies, as you can see, that there's a great benefit, of this medication on this disease, up to 70% and also 90% clearance of the disease, and also through the validated, investigated global assessment. All of these parameters has been improved on those patients after receiving this medication. The same thing here is how to tell you how they improve. And the more important here is the induction of the benefit. Can you see within 1 or 2 days, patients start to respond, which is great on those patients. The trust in the drug can be easily built within the patients. Like within few days, patients can see the effects, and over the time there's a sustainability of the medication efficacy compared to the placebo. Again, the same thing with clearance of 90% of the disease. The same thing, actually it can be easily appreciated here. Again, the pruritus, the same thing. There's a great improvement, and the induction of stoppage of the pruritus is so fast. Again, see, this is just concentrating on the induction of response in day 2 and 3. And this is great, and this is marvelous in medicine and in dermatology to get that result as fast as these few days. And within week 16, most of the patients get the target response. The same thing, patients can stop steroids. This is this interrupted line. This means when patient will stop the topical steroids, as we can see here, it can stop it within like 2 months or 3 months after starting this medication. That means he can refrain from using topical steroids. If we can see here these adverse effects, we can see there's a minor serious adverse effect when you compare it to the placebo. As you can hear, the placebo compared to the medicine is almost the same. That means the safety profile of this medication is too high, and there's no serious adverse effect. If we go to the common side effects here, we can see the acne is one of the most common side effects among the treatments, these new JAK inhibitor treatments, and also mild infection. But there's no serious adverse effects. Again here, just to tell you that these two dosage, which is 15 and 30 milligram, they reach the same almost target with the prolongation of the therapy. However, the induction might be better with the higher dosage, but overall we don't need that fast induction because it's only a few days difference. So again, the same thing, they are within EZ90, they are better, they are reaching almost the same efficacy over 52 weeks. That means there's a persistent of the efficacy on these medication. Again, the same thing, actually, we are just talking about the improvement of pruritus it tells you all the symptoms of that disease improve. This is just repetition of the adverse effect. Again, there's no serious adverse effect when compared to placebo effect. There's a similar or more of acne in those patients compared to the placebo. There's a little bit more of upper respiratory tract infection. However, that's improved with time when you see the second slides. So there's no adverse effect. This is, we just compare abatacetinib with the previous systemic biological therapy for atopic dermatitis. And we can see, just to make things short, the abatacetinib, when compared to the dupilumab, which is a biological therapy attacking the interleukin-4, still we can see the new molecules probably bring better results and shorter time for onset of efficacy when compared to dupilumab. Anyway, these two medications are so effective and beneficial, with the benefit of the new molecule. It gives faster effects and probably significantly more clearance of the disease when you compare to 75 or even 90, EZ90. That means it is more percentage of patients will respond to the new molecule compared to the previous therapy. At the end of the day, they are excellent medication. They are helping those patients in a big time. Again, the first effect is almost similar between these two medications. Here, probably is one of the last slides, just to tell you, among all these JAK inhibitor systemic therapy for atopic dermatitis, we can see abatacetinib probably bring better result than others, but also these paracetinib also bring a good results, which is these paracetinib. All of these medication are JAK inhibitors. Tells us that these medication works, or this disease using these pathways to affect the patients. And once we block these JAK inhibitors, genus kinase pathway, we could get a good effect. However, with abatacetinib, probably at this point of time, is better than all of these JAK inhibitors medication. Anyway, the message here, these pathway is an important pathway to create that medications. Again, the same thing with EZ90, that's these medication bring best result compared to the previous treatments. The same thing that these medication, which are JAK inhibitors, including abatacetinib and paracetinib, that these medication bring excellent results for those patients. Thank you very much. I think we just finished at this point of time. Thank you.
Thank you, Dr. Abdul Majid, for your informative presentation. And now we would like to present Dr. Manal Bashha presentation from Bayer Company, which is about unmet needs in chronic kidney disease and type 2 diabetes.
Assalamu alaikum wa rahmatullah. I would like to thank the organizing committee of IHOP for having me today here. Our talk today will be about the unmet needs in chronic kidney disease and type 2 diabetes. For the content and the objectives of the presentation, we will talk about the burden of the chronic kidney disease in type 2 diabetic population with early diagnosis, moving to the pathophysiology of CKD in type 2 diabetes, and briefly, we will discuss the clinical guidelines, recommendations, and we will end up by the new data on the chronic kidney disease and disease progression in diabetic kidney disease. For the global overall burden of type 2 diabetes in patient with CKD, there is a globally high increase in the number of patients who developed chronic kidney disease in type 2 diabetes. And almost as you can see here, type 2 diabetes accounts for almost 90% of all over global burden of diabetes by 2019. and almost with an estimated 160 million adults living with diabetes and type 2 diabetes, which is account almost 2 in every 5 patients diagnosed with type 2 diabetes to have a CKD. For the risk and cardiovascular mortality in patients who develop CKD and type 2 diabetes, as you can see here, the cardiovascular mortality in diabetic patient with CKD almost 6-fold when we compare them with the kidney disease patient and diabetes alone. For the diagnosis of chronic kidney disease in type 2 diabetes, the chronic kidney disease defined by structural or functional abnormalities in the kidneys, which will present over 3 months with a persistence of albuminuria manifested by albumin creatinine ratio of more than or equal to 30 milligram per gram. This readings has to be persistent over 3 to 6 months with at least 2 to 3 readings, and or the evidence of reduced kidney function by estimated GFR below 60 ml per minute per meter square, and this should be in absence of signs and symptoms of other factors that might cause renal failure. For the annual screenings, although all the clinical guidelines recommend both screening for albumin creatinine ratio and estimated GFR using validated formula in patients with type 2 diabetes and CKD at least annually, there is still a global suboptimal utilization of this screening worldwide. We can take USA as an example. Almost more than half of the patients found to be unscreened either for both GFR or albumin creatinine ratio with type 2 diabetes. And this will impact the overall management of the disease and will involve in the overall progression of the disease to renal failure. For the drivers of CKD progression, as you can see here, we have mainly 3 main drivers which will play an important role in the patient with type 2 diabetes and CKD progression. There is a hemodynamic, metabolic, and inflammation and fibrosis. All of them, hemodynamic, metabolic, and inflammation and fibrosis, will play an important role in the development of structural abnormalities in the kidney, development of glomerulosclerosis, kidney fibrosis, which eventually will lead to CKD progression and renal failure. Moving to the clinical practice guidelines, both ADA and KDIGO updated guidelines, they recommend the use of antiproteinuric, antihypertensive medications and new classes of antiproteinuric, antihyperglycemic medications, SGLT2 inhibitors and GLP-1 receptor agonists for patients with type 2 diabetes and CKD. The recommendation for hypertensive patients with type 2 diabetes to start the ACE and ARBs whenever there is evidence of albuminuria and GFR below 60 ml chronicity of a kidney disease. While for the SGLT2 inhibitors and GLP-1, they prove to have antiproteinuric, antihyperglycemic evidence. So it is indicated for all patients with GFR more than or equal to 30 ml per minute. It's very effective, and in such populations with albumin creatinine ratio of more than 300 milligram per gram. Back to the drivers of renal failure in patients with diabetic kidney disease and type 2 diabetes. The drivers of CKD here for the hemodynamic and metabolics usually covered with the ACE and ARBs and all newly approved medications. So, and although with this advancement in the management of metabolic and hemodynamic drivers for chronic kidney disease, there are still a lot of patients with type 2 diabetes and chronic kidney disease found to progress to renal failure because of this missing link in covering the third drivers for inflammation and fibrosis. So they found that the overactivation of mineralocorticoid receptors has an impact and important role in prevention of inflammation and fibrosis. As you know, that diabetes, continuous hyperglycemia, and overactivation of this RAS system will stimulate the mineralocorticoid receptor, and this overstimulation and activation by the ligands of aldosterone, cortisol, and other RAS activation will have an impact the inflammation and fibrosis, and it will impact also the renal outcomes and progression to end-stage renal disease. So by blocking this mineralocorticoids overactivation, it may prevent the adverse renal and cardiovascular outcomes mediated through this inflammation and fibrosis. And up to date, we don't have any medication yet covering these drivers. Moving to therapeutic options for chronic kidney disease and type 2 diabetes. This is, for the same drivers, hemodynamic and metabolic, with absence of any medication that will cover the inflammation and fibrosis. So still we will have patients who will progress to end-stage renal disease in spite of this maximum control of hemodynamics and metabolic pathway. So for the current treatment approach targeting hemodynamic and metabolic pathways for patients with type 2 diabetes and CKD, and because of the continuous increment in the morbidity and mortality because of this diabetes burden, and up to date, the maximum management and up to date for this diabetic kidney disease renal patient has been through the blockage of renal aldosterone system. For the renal trial, the use of the losartan versus placebo providing a renal protective properties, but as you can see here, there is a residual risk for the progression of patients to end-stage renal disease. And in 2019, the canagliflozin rule in type 2 diabetes and CKD was demonstrated through the CREDENCE trial. And again, the CREDENCE trial demonstrated that medication or SGLT2 inhibitors was providing a kidney protection, but still again, there is a patient with residual risk to progress to end-stage renal disease and also for increment of cardiovascular mortality as well. So to talk about the inflammation and fibrosis drivers in patients with CKD and type 2 diabetes, first agent demonstrated in phase 3 program called finerenone. This finerenone is a selective non-steroidal mineralocorticoid receptor antagonist. It got the approval of US FDA in July 2021, but not yet approved in Saudi Arabia. There is 2 sister clinical trials which demonstrated the efficacy and safety of finerenone as a mineralocorticoid receptor antagonist in providing a cardiorenal protection in patients with type 2 diabetes and CKD. It's a large-scale clinical trials, over 13,000 participants, worldwide international trial, randomized double-blind, placebo-controlled clinical trial. This finerenone phase 3 programs, as I mentioned, has 2 clinical trials, Fidelio, DKD, which is mainly renal outcomes and renal protection. The primary endpoints was a composite or time to onset of a renal failure, sustained decrease in the GFR of more than or equal 40% from the baseline, and renal death. However, for the secondary endpoints, it was looking for the cardiovascular outcomes, and the opposite to Fidelio is Figaro trial. The primary or the composite endpoint was looking for the cardiovascular finerenone use, which is opposite to Fidelio, and the secondary endpoint was the same as the primary endpoints for Fidelio. For the inclusion criteria of Fidelio DKD, adult patient with the age of more than or equal to 18 years old with CKD and type 2 diabetes, pre-treated with the maximum RAS blocking system at maximum tolerated doses, serum potassium less than 4.8 or equal, and those excluded from the trial of Fidelio, the non-diabetic kidney disease population, those with symptomatic heart failure with reduced ejection fraction and uncontrolled hypertension and hyperglycemia. For the primary endpoints of Fidelio DKD trial, as I mentioned before, it's the composite time to first occurrence of a kidney failure, sustained decrease in the GFR of more than or equal to 40% from the baseline over at least 4 weeks or 1 month, and or renal death. For the secondary endpoints, it was the composite of the cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization due to heart failure, with other secondary endpoints including change in the albumin-creatinine ratio and second kidney insult. For the primary renal outcomes, as you can see here, finerenone demonstrated a renal protective properties. As you can see, it provides 18% relative risk reduction in comparison to placebo, with a significant relative risk reduction. As you can see here, for the component endpoints of the primary endpoints, as you can see here, overall kidney protection was in favor of the use of the finerenone over placebo, with a sustained decrease of the GFR, estimated GFR of more than or equal 40% from the baseline. Moving to secondary endpoints of finerenone use versus placebo, again, it showed cardioprotective properties. Relative risk reduction was 14%. For cardiovascular endpoints, both of them statistically significant in favors of finerenone use over placebo. Moving over the secondary endpoints of albuminuria or albumin-creatinine ratio change over time, as you can see here, there is a significant relative risk reduction of 31% at month 4 with the use of the finerenone over placebo. For the blood pressure and blood glucose, what of interest that it has a modest effect on the blood pressure, the finerenone, in comparison with the placebo, while there is no effect in the blood glucose. And this will demonstrate that finerenone major cardiorenal protection was out of the metabolic and hemodynamic control, and it's mainly due to inflammation and fibrosis. For the safety, and emergent adverse drug events due to the use of finerenone, almost reported adverse drug events was related to hyperkalemia, and the change in the serum potassium over time. It was over the median follow-up of 2.6 years, almost 2.3% of finerenone in comparison to 0.9% with placebo. And as you can see here, the maximum mean differences in the serum potassium between the groups was equal to 0.3% at month 4. For the change in the potassium over time, there is a clinical consequences that was infrequent with the use of finerenone over placebo. For the term of death, there is no death due to finerenone use all over the clinical trials. And for the permanent discontinuation and cases of hyperkalemia leading to hospitalization, it was, as you can see here, it was higher than placebo, but it was infrequent with the finerenone over placebo. To summarize the efficacy of finerenone use in type 2 diabetic and CKD, as you can see here, one would like to need to treat only 29 patients with finerenone in order to prevent one renal outcome with a relative risk reduction of 18%, while for the secondary endpoint, they need, or the healthcare providers, they need to treat 42 patients with finerenone in order to prevent one cardiovascular outcome with relative risk reductions of 14%, and both of them, they are considered clinically significant. For the safety summary, in population with type 2 diabetes and chronic kidney disease, and on the maximum tolerated dose of ACE and ARBs, finerenone demonstrated a well-tolerated clinical profile, and the adverse drug reactions almost were comparable between placebo and finerenone arms. Finerenone led to mean increase in a serum potassium of 0.2 millimole across the sub populations versus the placebo, but this side effect, it was really infrequent, and it was manageable and very well tolerated by the patients. To conclude our presentation, CKD is the most prevalent complications associated with type 2 diabetes, which remains the underdiagnosed all over the world due to underutilization of screening tests for patients with type 2 diabetes and CKD. For the kidney and cardiovascular outcomes, they are associated with mineralocorticoids overactivations, as we presented throughout our presentations. So by blocking the overactivation of these receptors through through all pathways, metabolic, hemodynamic, and inflammatory and fibrosis pathway, this is very mandatory for overall protection of diabetic population with type 2 over cardiorenal events. So up to date, there is no medication yet used to prevent the inflammation and fibrosis pathway, but recently with finerenone, the selective non-steroidal mineralocorticoid receptor antagonist, which showed that it might provide a cardiorenal protection in patients with type 2 diabetes and CKD by blocking this residual risk progression to end-stage renal disease through the fibrosis and inflammation drivers blocking. Thank you. Assalamu alaikum wa rahmatullah. I would like to thank the organizing committee of IHOP
Thanks for listening. Your attention was highly appreciated. And now, I would like to invite Dr. Oswald Benting from Novartis Company to talk about our healthcare system are ready to value and pay for cell and gene therapies. Thank you.
Thank you. I'm just sharing my screen. Can please confirm that you can see my screen? Let me try again. I think it was, I saw a note that it was disabled. Can you enable the ability to share the content? Okay. You can see my screen? Yours. Okay, fantastic. So am I able to go now and start? Okay, thank you. So, good morning, or actually good afternoon, I believe, in Saudi Arabia. My name is Oswald Benting, and I lead the market access function for Novartis Gene Therapies, which is part of Novartis, and in particular Novartis Pharma. Thank you very much for this opportunity to speak to you around the challenges with launching cell and gene therapies. It's particularly exciting to speak to you today, given the recent developments in Saudi Arabia, and I would like to congratulate the stakeholders listening today on the achievement of getting numerous cell and gene therapies to patients in Saudi Arabia. I'm particularly excited to hear that patients have already been treated with Luxturna and Kymriah, and also obviously very happy that we have an agreement for the reimbursement of Zolgensma as well. So looking forward to hear about those patients receiving treatment as well. So the challenge today that I would like to address is, of course, the challenge of launching these cell and gene therapies, which of course are hugely innovative therapies, and somewhat, as you know, jokingly, I've put in this picture here on the right, where Fred Flintstone, I hope you're as old as I am and remember Fred Flintstone, but who is here offering to help operate on Luke Skywalker, of course, from Star Wars, representing the huge innovation. And it's somewhat facetiously, but you know, we really are at an inflection point here with a lot of cell and gene therapies in development. And although the graph on the left focuses on gene therapies and is a little old, it does make the point that, you know, we are going to be seeing a lot of these new therapies come to market. So the decisions we make as healthcare system stakeholders are going to have a huge influence on the success of these cell and gene therapies, and whether or not they are actually going to reach the patients. And that's critical because a lot of these therapies will be transformational in terms of the effect that they provide, and in some instances can be life-saving. So it really is critical that at this important moment in time, we get it right so that the future of these innovative therapies is guaranteed. So today I'm going to quickly talk through the cell and gene landscape, so what's happened to date, address some of the challenges with these one-time therapies in terms of how to value them, and then look at some of the solutions in the form of payment models or risk-share agreements, and finally some reflections on what would need to change within the healthcare system to kind of get that success that I was kind of alluding to. So looking at the cell and gene landscape, I want to start off just by highlighting that these cell and gene therapies are in fact very different to conventional or chronic therapies. First of all, chronic therapies are administered, you know, year in, year out, or every month, or whatever the time frame is, but they don't necessarily address the underlying cause. Often they're more focused on addressing symptoms of disease. You know, you have to keep taking them for them to work. And the current system is set up for valuing them with, you know, randomized controlled trials as the gold standard. And the system in terms of payment is designed to pay for these conventional therapies because, you know, as the benefits accrue, each time a payment is made. Whereas with cell and gene therapies, in particular gene therapies, it's very different because they're single dose, right, or very short administration period. So basically a one-time treatment. They tend to address the underlying cause of disease, and in some cases might even be curative. They, as a one-time therapy, have the benefit to have, you know, the option of being beneficial for a very long period of time, maybe even lifelong in some instances. And of course, there's huge uncertainty. Given these long-term outcomes, there's massive uncertainty at time of launch in terms of the trial data that's available, and that poses huge problems for value assessment, let alone also for paying for them, because you're actually ending up having to front load the costs despite them having long-term benefits. And, you know, payments or payer or healthcare systems may not be set up to cover that cost today if all that cost is front loaded. So there are huge differences, and these require some sort of evolution. If you look at what happened under the EMA, the European Medicines Agency, you can see that there's been, we've seen a number of cell and gene therapies go through assessment and successfully, right? And not all of those have necessarily been a success from from whatever perspective, actually. I mean, you can take, I would classify success as actually getting to patients. Well, if you take the first one, Glybera, I think only one patient was ever treated commercially. But success has really started to come from around 2018 onwards with the introduction of the CAR-T therapies like Kymriah and Yescarta. And obviously we're in a very exciting period now where we're starting to see some really new gene therapies come in, like Zolgensma or Livmeldi, Luxturna as well. Not all success is already demonstrated by Zynteglo, which was withdrawn from the European market recently, but clearly a lot happening in this space. And, they are disrupting the way payers look at valuing and paying for these treatments, right? They are different. The system is currently set up for chronic treatments. We have seen a large increase in regulatory approvals and frameworks, guidelines, committees, bodies, etc., have all been pulled together to kind of accelerate that approval process. On the payer side, the advances have not been as remarkable or fast yet. Yes, there are advances in how value-based pricing is conducted, and new tools are being developed. How to implement value-based pricing with these one-time therapies, and also there have been developments in terms of looking at how to pay for these therapies with new payment models. But this is a watershed moment. These are step change improvements versus standard of care, and they are disrupting the way payers need to think about how to value and pay for these treatments. So we are at an inflection point, as I already highlighted. Again, just to highlight the regulatory pathway, especially in Europe, that there is a recognition already from regulators that you're not going to have perfect data at launch. There are risks with these therapies. They have created new pathways to assess them, like the PRIME pathway under EMA. They recognize that real-world evidence is critical with these types of therapies to complement the trial data to address the uncertainty around durability, effect, etc. Importantly, there's a huge willingness to collaborate. I argue that on the value assessment side, my personal experience has been very positive, I have to say, but there is a slight reluctance to kind of shift away from this way of valuing and paying. So there's really much, it's really set up for chronic therapies today. And there is the reluctance to accept that this data is not going to be perfect. They still want to see perfect data at time of launch. They're also reluctant to accept proxies or surrogates for effectiveness. And real world evidence, we've been talking about it for so long, but it's still hugely problematic in finding solutions with real world evidence to address uncertainty, etc. So still huge room for improvement there as well. And I'll come on to that in a moment. But if we look at the challenges, how to value cell and gene therapies, I think this graph pretty much sums it up. I hope you can see my mouse move, but on the y-axis, you have the cost, and on the x-axis, time. And with these one-time cell and gene therapies, yes, the cost seems very high, which is why for the gene therapy in this example, it's a one-time cost. It's constant. That's why it's going across the graph, this light blue line. But it's a challenge because in red here you see the payer observation rates. We all know that payers work with budget cycles. They look a few years ahead. So in terms of budget cycles, they're not able to really assess or accept or acknowledge that long-term value. They're really focused on this period in red. But what you see with the comparator or standard of care therapies is that these are tend to be chronic therapies. They accumulate in terms of cost over time until they reach this break-even point, say here in the middle. But then they continue. So effectively, if you really look at it at face value, these cell and gene therapies, not all of them, of course, but many of them have the potential to actually be cost-saving for the healthcare system if payers were willing to look out far enough. But because they don't, we need to find solutions on how to address this issue. We also need to acknowledge that these trials with these therapies are not going to be perfect. You're going to have very limited patient numbers. They're often in rare diseases. It might be unethical to do a placebo study, right? I mean, if these are life-saving treatments and there's nothing else available, you can't do a placebo trial. So it's always going to be difficult to find, the perfect kind of study design or studies for these types of treatments. On top of that, these there are subgroups often within these patient populations which are heterogeneous. These are often diseases that progress, and so you've got patients at different stages of progression. Obviously, early treatment, better outcomes than late treatment because the disease progression cannot be reversed. And so you've got different groups of patients with potential different value propositions. And then the question of durability, I mean, that's never going to be addressed because what treatment's ever going to launch with 20 plus years of data? So you're always going to have this question around durability of effect. So the challenges are multiple. They are clinical because ultimately today regulators and payers are taking different perspectives on the value assessment, on the interpretation of the data in terms of benefit risk and relative effectiveness. You're going to have uncertainty. Payers are going to be unhappy ultimately because the patient numbers are too low and the uncertainty is high. Their expectations are higher than what they're seeing. In economic terms, the price is negotiated up front, but the focus is on the short-term budget impact. Often other benefits, i.e. to families or the wider society, are not considered. And so that biases the view for against one-time therapies versus chronic therapies. And last but not least, because they're one-time therapies with high upfront costs, payers may not be ready to pay for them. So without any kind of payment solutions, we all know that healthcare system budgets are constrained. That's going to pose a real problem to payers. And on top of that, you also have this issue around what I call sticker shock. Everybody is looking at the cost of these treatments in terms of annualized treatment costs. They're used to chronic therapies, and suddenly they're seeing these very high costs, and they're thinking, "Wow, and you get these kind of headlines, the most expensive medicine in the world," but they're not really recognizing that these, as I highlighted before with the graph, these treatments over time actually could be health saving to the healthcare system, and sadly, they could create. This perception could create a perverse incentive where, it might be more commercially attractive for manufacturers to focus on chronic therapies because they might be, rewarded, or bluntly said, more money to be made. Now, of course, I'm not saying that is actually happening, but I'm just highlighting how unfair in a way the system would be if these types of treatments were not fairly or adequately rewarded. And just to put that into context, I mean, if you look, this is Germany, and these are list prices, and this is from 2019, but these are well-established rare disease chronic therapies, and I'm sure you're familiar with them, but you only need to look at the 10-year cost to see that these therapies can go up to north of 4 million euros. Whatever that is in dollars, $4.5 million. These cell and gene therapies often don't come near those types of costs, right? So you need to put it in the right perspective to really understand what the cost really is. So what could be a solution for these types of issues? Well, clearly payment models and risk share agreements are large part or partial parts of the solution. If we look at payment models, first thing, what are most suitable, of course, for cell and gene therapies are outcome-based agreements that address the uncertainty around durability effect. And if it's supposed to last for a lifetime or many years, you can pay by results or devise schemes that will ensure that money is rebated if outcomes are not met, etc. But also in terms of affordability, to address that budget impact in the early years, you can come up with pay over time schemes, also referred to as annuities and installments. And there are other potential solutions here, which I won't dwell on, but clearly there are solutions out there. And I don't want to sound negative. I want to be positive. I want to highlight that a lot of, the negotiations we've been having have resulted in agreements. Thankfully, because both parties were looking for kind of a way forward and agreed on these types of schemes to address those uncertainties and affordability issues. But just to show, I mean, clearly, if in this graph, you either have the upfront cost in year one, which to many would seem like a very high cost and might lead to issues with budgets. But you can also say, we're going to spread that cost over time. And even better, you might even be able to combine the payment scheme with an outcomes-based scheme. So, i.e., if an outcome's not met, from year 3, then from that point onwards, no further payments, right? So you're massively reducing the risk for the payer side as well. by really showing that there is confidence in this kind of long-term effect of this treatment, and we can find outcomes that we can link to this to these payments. So, in summary, what needs to change, and these are just some reflections. Clearly, we are making a lot of progress as we speak. Solutions are being found, but we are in some ways the tip of the spear, the first cell and gene therapies, and what we do will really have implications for future cell and gene therapies. And it's clear that society has very high expectations for cell and gene therapies. They expect superior efficacy. They expect this to be targeted in terms of treatment because we can do genetic testing. We can see which patients will benefit very clearly. So very, almost like personalized medicine. And they expect it to last. They want these treatments to be durable in terms of sustained effect over time. But we must also realize that we're not going to be able to get the type of evidence in the traditional clinical trials to demonstrate upfront that these expectations can be met, and certainly not within the sort of the framework of current kind of HTA assessment. And I of course acknowledge that every country is different rules, but generally speaking, HTA assessment as it stands today cannot necessarily address all of these expectations. So what would need to change? I think the most important thing is a greater acceptance of uncertainty and flexibility in evidence. The current reality is, of course, that these frameworks on the regulatory side are evolving in the right direction, but we see that what regulators say is not necessarily, or often not, adopted by payers and HTA bodies. So there are very big differences in terms of interpretations of what the data says. There are still expectations that the studies be done in the traditional sense, and there's a mistrust of the clinical benefits that are done outside of kind of the gold standard trials. What would be ideal in future is that there's better alignment across payers and regulators, that treatment time to access is accelerated because uncertainty is accepted, and we work together with payers to kind of generate the evidence to prove that those therapies are working as expected. We need to be a bit more flexible about what evidence types and study designs would be acceptable, and we need to give more time or more kind of consideration to patients and what matters to patients, and work together to find efficient ways to generate evidence. So we need also a broader and longer perspective, right? So not focus just on the early years, but accept that these are one-time treatments with longer-term benefits, and so go from the current reality today, where we focus most on what matters to patients and families, not being the case necessarily, where we have a narrow focus on the value criteria, very strict HTA rules around cost per quality, et cetera, very short-term perspective of data, and very kind of critical of that short-term data, and not really looking at the kind of how healthcare system impact in terms of the wider economy of society. The future needs to be a future where we have longer horizons for value assessment. We hopefully have a reduced burden on families and caregivers. We acknowledge that there are these savings to the healthcare system and the wider economy, and we better integrate the views of patients and carers. Real-world evidence is clearly also an incredibly important topic, because today there are many registries and observational studies, and we ourselves, Novartis, doing many of those, but it's a bit of a hodgepodge in terms of what different countries expect, and we have to work with existing registries in countries, and so there are many issues around data interoperability across different registries. So in an ideal world, we agree on how to capture this evidence. We work together, across stakeholders, get alignment on what that data needs to look like. We are able to link those registries and observational studies to pay-for-performance schemes to address the uncertainties, and we share the burden. And that can be from a financial perspective, but also in terms of trust, right? Because one of the big problems is that you can set up these registries, but then you have centers and say, well, we're tracking the data ourselves, and we're not really keen on doing this. A, it's a lot of work, and B, we don't trust these pharma companies necessarily because who knows what they're going to do with the data. So that's an unfortunate reality that we have to deal with. So if we could all kind of hold hands and agree on how we're going to collect this real world evidence, how we're going to use it, and do it in a transparent way so that all parties trust, then that really would be a huge step forward in terms of ensuring that cell and gene therapies can successfully be launched. So in summary, we need flexibility in evidence requirements. We need a broader perspective and longer term perspective for value assessments. And we need to be innovative and creative in terms of finding ways to address the uncertainty and how to pay for these therapies, given that they're one-time treatments with potentially lifelong curative benefits. So with that, I'm going to pause. I hope I didn't go over time, but I believe that there was going to be some Q&A.
audience.
Dear audience, we would like to start our fourth session, which is about pharmacists as an employee, and I would like to invite Dr. Saleh Al-Anazi as a moderator for this session. تفضل دكتور.
السلام عليكم. مساكم الله بالخير جميعا. We'll start with Dr. Hind Al-Mdemigh with the presentation or talk about by title Burnout. Dr. Hind Al-Mdemigh, cardiology consultant pharmacist. Ministry of National Guard Health Affairs. She also holds the position for the chair, the Corporate Drug Evaluation Subcommittee, member of the Corporate Pharmacy and Therapeutic, and the chair of the Saudi Medication Safety Center in National Guard. Welcome, Dr. Hind.
Task and you've been, probably procrastinating in doing it, it will take you months to finish that. So this is the difference between stress, burnout. I am overreacted. Anyone who's talking to me, I'm like, oh my God, I'm like you, that person. But then, I don't really have a specific emotions. My emotions are blunt, and that's how you identify a person with, a burnout syndrome. I have to do this now, and it has to be finished. I have to actually meet the deadline. But as a burnout person, I'll probably say it can wait, and I probably will procrastinate. I will never meet my deadlines, never meet my my tasks, or I never finish them. Now, in stress, I don't have energy. But in burnout, I don't have any motivation. Why would I do this? I mean, there's nothing really rewarding. If I probably would be given the same task and the same with no reward, probably that will not be encouraging. I will be anxious, and probably it will damage the damage will be in my physical health. And as a matter of fact, it can kill me prematurely if I'm stressed. However, the damage here is actually, as a burnout, it will be emotional, and probably will lead to depression, and I will be detached from everything that is around me. What causes burnout? It's either personal or workplace, and managers, directors, or those who are actually in administrative positions, they have to understand that you cannot separate personal life of your employee from the work requirement. Personal, for example, if you have someone who's actually who has personal health issues, family matters, any financial hardship, and of course, and we know with COVID-19 that actually added extra burden on us as healthcare professionals and as pharmacists for the workplace. And I believe there is heavy workload, and I believe especially the young generation who actually just joined the workplace, they will understand that probably what is this the amount of workload on them, especially those who work in large tertiary hospitals. Documentation requirements, and now with our electronic health system, it's really sometimes, I know we do it for the patient safety, and this is really important. But sometimes, and even with the alert that is coming from the system, but sometimes, these alerts, these notifications, the need for documentation, probably that will add an extra load on, the employee and the pharmacist as well. If we go with the dimensions of burnout, so we're talking about exhaustion, overwhelming, and then feeling cynicism, which is probably, I don't really respect my colleagues in my workplace. And of course, sense of effectiveness. It means that, well, I don't really matter in this organization, so why would I put a lot of effort? It doesn't matter if I actually come and go, if I actually witness, whatever, it doesn't really matter. So these are, why am I talking about these dimensions? Because it's addressed in the scale of assessing, the patient, someone's, if this pharmacist or this healthcare professional is actually burnt out. And I do recommend that probably as an audit tool, maybe those who are actually in higher administrative positions, they can distribute these scales on their employees and see if they're actually burnt out or not, and they can actually come up with programs to improve, their psyche or their well-being. So the best tool, and this is the tool that we actually use in our small scale study, but it showed really, frightening number of, results, like, in patients on pharmacists who are actually experiencing burnout. It's actually them, أنا أسميه مصلح سموه على كيفكم هو مصلح burnout inventory. It actually addressed, we talked about the 3 dimensions, it actually addressed the 3 of them, and this is the best tool because there are other tools, but this is the one that addresses the 3 dimensions of burnt out. But they modify it. It started as maslach alone, but then it was actually modified to have a maslach burnout inventory for health services workers, those who work in healthcare. So this is the MDI HSS is actually addressing the burnout in healthcare professionals, and also not only that, not only the dimensions of burnout, but also it included specific causes, because it includes some elements, what really led to this burnt out. Is it actually financial? Is it personal? Is it actually the workplace itself? And I believe, as I said, administrative people can actually use this tool to improve the quality of the workplace and their thing. So the scale is about, again, we talked about, it actually addresses the exhaustion, the emotional exhaustion. It actually measures it within 9 statements. It will tell you, will ask you, those who's going to fill the survey, do I actually feel emotionally drained from work? And I feel used up at the end of the work days. So the score actually from 0 to 18. So lower, those who scored 0 to 18, it means that they're okay, they're fine, but probably 27 or more, there is a problem and it has to be addressed, and it would be better if actually you, as an administrative, you could actually approach this person and try to actually counsel them or provide them with, area for, to actually release their burnout. And the second part from the dimensions that we talked about is personal accomplishment, because I want to feel that I accomplished something. I am actually worthy of, being in the workplace, and I actually contribute to work. And that gives us a sense of, accomplishment, something that it makes us feel that we actually did something. 8 statements, for example, I can easily understand how my recipient feel about things, and I deal very effectively with problems of, my recipients, which are basically my patients. 40 or more indicates a high level of personal accomplishment. 0 to 33, it means that probably you need to work with your employee on this. The third and final dimension is depersonalization. It means that at one point, when you are burnt out, at one point you'll feel that you really don't know yourself anymore. When you started, for example, as a pharmacist, and you tried to change the world, but with time and with pressures and with stresses around you, you feel that you really don't know yourself anymore. You used to come at 7 or 8, on time, whatever, and then you're not actually even coming to work, and you find excuses. So this is the depersonalization, that you really don't know this person you're looking in the mirror is not the person that you know. And again, the score will be 0 to 5. It means low level, which is really not good, but 10 or more, it means that you probably, which is actually good, that you're okay and you still like yourself. And we have to love ourselves at the end of the day. You have to, and I ask all members in this hall, please ask yourself these questions, and these questions have been maslach, and of course later, they notice that if you want really to know where are you from the, being burnt out or not, and we are at one point of our career, we are exposed to be burnt out. So ask yourself about workload. Is the workload requirement within reasonable human limits? We ask about, is there community involved in our actually business? There's a collaboration. Values, are you actually able to work in alignment with your personal values? Fairness, do you think probably the work or the organization you work for provides you with, equity, inclusion of, diversity? You feel happy about, what is incentives also for the reward? Do you feel that you've been rewarded for the things that you've done? And is there enough areas of your work, how do you work within your control? Can you control the environment that you work with? Ask yourself these 6 questions and see actually where do you go there. How do I prevent burnout؟ 5 دقائق لا خلص هي آخر سلايدين أصلا لا عادي مرتبتها لا تخاف. So you have to start your journey, okay? Probably you need to do your self-assessment. Consider your risk factors in your personal, professional lives. For example, identify, do you have personal issues that can actually lead to burnout? See if you can probably, even if you feel that your boss probably is bossing you more than you can tolerate, do this. Go and do your self-assessment. You can access the pharmacist well-being index, and this is the website and the presentation. You can have actually a copy of it. It's an interactive online, and it's actually a validated tool, so it will help you to identify if you are in the risk zone of having being actually burnt out. There's also several. So this is your self-assessment. You probably need to know: are you okay? Are you happy? Probably you can take a leave, and just check yourself. And then you can actually go to the websites here, included here, and check. And they're all validated, and they will tell you if you're actually burnt out or not. And then these websites, again, you can actually ask IHOP to give you a copy of it. You can access it, and they will give you recommendations how to improve yourself, how to stop, this process of you feeling that you are overwhelmed and you are burnt out. So probably it will give you some recommendations. Some issues will not be resolved. These tools will not help you. Sometimes you have to go to the core of the problem and actually fix it. You cannot change, like for example, an incompetent boss unless you change job or your boss is actually removed. So there are some things in life you can't, but you have to make your choices, and life is about choices, and you have to actually make them, and when you take a choice, you have to make sure that you're making the right choice. When you leave a place, you have to make sure that you're happy with your decision, no regrets whatsoever. This is basically my email if you need more information, or if you needed to actually contact me. If you have any questions, and I hope that I finished on time, Dr. Saleh. شكرا.
Great presentation. Topics very important يعني ويشوفها دائما صراحة.
Mental health is really important. Don't actually underestimate this. أتمنى بتروح عشان بس أتكلم. لا طبعا خلاص أنا خلصت. Mental health and well-being is really fundamental in our work. You have to actually make sure. I know everyone is talking about scientific knowledge and the boards and everything, but we also have to focus on how to actually have, a healthy person, a healthy pharmacist who actually his attitude and behavior, because mind you, burnt out will not only affect the person himself. It will affect the work. It will affect the patients, the relationship with other colleagues, because you will be angry all the time. You feel like you're not really happy. You cannot actually make any kind of connection with your colleagues or with your patients because you're just fed up with that. And this is what burnt out is about. So do not take this lightly. Administrative, please try to actually probably in all regions, you probably can actually work on this and see if how is your employees, or how are your employees are doing in terms of, being burnt out or not. Maybe you can give them support, not necessarily financial, support. Sometimes it's just they feel that there's someone who's actually taking care of. Shukran. Shukran.
Thank you for Dr. Hind. Now with the second speaker, Dr. Bandar Balkhi, with his title Hospital Pharmacist Satisfaction. Dr. Bandar, Associate Professor of Pharmaceutical Economic and Policy, King Saud University. He's holding PhD in Pharma Economic and Outcome Research, MCBHS University, Boston, USA. He's the whole Doctor of Pharmacy, PharmD, Pharmacy, Mass College of Pharmacy and Health Science 2011. Bachelor of Pharmacy, King Saud University 2007. Welcome, Dr. Bandar.
Assalamu alaikum. Good afternoon, everyone. It's been a pleasure to be here. I'd like to thank Dr. Saleh, for the introduction. Today, I will talk about job satisfaction among hospital pharmacists. This topic is actually usually neglected. However, it's very important because this is like where you can see the successful organizations or not. Because if you have satisfied employee, you can have satisfied patients and care as well. So job satisfaction is very closely related to the employee behavior at the workplace. It's increased involvement of the patient in the workplace and also increase their motivations. It represents two combinations, the positive and negative feeling about the workplace that the employee work, and also it's the perceived relationship between person's expectation and the actual results. So what's your expectation from workplace and what's the actual result that? If there are any variation between that, that's how we're gonna vary in the job satisfaction. If you have more expectation than result, you usually have unsatisfied. So job satisfaction of the medical staff and patient satisfaction. This is have a lot of the research doing in this area, and they found there's a huge relationship between the satisfaction of the medical staff and the patient satisfaction. We know that this day we are moving from the traditional healthcare to the healthcare where we focus more on the patient care, the value, so the patient start to be the center of care. So we usually often care about the patient experience, patient satisfaction, and patient's quality of life. And we cannot be achieving that unless we have satisfied employee. So patient may be more likely to return if they have positive experience. Imagine that you want to pick a prescription with the pharmacist. If you go and feel the pharmacist is motivated, happy, smile to you, you can imagine that you can feel that the patient have more positive experience. On the other hand, if you go to pick a prescription and you find that the pharmacist himself is sad, unhappy, he don't like his job, he is unmotivated, he's depressed, you can have negative experience about that, and maybe you will not return to that pharmacy. So in this day, hospital need to be proactive in every day to ensure that the patient have positive experience. One way to do that is invest in the human resource, invest in the quality of the human resource that you have, and also invest in to understand that you have the satisfied employee. So quality of the human resource service is one of the indicators that widely used to assess the job and professional satisfaction. So you have the KPI where you have to look for the job satisfaction. If the patient can understand that, if the patient can feel the employee satisfied, there is where you can move on. So once the patient's satisfied, you can understand why do that. So sometimes we're just focusing on giving a score for the patient, give survey to the patient to understand if they are satisfied or not. However, if you have unsatisfied employee, this can be very difficult to attain. Another relationship is between the job satisfaction and job performance. There is a huge study in this regard, and they're highly related. If the employee is satisfied, they usually get like their job and the job performance, productivity will go up. So hospital personnel have difficulty in meeting the need for their patient, the need for the patient, like give him consultation or any other like need if their own need is not met. So if they are unsatisfied, they are rarely try to satisfy the patients. So as hospital manager, you are responsible for both your staff and your patient as well. So you have to understand how you're going to make your patient satisfied, and also in order to make it this, you have to make your employee satisfied. So how this satisfaction going to affect your organizations? You're going to have like negative perception by your employee. You're going to have lack of the motivation, lack of interest about the job they're doing. So your employee will not like the job. They start having stress and anxiety. On the long run, they're going to have burnout, as Dr. Hindi mentioned. They start to have less productivity compared to where they are before. They're going to affect their performance. Maybe this is going to also affect other employees. So once they have that, maybe they start like chatting about they are unhappy with their another like colleague and employee, and you can see they have like negative in the culture. At the end, sometimes the employee is unhappy, sometimes is left your organization, so they have high staff turnover. And this is very expensive to the organization because you like train these employees for a long period of time. He has his job, high productivity. If you are trying to replace him, you have to start recruiting, which sometimes take a lot of the times. At the end, the reputation of the organization sometimes is decreased, sometimes affected if the employee is dissatisfied. So what we already know, several studies have been addressed the job satisfaction of the hospital globally, and here we can see in the United States and UK, they try to focus and see if their employee is satisfied or not. So in the United States, they found that both the pharmacists working in the community or working in the hospital have moderate level of job satisfaction compared to other like career. They found that some factor like can be like related to the job satisfaction like age, income, and practice side. In the UK, they found correlation between the stress and workload and job satisfactions. In order to assess job satisfaction, we have like two main types. We have intrinsic and we have extrinsic. You have to combine these together in order to get the overall global job satisfaction. Intrinsic, it means like the job itself, the recognition that you have, the accomplishment, and etc. Extrinsic means your relation with the manager, maybe the salary and the co-worker and colleague that you work with. Here is the 5 main factors that we have to consider in order to assess the job satisfaction. The work that you're doing itself. Are you happy with the work? What responsibility are you going to get? Are you interested or not in the growth that you're going to take with your career? Then the second one related to the supervision that you're going to work with. Your relationship, the quality, it has give you the feedback, social support, and etc. Third thing is about the co-workers. We know we spend a lot of time in the job, so relationship with the co-workers sometimes is very important. If they're only like harmony, if they're only treat you with respect, are you like happy with these colleagues or not? The fourth is very important, like promotion opportunities. Do you promote through all your job or not? Enhance like further advancement and etc. Lastly, and sometimes this come on the top of the any like a job satisfaction factors like the pay and salary. Is it like adequate for pay? Is it like you feel like you take what you are supposed to or not? So here we have I list 10 of the most common job dissatisfaction factors. So this you usually have to assess when you like to try to assess if your employee is satisfied or not. First thing is the workplace relationship. How the workplace can affect your organization. Like, do you have the right equipment? How smooth the work in place? Second one, lack of interest. Is the employee interested in your job? If they are interested in the type of like duty they have or not? Third is lack of training and development. Do you like train your people? You give them like opportunity to go, looking for like other opportunities, development, like give him the opportunity to take the master degree, residency, PhD, etc. Training women just go to the tech seminar or workshops. The work-life balance. Do you like respect the people life or not? Or you give him like a lot of like overtime, you give him like a lot of the like duties outside the working hours. Lack of the meaningful work. So sometimes the people didn't understand why they're doing the job. If they have lack of that, sometimes it's going to be affect their dissatisfactions. Unsupported manager and poor management. Management usually one of the top factors why people dissatisfaction. If you have poor or bad management, if you have the people who not like understand you, not respect you, not like give you the feedback that you want, sometimes it's going to be one of the major factors why people is not satisfied. Limited career growth, promotion. If you stay in the same place for several years, how this going to impact your satisfactions? Feeling underpaid is usually related to the feel undervalued. If you feel that the performance you are getting, you need more paid, so this sometimes also feel and be major factor for patient or employee dissatisfactions. Also, lack of appreciation from the society, the patients, or also your colleague or your manager. Sometimes one of the factors can lead to the dissatisfactions. So here are the two factors called theory of the motivations that we need to focus on if we'd like to increase our people satisfactions. It's called poor hygiene and motivation factor. Poor hygiene, we mean the factor that can decrease the employee satisfaction. So we need to decrease these factors and increase the motivation factors. This factor, like policy, if we have restricted policy, if the policy have an impact to our employee, the work condition itself, the salary, the pay, and also the supervisor relationship with their employee. So we need to decrease this type of factor in order to increase the satisfaction. The other factor called motivation factor, and this is where we have to increase it, increase our recognition. If the people do something good, we need to give him positive feedback, recognition, the achievement, give him some responsibility, how your value of board respect, and also the promotion and personal growth. Job satisfaction in many organizations use as the KPI for measuring the quality. So after you doing that, you can use it for some benchmark, including, for example, the employee NPS, which means the promoted scale, where you can ask your employee, how likely you're gonna recommend your company or organization for your colleagues or your friends or your family. So by answering this, you can see how value and how satisfied they are in their current job. Employee productivity, you can assess the productivity and link it to satisfaction. You can also assess the internal promotion rate and see how you doing compared to others. If the people promoted in your place or just staying in the same place for several years. Because as you said, this is one of the important factors for many people is the promotion and the advance in their career. Successful hire after the trial period. So if you have the trial period like 3 or 6 months, after that you can assess if the people is staying in your job or just leave to another job. Sometimes they are not the right fit, sometimes because they are not engaged or they are not the culture or the type of job they are doing. Turnover rate is one of the important scale and factor that you can assess for quality of care, quality of service that you're going to provide, and also for employee satisfaction. If the turnover rate is high, you have to assess the main cause of that and understand how you're going to try to decrease it. So you have, as a manager, to understand the main factor why your employees dissatisfactions, and then try to overcome these variables. How are we going to measure the satisfaction? Usually there is several ways. One of the most common is by providing your employee the survey. The survey should be a combined all of these factors that we talk about. After that, you can assess that if the employee is satisfied or not. Globally, as I mentioned, this is a study done for several countries. You can find the pharmacists in Australia satisfied, 77% of them satisfied, in US 67, and in India 16. So the range between 60 and you say 77 is the satisfaction rate in this country. So the question that we have, how about our satisfaction in our country, Saudi Arabia? So this study we done a couple of years ago to assess the satisfaction among pharmacists working in the hospital in Saudi Arabia. So our objective, we have two main objectives: to assess the satisfaction rate and also to understand the main factor, the main reason why the people is satisfied or unsatisfied. What's the driving these satisfaction rates? So this was cross-sectional study, sitting a pharmacist working in the government or private hospital. So both public and private hospitals as a target. We give him the self-administration survey. So here we have the total of 133 pharmacists who answer the survey. So it's a small sample, however it gives us some understanding about satisfaction. You can see here most of them is male, young age from 25 to 30s, and also along with them have few years experience from 5 to 10 years. So here's the result. Once we get the results, so this is where satisfied. They usually satisfied about the clear policy that their department or hospital have. So they are satisfied, they happy with the policy. They also have the availability of the necessary equipment and resources like the healthcare resources or healthcare equipment that they need to deliver the patient's care. They usually appreciate the appreciation from the society. They are happy and satisfied if they society appreciate the work they done by the pharmacy. Also, they're happy with the relationship with the supervisor. As I mentioned, this is one of the main factor for any satisfaction is how we can relationship with your manager. So here they are satisfied. They also think that their hospital hire only competent people. They also are happy with the we know that the pharmacists usually work in the team, so they're happy with the co-worker in other departments like nursing and physicians. So that's the positive thing. How about the negative? They are dissatisfied with several factors. On the top of that, we have the salary. They are not satisfied with the salary. They think they are undervalued, they are underpaid, and they think they are worth more. They also complain about the workload the pharmacists have in this day. They complain about the schedule, and schedule sometimes night shift, morning shift, and sometimes this is going to be affect their life. They are also complain about opportunity for training or to sending abroad to studies or for also local workshop and training. Some of them complain about show appreciation about the safety from the patient. Sometimes the patient is not satisfied, and we can see in the beginning if the employee is unsatisfied, sometimes they're gonna reflect on the patient as well. They complain about the clear policy about promotion. So this is the policy is unclear, is unequal. So sometimes we have to think about the equity. Some people get promoted, some people is not. They also think about the size of the workplace. Some people complain it's small. The physical arrangement may be worth more arrangement to make it smooth in the work. So here are the top factors that we collected from the survey. We can see the usual unsatisfied about salary, workload, and promotion is the top 3 factors that why people is unsatisfied about their job. So here the overall satisfaction rate. You can see it's the satisfaction is 53, however, we still have 47% is unsatisfied about current job. We asked them, are they gonna willing to spend their retained life in the current job? However, we have 66% say they're looking for a new job. However, some people leaving their work with a bad feeling, so they not enjoy their work in their daily pace, and you can see here 62% answering no, and only 38% having that bad feelings. So in the conclusion, we have overall global satisfaction is considered low compared to the other globally or other countries. A decision also to remain in the same career is even lower, and you can see some people try to shift to other career. They tend to also use a response about job satisfaction, higher positions. We found that people who have higher position, higher job title, try to be more satisfied than other people, maybe because they are getting promoted and the salary and their experience. We have some limitations in this study, small sample size, unable to maybe have some group analysis about maybe male, female, about some age group, experience, and some maybe clinical pharmacists or other traditional pharmacists. Also, the most of the responses have less experience, so maybe this is maybe different from people who have more experience. Maybe the people more experienced can give us different result than the pool that we have here. Also, the sample technique, we use the snow modeling techniques where we just given the people and try to give another response. Maybe this have some sort of the result bias. In conclusion, we talk about the high turnover rates because of dissatisfaction. This is very expensive, and as manager, we have to think about how we're going to decrease that. You should be able to identify the area that require more attention, the area that maybe focusing about put more motivations to your employee. So this need or our work maybe need further validation by having more sample size, maybe doing across several hospital, several having maybe more than 1,000 response give us more credibility and more generalizable response. So in conclusion, we'd like to shift from unsatisfied to satisfied employee, as we saw for all the factor or the positive thing that can happen. This is sometimes don't have to be invest a lot of money. You can enhance motivation by maybe recognition, accomplish, advance. You can also think about how you're gonna increase the trust between you and your employee. So trust them, give them the opportunity to do the thing right, and make them feel great. Usually is a great opportunity for them for increased satisfaction. So that's it for my presentation. Thank you for listening. Thank you so much.
Dr. Hind, would you mind to come here for if there is any question?
طبعا شكرا دكتورة هند، شكرا دكتور بندر على المواضيع الحساسة جدا والجميلة. أنا عبد الرحمن السويدي. طبعا راح أسأل بالعربي لأن الموضوع يهم الجميع بالعربي نسمع. هل في رابط مباشر ما بين الرضا الوظيفي والاحتراق الوظيفي؟ هذا السؤال الأول. السؤال الثاني، تسمع بعض العبارة تسمع عبارة دائما يعني تتكرر من بعض المدراء انه لو اعطيت اهتمام زائد بالموظف تبغى يعني تبحث عن الرضا الوظيفي راح ينعكس سلبا على اداء. تلاقي دائما يبحث عن الاهتمام، يبحث بخف الاداء. العبارة هذه صحيحة او خاطئة؟
بالنسبة للسؤال الأول، علاقة البيرن اوت بالساتسفاكشن ريت، في علاقة وطيدة بينهم. يعني البيرن اوت زي ما تفضل الدكتور هندي يسبب لك الاسترس، يسبب لك الانكزايتي، وهذه زي ما شفنا احنا احد العوامل الرئيسيه في اني جوب ساتسفاكشن. فعشان تمنع انت البيرن اوت ممكن تزيد الساتسفاكشن، ولكن جوب ساتسفاكشن كبرودر كونسبت انه اعلى من مجرد البيرن اوت. زي ما شفنا نعتمد على اشياء كثيره، ولكن احد الفاكتور المهمه فيها هي البيرن اوت فاكتورز. الدكتور هندي ده بتكمل في الموضوع.
اكيد طبعا. definitely agree with that. زي ما يعني ذكرنا احنا في المحاضره انه هو حقيقه جزء اللي هي related to work او اللي هي متعلقه بالعمل، اللي هي انه الواحد يحس انه يعطى تاسك كثير مره، يعني اشياء اكثر من طاقته. يعني يعطى مثلا تشوف انه مثلا اوكي انت شغلك مثل تسوي 1 2 3، بس يقول لك لا سوي هذا عشان انت سريع، سوي هذا عشان كذا انت مدري ايش، وانت اللي يسمونك الجوكر. احيانا انا ما اعرف هذا المصطلح، احيانا يستخدم يقول لك اوكي انت جوكر، يلا تعال انت اشتغلت الان نايت شيفت، تعال بكره مو داي، ممكن انت اشتغلت ايفنينج شيفت، تعال بكره شو اسمه داي شيفت عشان انت مره انت ممتاز ونسمع لك. فهذا ابغى اسويه عشان انا جود فارماسيست وام تراينج تو امبرس ماي امبلوير ماي باس، بس حقيقه on the long term بيرهق الشخص. فهذا فعلا يسبب الاحتراق الوظيفي. عرفت؟ يعني احنا في بداياتنا لما نبدا صغار وكذا we try to improve او impress لا مش عشان تو امبرس اور bosses. احنا لما نبدا نحب الشغل نشتغل عشان نقول نثبت انفسنا، نقول لك عشان الناس تعرف اني انا اما جود فارماسيست. فاي شيء يطلبونه مني اقول لهم ايه يس انا موافقه وانا باخذ وبسوي بحطه كذا او انا بحطه مدري. لكنك لازم انت تحط، حتى لو كنت جونيور، حتى لو كنت لسه متوظف، لازم تحط باوندريز. وكمان المدير لازم كمان هو يعرف احتمالات الاشخاص. احنا شخصياتنا الكاركترز وكذا تتغير من شخص لاخر. الارهاق سبب مهم في الاحتراق الوظيفي. لما تحس انك انت قاعد تشتغل كذا زي الآلة، اعتقد هذا مو هيلثي ابدا. لكن في شبابنا في ايامنا في بداياتنا كنا نحب نشتغل كل حاجه يعني، بس احيانا ما يكون هذا يعني صحيح. سؤال الثاني لو سمحت كان
المدراء ممكن ينعكس سلبا على الانتاجيه.
انا برأيي انا حقيقه وانا اقوله والحمد لله مديري موجود قدامي الحمد لله. لا انا لما كلمه انا ارى وانا حقيقه اشوف ان هذا جزء طبع من الانساني. كلمه حسيت ان مديرك يرضيك، كلمه حسيت، وهذا النورمال وهذا الطبيعي وهذا المفروض كل الناس. كلمه حسيت انك انت لابد ما تسوي حاجه عشان انه هو يعطيني في المقابل انا ازيد انتاجيتي. كل ما اعطاني شيء يعني انا حقيقه يعلم الله دكتور سعد كان مديري من زمان ما يبقى له كم سنه لو سمحتوا، ارجع انا عشان الاحراج بس يعني. لكن انا كهند بدينيخ ما كنت راح اوصل للي انا وصلت له وهو ما هو بذاك الشيء الكبير، لكن أنا أشوفه قدام نفسي إنه هو الأشياء الجوز حقت حياتي يعني. ما كنت بوصل لما حصلت من الدعم من الإدارة، فكل ما أسعدوني طيب كل ما أنا قمت رحت أعطيت زيادة بكل رضا بكل حب. وأنا حقيقة أنا أقول لك أنا ما أعتقد تعرضت أبدا للاحتراق الوظيفي، لأن أنا كانت عندي إدارة كويسة وأنا نفسي كنت أحاول إني أنا يعني عرفت أضبط الأشياء. ممكن لحظات كذا مرت علي وكذا، لكن أوفرول. فاللي ساعد إذا الإدارة ساعدت الموظف صدقني 99% الموظف هذا بيعطيك أكثر من اللي عنده، بيعطيك 150% of whatever this person. كل ما حس الموظف أن مديره داعمه من أجمل الأشياء اللي أنت ممكن تتخيلها في حياتك. بالعكس أنا أعطي وزيادة وأعطي بكل رضا، ولا أحس أني أنا أبي أبيوز أو أن أحد قاعد يستغلني. كل ما زادت الإدارة أنها تعطي وأبريشيت small incentives، شهادة شكر، تقدير، وهي أشياء بسيطة ترى، مو لازم فلوس ترى. أحيانا إحنا ما نبحث على الفلوس، إحنا نبحث على الأشياء اللي تحسس إنه مديري معجب عن أدائي، وخصوصا لما تكون أنت صغير لسه جاي لسه بادئ كذا. فهذا بالنسبة لي كان واحد صغير أو واحدة صغيرة، إنه والله مديري شايف شغلي وشايف أنا إيش قاعد أسوي وأبريشيت، هو عارف إني أنا فعلا قاعد أشتغل وقاعد أسوي وقاعد أبريشيت. كلمات بسيطة، شهادة شكر بسيطة every now and then. وعندنا برنامج حق الابريشيشن في الصيدلية في الحرس، يعني كان رائع جدا، يساعد حتى التكنيشنز حتى كمان ينعطون ابريشيشن، مع انه هو شغلك انت لازم تسويه، بس لما يقدرون انك يعني فعلا شغلك كان رائع وكذا. فهذه الاشياء ما ابدا تدلع الموظف، بالعكس تعطيني فرصة استمر اكثر واكثر. احس ما ادري، انا احس اللي خلاني استمر ال 25 سنة اللي فاتت قصدي من 10 سنين اللي فاتت من 5 سنين فاتت هو الدعم اللي حصلته من إدارتي حقيقة.
يعطيك العافية دكتورة هند.
أوافق الدكتورة هند أنا في الموضوع هذا، وفعلا يعني لازم يكون في بالانس، يعني ما نوصل للدلع أوقات، ولكن فعلا we have to get more attention to our employee. يعني شفنا احنا كيف الجوب ساتسفاكشن راح نعكس انعكاس إيجابي لطريقة العمل، للبرفورمانس، للأداء، حتى في النهاية للبيشنت ساتسفاكشن نفسه، رضاء المريض. فاحنا أوقات نركز على المريض، نركز على الجوب ساتسفاكشن أو البيشنت ساتسفاكشن، ونهمل الجانب اللي في البداية هو فعلا الموظف هو اللي راح يكون الأداء أو الشخص اللي راح يوصل لنا هذه بطريقة صحيحة.
يعطيك العافية. أول شيء تسمحوا لي بس أرحب بالدكتور خليل الماجد مدير التشغيل عندنا في الحرس الوطني. تعال هنا يا أبو عبد العزيز عشان تسألنا يا أخي. والدكتور سعد العبيدي مدير الصيدلية في الحرس وجميع الحضور يعني. تفضلي دكتورة إذا عندك سؤال.
السلام عليكم. أنا والله توني أشوفه. أجل طلعت العفش قدامك كان علمتوني. طيب
أقول ما خربتيها أنت درت.
هو ما شفته.
والله ما شاء الله أشبعت الموضوع ما شاء الله. طبعا أشكر صراحة موضوع البيرن اوت من المواضيع الحساسة جدا، واللي أعتقد الكوفيد 19 كان له امباكت عالي جدا على الهيلث ووركر بشكل عام. اعتقد التنوع في الابريشيشن والموتيفيشن للستاف والاد فاليو، لكن صراحه حقيقه في جانب يخص الهيلث وركر نفسه، انك لما تكون داخليا عندك الموتيفيت تو هيلب البيشنتس، في النهايه الاند يوزر هو الشخص المقابل لك، وهذا اللي نحرص دائما عليه انك هيلث وركرز انه يكون بارت مهم في العمليه الطبيه المقدمه كامله للمريض. جانب البيرن اوت موجود في كل الوظائف، لكن جانب الحماس للوظيفه والانثياستك اللي تبلت الباور لنفسك وللتخصص وللمستقبل اللي بعدك. فما قصرتوا صراحه، لكن كنت صاير في متوزع عنكم، لكن جبتوا
كبيت عفشي قدامك عاد.
يعطيك العافيه دكتور. تفضلي دكتوره اذا عندك سؤال.
مع اختلاف الأجيال الآن لاحظت أن اختلاف الأجيال يختلف الورك إثيك لكل جيل، فالابريشيشن يختلف. يعني موظف متوظف في 2020 يحتاج ابريشيشن مختلف عن موظف في 2000 متوظف. فكمانجر how do you know what kind of appreciation the employee needs لأنه هذا بصراحة يعمل يعني لو حطيت مثلا أنت شيء معين، مثلا let's say شهادة شكر على موظف الشهر مثلا، في بعض الموظفين يجي يقول لك إيش أبغى شهادة شكر يعني سوت فكيف تقدر تعرف differences بين كل موظف وموظف، كيف how to target it، خصوصا لو كان عندك 100 بلس يعني موظف، كيف to target الappreciation؟
إذا سمحتوا لي بس أنا بوجه السؤال للدكاترة. عندك في 3 هنا هم أصلا ماسكين حوالي 500 employees. let them go ahead and بعدين
دكتور سعد إذا عندك شيء، دكتور سعد ولا
سعد،
دكتور
دكتور
بندر؟
ماجد، الشناوي، كلهم هذول يعني ماسكين مئات. فتفضلوا.
The burnout and the job subject pharmacy leader, unavoidable increase of working workload, extended working hours. I mean, as she mentioned, I mean sometimes the expectation of the employee. Okay. Budget constraint. I will start from the beginning. Maybe it's burnout and job satisfaction is a very challenging subject to all pharmacy leaders. Unavoidable increase in workload, extended working hour, and sometimes the appreciations didn't reach the expectation of the employee. Budget constraints. Okay, I think we should think of redesigning our workflow. Okay? I mean, as well as the patient is very important subject in this. So engaging the patient with us, okay, would also create an environment of appreciations to the staff. So engagement to patient is very important.
يعطيك العافية دكتورة. بالنسبة للسؤال اختلاف الأوقات، فعلا التايم از بلاي، يعني كل جيل مختلف عن الجيل الثاني، فكيف نعرف how we're gonna measure this is usually through the job satisfaction survey itself. فنبدأ نقسم احنا الأشخاص على حسب الجروب حقهم الايج جروب، بعد كذا نشوف احنا which the major factor that impact these employees. إذا فعلا لقينا إنها مختلفة ممكن نبدأ face to face interview، نجيب أحد الجروب هذا نبدأ معاه ونشوف احنا حتى نوصل للفاكتور المعين اللي ممكن يكون مختلف من شخص إلى شخص أو من time to times.
دكتورة هند عندك كومنت على الموضوع؟
ما agree with Dr. Bender يعني definitely هو
طبعا أنا عندي كومنت على الموضوع هذا. يعني أعتقد إنه الستاف ساتسفاكشن ستارت زي ما قال الدكتور سعد من الستاف انجيجمنت. الستاف وانس انه حس انه انجيج في كل شيء، في الديسيجن، في البروموشن، في الاشياء الثانيه يعني، والكارير حقه يكون كلير. اعتقد this is the first يعني point or step to staff satisfaction.
بس أنا totally agree مع الدكتور بندر. do a survey وشوف الموظفين اللي عندك ايش اللي بيعجبهم. والآن صارت كذا حتى اريا، صاروا الناس الآن متحمسين. الآن صار في مثلا عندك الامبلوي ساتسفاكشن، لأنهم تحسوا أن كثير مثلا الناس قاعدين يطلعون من الدوام أو يعني يتركون الشغل يغيرون الشغل وكذا، ف you can do a survey.
بس هي تقاس دكتورة بستاف ريتنشن. في نهاية المطاف الستاف عندك هابي ويقول لك ساتيسفاي والريزيجنيشن كثيرة.
بس كلنا نبغى فلوس زيادة.
هي في نهاية المطاف هي الكي بي اي از الكي بي اي اي ريكومندد از كواليتي مان از كيو اي ستاف ريتنشن نوت ستاف ساتسفاكشن.
والله ما عندي الا موظفة واحدة فما اقدر اقول
يلا دكتور.
طيب شكرا جزيلا يعطيكم العافية. بس ملاحظة سريعة جدا، لما اجي اقول as a manager او as a leader and he will create a survey to know what their staff need, it means that that manager or that leader has to leave his place As a manager or a leader, he should schedule at least weekly, monthly meeting one-on-one with each employee he has, especially with the direct managers that you have. Yes, if you have a direct manager in the area, he should schedule. Managers that they are waiting to meet with their staff just only for the yearly evaluation, or if they do a mistake, they are not considered as managers. Meet with your staff, discuss with your staff, negotiate with your staff, know what your staff knows, not through a survey, through a one-on-one meeting. You should know what they request. Some of the people, they consider financial compensation is an appreciation. Some, they just only need a thank you word. Thank you for what you did. Others, they will require a thank you or appreciation certifications. So know exactly what your staff need, and then base your action on what they need.
شكرا دكتور شناوي. I totally agree with this. هي إشكالية إن إحنا مثلا دائما ننسى مثلا لما يكون واحد إداري وكذا، إحنا دائما ننسى إحنا تأبريشيت الأشياء الصغيرة والأشياء اللي يسوونها الموظفين وكذا، لكن لما يكون في مثلا خطأ أو شيء دائما إحنا على طول إيش اللي صار. لكن في هذا، لكن أنا believe the pharmacy department is actually doing a great job من ناحية الابريشيشن والجود كات بروجرام من ناحية الميديكيشن ايرورز وكذا، فهذا أنا أشوف إنها مرة كويسة. Our scheduled meetings is really important. لكن إيش الفائدة من الاجتماع إذا كان المدير is not willing to change؟ يعني أنت تجي له كمثلا 70 جنيه.
Listen to your staff.
They don't take an action.
Listen to your staff. No, believe me. Just listening will relieve almost 70 to 75% of what staff needs. And then try to stand with your staff situation. Try to back up your staff. Never tell your staff that I cannot back you up. No, you are his manager. You have to back them up. You have to do your job. And they have to feel this, that you are standing with them, not against them, even if they made a clear mistake. If they will feel this, believe me, they will retain in the hospital. They will never find outside opportunities.
Last question, please. يعطيك العافية دكتور محمد. Last question. ايوه هو الدكتورة عندها
السلام عليكم، يديكم العافية. دكتورة أمنة مختار، كينج فيصل جدة. My question, how we can overcome as directors and administrators the short-end staff and the higher workload and the needs of our operations. This is a very difficult equation, and we were never been able to solve this. Any comment?
والله ما عندي because I'm struggling with short of staff.
طيب بجاوبك لو تسمحين لي يا دكتورة. لا بقول لهم طبعا الأسبوع الماضي كنا في ميتنج أنا والدكتور سعد. There is no يعني excuse إنه الورك لود وشورتج اوف ستاف وسبيس، الأشياء هذه في كل مكان. لا تجي وتقول لي أنا والله عندي ورك لود وشورتج اوف ستاف، كل الناس عندها كذا الآن وسبيس ما ياخذ. هي لازم تسوي البرايورتي، والبلد الآن 2030 مقبلين على الشيء هذا وحاطين أولويات. You have to يعني list your priorities وستار with it. الهايرنج بياخذ وقت لأنه السيستم تغير في البلد، الشورتج اوف ستاف موجود، الكرايتيريا تغيرت كليا، احنا في شيفتنج we have to يعني believe it يعني ما لذلك أنا عندي work load لازم أبدأ في الأولويات فقط على أساس أبدأ أنجز فيه. ستاتستيك. طبعا في عندنا مشكله كثيره، انا والله مزحوم، انا والله مزحوم. انا جيت مستشفيات كثيره مع سباهي ما في ورك لود ستاتستيك، ما في. اجل مزحوم، انت كيف تقولي عندنا ستاف مثلا في سترايت اكس، صح ولا لا؟ يعني عندنا في المستشفى يعني انا اوفرلود، انا ورك لود عالي. طيب قل لي يا دكتوره ولا يا دكتور، الارقام هي الارقام، انت كيف عندك زحمه؟ لذلك يا دكتوره يعني اي ريكومند اول صراحه انه الورك لود ستاتستيك ستار وذ ات، يعني ستار بلاننج بيست اون ورك لود ستاتستيك، نوت اف تي اي، ورك لود ستاتستيك. ومن بعدها حتى البليفنج للهاير مانجمنت، يعني يوم ترفع لاداره الاداره الرعايه الصيدليه في الورك لود ستاتستيك ديفرنت بتوين انه والله انا احتاج 5 ستاف لان عندي كذا. لان هذا الشيء اللي هذا يعني اذا كان الدكتور محمد ولا الدكتور خليل عندهم اي كومنت.
دكتورة آمنة كيف أحوالك؟ الحمد لله على السلامة أولا. ثانيا أنا بعطيكم بس خبرتي البسيطة. أتحدى لو في أحد راح لأي مدير صيدلية في العالم مو في المملكة وقال له do you need more staff وقال له لا أنا I have enough staff، أتحدى ما في مدير راح يقول لك لا أنا I have enough staff. كنت في كينج فيصل في الرياض، كنا بنقول we are shortage في الستاف. رحت إلى وزارة الصحة لقيت إنه أنا عندي صيدليات لمستشفيات كاملة قائمة بعدد يمكن لا يمثل 5% 10% من الستاف اللي رانق فيه الكينج فيصل اللي في الرياض. طيب كيف إن هي ماشية؟ كيف الشغل ماشي؟ والله ما تعرف. خلاص it's an internal arrangement we put it for the working hours. Try to tailor your work experience, your tasks based on your working hours. If not, I will ask, all of us now, we are asked to open a virtual clinics. All of us now, we have all of our ambulatory, all of our outpatient prescription is increasing. What to do? Shall we go and increase the number always? No. The answer, we need to look how we are doing the process and to retailer it based on our needs. This is my experience, small experience. I have experience in King Faisal and MOH only.
I can comment just comment. يعني just think about different processes like tailoring the processes. But for example, maybe 2 years ago we had to كان لازم عندنا اتفاقية مع سعودي FDA إن إحنا increase the number of adverse reactions. فطبعا كان كل العبء يمكن 90% كان على الصيادلة لأن هم they have to increase reporting rather than the physician، لأن يعني الphysician ياخذ وقت طويل عشان to do something like this. ففي الأول بدأنا وكانوا كلهم increase workload، إحنا حنزيد حنعمل نفس الحكاية مرة ثانية، حيصير أكثر، يعني كان في resistance كثير على حكاية إنه هو workload. وكملنا على هذا يمكن سنة. بعد لما بدأ كوفيد for some reason حولنا البروسيس from manual to electronic، إنه هم يعملوا reporting electronically. فجأة من غير ولا أي حاجة زاد الريبورتينج. فاكتشفت أنا كمانجر إن الفكرة ما كانت workload، غير إنه كان البروسيس والبروسيجر كانت tedious، تزود نفس البروسيس تزود الوركلود. فيمكن إذا زدنا أعباء أخرى نحاول redesign our previous workload or processes previous work بطريقة إن هي تخفف الضغط من هذاك الشغل. مثلا automation is very important في decrease workload most of the processes. فمو على أساس إن إحنا عشان نفسح مجال لشيء يدخل لازم نغير process قديم ونخليه مختلف. Utilizing interns, resident, technician, pharmacy technician has a very good role in so many processes in the pharmacy. So إذا جاء شيء جديد نحاول نشوف مين عندنا we can utilize them حتى لو ما كانت النورم إن إحنا ندخلهم في البروسيسز. بس هذه أشياء ممكن
يعطيك
تقل.
العافية دكتورة، يعطيكم العافية. شكرا دكتورة هند وشكرا دكتور بندر. كانت يعني البرزنتيشن يعني great presentations، والأكبر دليل الدسكشن اللي صار. شكرا لكم ويعطيك شكرا للحضور. والسيشن اللي بعده خلاص يعني ما عندنا. يعطيكم العافية.
يعطيكم العافية دكاترة، النقاش كان جدا ممتع ومثري. وتفضل دكتور محمد الشناوي لتكريم السبيكرز. الدكتورة هند المدميغ. الدكتور بندر بلخي. الدكتور صالح العنزي. Dear audience, by now we will proceed to our fifth session, which is about clinical pharmacy qualifications. And I'd like to invite and welcome Dr. Fakhr Al-Ayyubi, which is our moderator for this session. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody, dear colleagues. It's always a pleasure being in the pharmacy gathering. Again, talking to each other is a very important step that IHOP was able to do it. I want to thank the organizing committee. Dr. Muhammad Shinawi, thank you very much for having the lead to make people talk to each other. Today we're going to talk about a very important aspects, which is the clinical pharmacy qualification. The audience here doesn't look excited about it. Why? Okay, great. Like, it's a debate. I know pharmacy profession has been there for more than maybe 50 years now. King Saud University was the only for some time to be the College of Pharmacy in Saudi Arabia. But it's not the story anymore, like what you heard yesterday from Dr. Shinawi, that it's a 27 College of Pharmacy producing pharmacists to the culture. So let us now talk about it in deep details. It's a pleasure to introduce Dr. Ahmed Al-Sagar. Dr. Ahmed, Manager of Pharmacy Service, John Hopkins, Aramco Healthcare Al-Hassa. He has a bachelor degree and a master degree from Australia. On the top of that, a BGY 1 and a BGY 2. Again, he has the combination of both academic and practice. So let us see your experience, Dr. Ahmed. Tfadal.
Assalamu alaikum wa rahmatullahi wa barakatuh. Actually, it's a great pleasure to have myself feeling home, actually. As a member or ex-member of Ministry of Health, sure that all the level that I reach now starts from Ministry of Health. So I am glad to have myself between Ministry of Health leader, colleagues, and pharmacy practice. First of all, I have nothing to disclose regarding this topic and this presentation. Our objective for today is to have an overview of master degree in clinical pharmacy, as well as an overview of pharmacy residency program, and then to review a position statement by Saudi Society of Clinical Pharmacy. Actually, I try to compare apple to apple, utilizing the residency program in Saudi Arabia as well Master of Clinical Pharmacy in Saudi Arabia. And maybe we can go through some other program, international program, if we have the time. And also I would like to assure you that I will finish on the time, if not aerial, inshallah. All the information provided in this presentation representing objective information, not representing personal opinion. Maybe I have a small statement about personal opinion. However, all the information is based on what I obtained from the literature. So starting with the master's degree, if we will define it, it's an academic degree awarded from the university upon completion of course of study, demonstrating mastery or high order overview of a specific field or subject of study or area of a professional practice. It comes in two pathways, including research or coursework. If we talk about research, its purpose to qualify individuals who apply an advanced body of knowledge in a range of contexts of research. If we compare it to the coursework, the purpose is to qualify individuals who apply the advanced body knowledge in a range of contexts for professional practice. For both degrees, if we talk about the research or coursework, it can qualify you for further study, including PhD. Our focus about Master of Clinical Pharmacy, it's preparing the graduate to assume his professional role in the advanced practice in clinical and hospital pharmacy in various work institutions, including hospital, primary health care, health education, healthcare institution of all kinds in the government or private sector, including regulatory body. The program has been designed to enable candidates to acquire the necessary knowledge and skill and ability in the field of the theoretical and the clinical treatment that place him or her in the main site of a practice. If we classify it as objective to be more accurate, the candidate will acquire advanced knowledge and understanding of the management of range of acute and chronic condition. Also, will be able to acquire skill in medicine optimization and the ability to communicate with the range of the healthcare professional to promote the appropriate use of medication. Also, they will be able to acquire a skill in a critical evaluation of a range of health services and product literature. For the Master of Clinical Pharmacy in Saudi Arabia, if we talk about the duration of program, based on my search, I identify 3 Master of Clinical Pharmacy available in the kingdom. The first program established by King Saud University, the second program provided by Riyadh Al-Ilm University, and the third program by Al-Qura University. The standard duration of the program is 2.5 years of mixed mood type of learning, including coursework, practice or clerkship, and research. Here I will expand our discussion. If we compare this program to international program, we have like most distinguished program compared to other countries who have Master of Clinical Pharmacy. If we talk about United States, actually they don't have or they don't offer Master of Clinical Pharmacy. The only pathway for the pharmacist to advance his career in clinical pharmacy is via residency program. If we talk other countries, including England or British, or other country which calls British colonial country, for example, Australia, New Zealand, South Africa, they have the Master of Clinical Pharmacy, and it's ranged between 1 to 1.5 years of coursework, including, and they proposing that a training or clerkship for those who are employed in their country. However, if you are not employed in their country, I don't think you will have sufficient training compared to what we are providing here in Saudi Arabia. And this is one of the advantages of our program here, which we are proud of. Then we will go to postgraduate pharmacy practice residency program. It refers to a structured clinical training to qualify healthcare practitioner, usually in healthcare institution setting, under the direct or indirect supervision of a senior clinical registered in the specialty, such as in our practice, we talk about the clinical pharmacy under a clinical pharmacist or consultant clinical pharmacist. It aims to prepare the pharmacist to practice as high qualified independent, and I am putting two lines about independent compared to the master of clinical pharmacy. Qualified independent practitioner able to provide patient care in a variety of environment, apply skill in medication-related education, serve as a leader within the profession of pharmacy, and excel during the further postgraduate training. And for the further postgraduate training, we have here BGY1. He can proceed to BGY2 or even to fellowship in the clinical pharmacy practice. As we mentioned, in Saudi Arabia, we have two programs. First one is Diploma Certificate in General Clinical Pharmacy, or what's known as BGY1, and its duration 2 years. Also, we have Saudi Certificate in Clinical Pharmacy, or BGY2. It's 1 year duration after completion of BGY1. As a total, if we complete it in Saudi Arabia, it's going to be 3 years. If you came from the state as a BGY1, which is 1 year, and you will complete the BGY2 in Saudi Arabia, the total will be 2 years. So if we talk about Diploma Certificate in General Clinical Pharmacy, or BGY1, the General Clinical Pharmacy Diploma Program qualify graduate to work with different patient care teams to deliver integrated pharmaceutical care and comprehensive medication management for patients. For the first year, it consists of ambulatory care rotation, inpatient rotation, sterile preparation, administration, medication safety and automation, drug information, and introduction to clinical rotation. For the second year, mainly focus on clinical rotation, 6 core rotation, including adult critical care, cardiology, infectious disease, as well as internal medicine, and 3 elective rotation, which is being administered based on the institution availability of the place. For example, transplantation, parenteral nutrition, nephrology, and etc., or pediatric as well. If we talk about the Saudi Certificate in Clinical Pharmacy, or BGY2, the Saudi Certificate in Clinical Pharmacy program qualify graduate to work with specialty patient care teams to deliver specialized pharmaceutical care and comprehensive medication management for a specific patient population. Varied specialty, including critical care, which is available here in Saudi Arabia, internal medicine, cardiology, infectious disease, parenteral nutrition, pediatric, oncology and hematology, nephrology, ambulatory care, transplantation, and medication use safety and policy. And for each program, it have its own policy, have its own guidance. So for this presentation, if you are interested to know more, please visit the website of Saudi Commission to know more about each specialty. So now we see all the information about the two programs, Master of Clinical Pharmacy and residency program. Maybe we ask ourselves, which one over one? I would say no one better than one. However, when I search in the literature looking for the market assessment for the graduate of the programs, including residency or even Master of Clinically, the literature is scarce, and there is no much literature support what's the outcome from the Master of Clinical Pharmacy and the practice, or in the market demand, or from the residency program. The only guidance that maybe I will rely on here is the statement position by Saudi Society of Clinical Pharmacy, which have their statement about the postgraduate program for the clinical pharmacy. So, as I mentioned, in 2021, Saudi Society of Clinical Pharmacy published its position statement that defined the concept of a clinical pharmacy, described the required education and training, and highlighted clinical pharmacist's scope of practice in Saudi Arabia. SSCP believes that there is a need to define and describe many of aspects related to the clinical pharmacy profession in Saudi Arabia, including education and training. And on those statements, I focus what's related to clinical pharmacy as post-graduation education. So start with the position 3, related to pharmacy education and training. The SACCP recommend that in order to practice as general clinical pharmacist in Saudi Arabia, one should pursue structured postgraduate pharmacy practice residency training or postgraduate master of clinical pharmacy, either from a national or international institution that is recognized by the national authority. So the statement is clear. So if we want to be a general clinical pharmacist, we can pursue either with Master of Clinical Pharmacy or postgraduate residency program, including the BGY1. Position 4 stated that the SSCP advised pursuing an accredited pharmacy practice residency training as the preferred postgraduate training. So the statement is self-explanatory, so you can decide based on this statement. Position 5, the SSCP advised for any master in clinical pharmacy degree to be at least 2 years, including a minimum of 6 months of clinical training that encompasses direct patient care in addition to dedicated coursework to prepare the graduate to practice as general clinical pharmacist. For position 6, the SSCP recommends that in order to practice as specialized clinical pharmacist in Saudi Arabia, one should pursue a structured, specialized postgraduate pharmacy practice residency training, either from national or international institution that is recognized by the national authority. So this is the statement from our society explaining which one graduated or that qualify you to practice as general clinical pharmacist, and those will support you to practice as specialized clinical pharmacist. So if you ask me, so what's your opinion, Ahmed? For me, I went through the both pathway as a Master of Clinical Pharmacy as well as residency program. I believe with this statement, which I will conclude with for this presentation, it's your reputation like the shadow. It could be gigantic when it's precede you and pygmy if it's in its proportion when it's follow you. باللغة العربية حرص على سمعتك. Either if you are Master of Clinical Pharmacy, if you are joining, or if you are in residency program. And if we think about the both courses or both programs, they are justified. When we are talking about a residency program, we wish everyone to have the residency program. However, the limited seated can be compensated by considering Master of Clinical Pharmacy. Also, for the Master of Clinical Pharmacy, it's considered one of the academic program initiated by Mother University in Saudi Arabia, King Saud University. And that's qualify many of highly qualified clinical pharmacists who practice in the field and providing the training even for the BGY1 and BGY2 clinical pharmacists. So it's your reputation, work on it, make it gynectic, جعلها ضخمة بأنها تسبقك ولا تجعلها صغيرة بأنها تتبعك. That's ending my presentation, and thank you.
Thank you very much, Dr. Ahmed. A very nice presentation. I felt so proud of being one of the candidates of our university because, as you can see, we are even beyond the standardized global education products around the world. The point here is that we're going to introduce Dr. Mohammed Shinawi for his speech. Dr. Mohammed Shinawi, he's a Saudi product. King Saud University. He's a general manager, director of the pharmaceutical care in the MOH. He gave us a very good example. He has a master's degree in MBA, which means pharmacy is not just science, chemistry, and medications. It's also leadership, management, and business-oriented mind. Dr. Shinawi, please, the mic is yours.
السلام عليكم.
أولا thank you everybody, thank you for being here. I usually start my talk by thanking the organizing committee and the conference for the invitation. However, I cannot do this right now. So I want to thank you for being here. And I want to thank the people that they are online for being with us. Thank you, Dr. Ahmed, for this great presentation. You did the nice job. Let me take the bad job and try to be a little bit naughty person. And I will pinpoint the problems that we are facing, and I believe everybody is facing. First of all, I will start with my objectives as an introduction and historical background, our current status, and the hospital versus clinical pharmacy residency. Is there any differences between both? Is the hospital is clinical or clinical is part of the hospital? Challenges, future expectations. And please do not consider what I'm telling, I will say in this presentation is quoted from anybody. This is quoted by only my experience in the field. I am not clinical pharmacy master graduate, and I am not a residency graduate. So as a disclosure, I have no financial relationship and no actual potential conflict of interest in relation to this activity. Healthcare system in Saudi Arabia, it's a national healthcare system as a background, in which the government provides a free healthcare services to all citizens through different healthcare sectors. Everybody, we all know about this. The governmental agencies that it control and regulate the health system starts from Ministry of Health. It provides healthcare treatments and medications for almost more than 60% of the population. And the Saudi Commission for Health Specialties, that they are responsible for regulates the healthcare and to give the license for all the healthcare workers in the kingdom. And the Saudi FDA, Saudi Food and Drug Authority, which regulates the pharmaceutical and medical supplies, the devices in the kingdom. So the healthcare expenditure worldwide, it is increasing everywhere, not just only in the kingdom. They will not request just only from you to minimize your budget or to decrease your budget. It's happening everywhere. The healthcare expenditure is going up worldwide, so it's not just only us. As a total healthcare expenditure, it reached to 45.90 billion in almost 2019. So, as a historical background, in late 1950s, the first school of pharmacy was created, not just only in Saudi Arabia, in all Gulf areas. It was King Saud University, the mother pharmacy college. And in the mid-1970s, the clinical pharmacy concept was introduced when clinical pharmacists from the United States implemented pharmacokinetics, parenteral nutrition and drug information services in King Faisal Specialist Hospital and Research Center in Riyadh. Then the traditional role of pharmacist in Saudi Arabia started to shift from focusing only in the dispensing to having more as not just only a bachelor degree, to go for a clinical oriented PharmD degrees. This is the exact year. So from 1959 until 2003, we had just only one College of Pharmacy, King Saud University. And then from 2003, we started to have pharmacy schools establishment. In 2015, we had almost 27 governmental and private pharmacy schools. And over 3,000 pharmacy graduates every year from all colleges. So pharmacy education, as all you know, entry-level degree in pharmacy is a bachelor degree or a doctor of pharmacy
implemented in many schools. Shortage of clinical colleges is a challenge. Many are seeking a local and international certifications like the ACPE, like the board certifications. King Saud University was the first to receive the ACPE accreditation internationally in 2013. Others have followed the King Saud University. Okay, pharmacy organizations. Saudi Pharmaceutical Society, established in 1988, and it has more than 6,000 members, and they have 9 board members. They are elected every 3 years, and they are different in interest groups, organize an international meeting, CIFA, every year. CME provider and publish the SPJ journal, which is very well reputed. Scientific Pharmacy Council, المجلس العلمي للصيدلة. It's under the Saudi Commission for Health Specialties. It's in charge of the National Pharmacy Residency Program, 2 years program, which is the R1 and R2, equivalent to, as Dr. Ahmed said, equivalent to PGY1. It accepts almost 85 residents a year. Other specialty residency program starts in 2013 as a 3rd year, PGY1 1 year. The 5th cycle started in January 2018, and we are almost approaching the 5th cycle, and the 6th cycle, inshallah, will start in January after 1 month. I believe the members, they are already elected, and they know themselves, but it's not announced maybe yet officially. The SSCP, it's under the Saudi Commission, again established in 2018, more than 1,100 members with the 15 board members, focusing advancing clinical pharmacy practice in Saudi Arabia, helps development standards of practice, participate in improving postgraduate residency training, published the Saudi Journal in Clinical Pharmacy, a new one. Congratulations for them, SJCP. That was released as a literature, pharmacy practice and the healthcare system in Saudi Arabia, which published by Dr. Jadea and Shuru Qaisi and Dr. Al-Mayman. It's indicating the increase in the expenditure, as I mentioned. And this is the one that Dr. Ahmed Al-Sagr, he indicated clearly the status of the SSCP for position statement by the Saudi Society of Clinical Pharmacy. It was published recently, and it clearly indicates the role and responsibilities for the clinical pharmacists. I will not go through the statements. Dr. Ahmed, he already did. The ACCP Task Force for Resident recommended, this is the American recommendation, recommended that by 2020, residency training should become the prerequisite for entry into pharmacy practice. This will be accomplished most effectively if employees and payers establish appropriate pharmacist credentialing expectations. Okay. I will tell you a scenario. Currently, we are open just only a clinical residency programs. Again, ya Jama'ah, and I'm not against anybody. I'm telling you the truth. This is the experience that I faced, and I'm still facing until today. Everybody will finish the PharmD program, then they will go to the residency. زي طلع كده من ابتدائي دخل على متوسط، بعد المتوسط دخل ثانوي، بعد الثانوي يدخل الجامعة، بعد الجامعة ياخذ الفارم دي، بعد الفارم دي الريزيدنسي، then after that the specialized residency and go on. It's totally different. So what happened? I know for a fact, everybody wants to do this. Everybody is looking for a professional growth. So they will search for the only thing that's available right now, which is the clinical practice. طيب. Those jobs, inpatient, outpatient, discharge, sterile preparations, narcotic and controlled, medication safety and quality, informatics and automation. Is it part of the residency? It is a rotation in the residency, but it will not allow you to be specialized in those areas. So what happened, that I will have everybody going through the residency program, then they will be a graduate of the residency, and at the end, they will be a clinical pharmacists. And you will have a fights with them in order to go back to the operational side, which you hate, and they will resist this going back to the operational side. So what happened? Clear conflict. What will happen? You will put more pressure on the operational pharmacists that you have. You will have a less number of staff. What you will do? You will increase the night shifts for the operational pharmacists. They will be more burned out. They will look at the residency program as this is a way to escape from working different shifts in our institution. So the poor pharmacists working in the operational side will get burned out. They will start to search where to go, keeping in mind that those operations will get affected. Tell me, who will dispense from your outpatient? It's a great idea to have the staff clinical pharmacists, but they are not specialized. I have a pharmacist in outpatient setting. They can dispense the medication, the prescriptions, very fast, very efficient, because this is their specialty. They know it. And on the other side, I have a clinical pharmacist. He's very competent in his knowledge and in his rotation, in what he's doing, and he's there with the healthcare, with the team, and he will provide his clinical knowledge. So, can we provide residency for those specialties? Is the hospital pharmacy is part of the clinical, or the clinical is part of? Statistic-wise, as you know, and I love numbers, it was released in 2018, indicating that from MOH, that pharmacists in the kingdom, they are 8.7 pharmacists per 10,000 population. Clinical pharmacy residency. We have an 88 seats, as it was released by the Saudi Commission, the Pharmacy Council, the Scientific Council. We have an 88 seats distributed among those sites. It's equivalent to 2.9% of our total graduates in the pharmacy. 2.9. We have 3,000 graduates per year. Specialized residency programs, keeping in mind that it's not just only limited to Riyadh and Jeddah. All other sites, they do not have a specialized residency programs until today. We have just only 52 seats as per the people that they will start in January 2022. And this is equivalent to 1.7% only from the graduates. Again, is it enough? Okay. So what's our other solution? As Dr. Ahmed said, go for the Master of Clinical Pharmacy. Master of Clinical Pharmacy, this is the end of it. He cannot do anything else. Master of Clinical Pharmacy, if he wants to pursue the R3, he has to go for the R1 again. He cannot do it. So, again, I'm not a graduate from this or this program. However, I can see, as Dr. Ahmed say, your reputation, your respect with the medical team. So your medical team, they can respect you. We have great examples, big names of our clinical pharmacists. They are graduated from our master degree all over the kingdom. If you want me to nominate somebody, I have my friend, my colleague, Dr. Hakim. He's one of the big names that I highly respect in the clinical pharmacy. He's a graduate from clinical pharmacy program. I'm not saying that residency program is bad. No, we have a big shining stars in our pharmacy field. Again, they are a graduate from residency programs. So we all agree that it's not enough. And whatever we will do now, tell me as an example, why the institutions, they are taking their residents, majority of the staff, they are taking their residents. Their employees in the institution. Go to any institution. Tell them, bring me your graduates from the residency program. They will tell you the acceptance is coming from the Saudi Commission. Great. Count them. If you find 100 graduates from the residency program, you will find 80 from the same institution. Don't tell me that the selection is coming from the Saudi Commission. Don't give me a fake numbers that it's coming from the Saudi Commission. Right? So this is a limitation. And I will tell you the truth. The thing that I faced, the institution will start to accept somebody from the outside institution because they do not have a seats for their staff. Again, ya Jama'ah, this is Muhammad al-Shinnawi. Don't be angry from me. I am transparent. I am transferring and transmitting the information that I need, that I face on a daily basis. So challenges: shortage of qualified clinical pharmacists, limited training programs, standard of practice, educational and training programs need to meet the international standards for accreditation, ACPE, limited national data on the practice of pharmacy exists, private sector involvement. Do we have a big hospitals in the private sector? Why we do not have single site accredited as a training site for a residency program? Pharmacy profession, over than 29,000 registered pharmacists, 8.7 pharmacists for every 10,000 people. Only 24% of them are Saudis. Practice areas include hospital, community, pharmaceutical industry, regulatory and academia and research. Is the people in working in the hospital, they are stepping on the people and the people's shoes that they really need to give the training? We all know that colleges, the people working in any college or any university, they are paid to educate. So if you are paid to educate, one of the things that we are facing in the hospital, once you go to any preceptor, I don't have time to educate. Take your residents out of me. So the people working in the hospitals, they are preoccupied by things. that Dr. Amna will come later on and she will say, I cannot give them more tasks. You are giving them more residents. So is the people, now we are wasting the time of the people, or we are taking the time and we are taking the job that it's really need to be done by other academic people. I am just releasing questions. So, do we really need a hospital pharmacy residency? And is there a possibility to have a combined master and residency program? Shall we bring the people in the academia? As Dr. Ahmed said, it's taking 2 years, almost 2 years and a half, to graduate or to take the master degree, and it's taking almost 2 years from the residency. Can we join both academic people and academia and the people from the scientific council, pharmacy council, to sit together and to unify the programs so the graduates will have the same benefits whether they took this program or that program? I am giving all of those questions, not to me, I am giving it to the new Pharmacy Scientific Council, inshallah that it will start in January, and I'm giving it also to our partners, our university, our academia people. If there is any possibility, please do it, because this will save us a lot of time, a lot of money, and it will increase the number of seats, especially if you go to the academia or to the colleges that they have university hospitals. Can we do this? Can we put a criteria to combine both of them? This is a question that I'm putting at the end. And thank you, everybody. Thank you for taking your time. And sorry for anything that I said that anybody didn't like. Shukran jazilan.
Dr. Ahmed, can we have you on the podium, please? I think it's a very nice session. خاصة الحين بدأ صلاة العصر، فقبل الصلاة كده نتناقش وبعد كده الصلاة تهدي إن شاء الله بإذن الله الحوار. I think I will start with my first question, Dr. Muhammad, Dr. Ahmed. Allah يعطيكم العافية. It was a very nice presentations. I think we are trying to decrease the gap between not just master and residency. I think what we are facing in Saudi Arabia is, what do we need? It's the biggest question. What do we need in our pharmacy profession? We'll start with Dr. Ahmed and then with Dr. Muhammad.
From my perspective, we're talking about what we need.
Your mic is away.
From my perspective, we're talking about what we are needing, if it's master or residency. As I mentioned clearly, both a program can qualify clinical pharmacists as per curriculum, as per coursework, as per research. Similar to residency program, as well as a graduate, a qualified clinical pharmacist. Again, for example, in my position now as a pharmacy leader, if I have 2 employees came to me, and one of them as a master and one of them as a residency program, first of all, I will look for what is his track. Is he having a good reputation? Is he doing a great? So this is the main things. For me, I am accepting both program, and I support them to increase the number. As we mentioned, we have a deficiency number in the clinical pharmacy in Saudi Arabia. So having both program available now, it's the recommended things.
Okay, Dr. Muhammad.
Well, you are asking a very difficult question for me. As I said that I'm not a graduate from this or that. However, comparing between both, it should be also compared in the accreditation, and the Saudi Commission qualifies both of them. Saudi Commission, both of them, they are clinical. However, in certain aspects, if you want to apply for a specialized residency, for example, it's accepted from the graduate of the residency program, but it's not accepted from a master graduate at all.
Okay. So I think this is part of the hassle that we are facing now. I would like to have the questions from the audience just in order. Okay, we'll start with Dr. Ahmed first and then Dr. Hakim.
I'm a Professor Maya. Most of you know me. Anyway, my question is, we keep talking about clinical pharmacists and pharmacists. Why do we talk about clinical pharmacists? Why are we differentiating these two entities in Saudi Arabia, since we are having a program which is PharmD programs? So what is the difference between clinical pharmacists and a pharmacist?
If you allow me to answer, it was answered, Dr. Iqbal, in the position statement that it was generated. Any graduate with a PharmD degree is not classified as, he cannot pursue the clinical duties unless he will get the master or the residency program, specialized residency.
But the terminology you're using, clinical, this PharmD gone through all the process of learning clinical. They've gone through rotation, they got all the therapeutic classes, and then they graduate. And now we are labeled them as pharmacists. So in my definition, if you're talking about places where you don't have the clinical program, you have a bachelor program, you may differentiate. But if you are dealing with a program where you have a PharmD program, in that case, everyone is clinical. I mean, yes, position statement is, spoke up by individuals, whoever wrote these things, but the question here is that how can you practice anything, even a filling a prescription, if you don't have a clinical knowledge? How can you process this prescription? Because not knowing, otherwise what's the difference between selling a drugs versus dispensing a drugs? So this is one of the things is keep bothering me with the definition of pharmacist versus clinical pharmacist. And second question is, what is the purpose of having residency program? I know you, all of you label, because I teach both of them. I am teaching master's program and also teaching your residency. I'm RPD, basically, for the, it's my product anyway.
Yes, I'm the proud resident to be one of your graduates.
Anyway, so the question here is that, is this the residency program is only training candidate for clinical work, or there is more to it? Because this is a big question. Clinical pharmacists can be anybody, but going through a program, they teach you a lot more than just the clinical part of it. They go into very deep and different type of leadership position we train them for, right? Then you have committees that they involve in evaluation, then you need deep knowledge. But just being clinical pharmacists through going through a residency program, to me is a defeating purpose rather than just label them as a clinical. And the third part is the master program versus the residency program. One of the problems that we're facing is that when candidates come out from the master programs and they go into the rotations, people are not taking them seriously. They're taking them very lightly, and somehow in a training by itself, they are not putting full effort in training them. So this is my personal observation. Versus when somebody comes with the residency program, we give them a lot of emphasis. So if everybody trained them as if like a resident in clinical master's program, everyone will be good. And they will be as good as PGY1. To me, so there should be any difference between PGY1 and somebody who just finished the master program, 2.5 years spending. They have a very good experience, and this is what I believe. anyway, I'm sure that there are a lot of PharmDs and residents and here's the Fagar is a clinical pharmacist practicing in cardiology and doing fantastic job. She's well trained. So I'm saying that if you want to utilize the individual who come out from the program, it's all dependent on the institution, how they channel them, how they process them. That would be the more important things, rather than we just looking for clinical masters and selecting. And I notice also a lot of directors have a bias toward residents versus the masters. Masters, they just put them in a dispensing area, and all of others are going everywhere and doing things. I think if you want to train somebody who already have a very good knowledge for your institution, as you mentioned about why we need more clinical pharmacists, or we need pharmacists, they can be utilized very professionally. Thank you.
Thank you, Dr. Maid.
Thank you, Dr.
Comment
I
on that?
have a
Yes.
comment when we discuss about clinical pharmacy from master or residency. We didn't critique that one is better than the other. Again, if we think that the master degree graduate not receiving, I would say, fair training, it's related to the academic institution, the university, if she is ensuring that their graduate will be trained, will receive equal opportunity as the residency program graduate. Vice versa, we talk about the Saudi Commission for Health Specialty when they ensuring that their graduate receiving the appropriate training via, I think, different accreditation process, meeting with the resident, ask them about their opinion. I think this question should be referred to the academia and to the Saudi Commission for Health Specialty.
Dr. Mohammed, any comments?
Dr. Iqbal, you mentioned, and you are as the thing that it's very strange that putting terminology as a clinical. I will tell you as many examples. They are a PharmD graduate from Saudi Arabia. They go to US to take the PharmD graduation certifications. This is the same terminology. And they are going to the US to take the same. If we consider that it is here, it's a PharmD, it should be the same. So we should reject. There is no difference between the PharmD in Saudi Arabia and PharmD in the US.
By the way, we fought this with the university from the US many times about PharmDs going from here to US, and they have to repeat a lot of things again.
Yes.
So repeating again, we have trained, and unfortunate part is that it is also financial
burden.
This is related to a university like Florida, University of Florida. I'm talking about my personal experience and being with these people who are you talking about. We have done several time discussion. That's why we're talking about the university having accreditation over just a recognition.
I will tell you an example from where that I brought this. So, if you have a graduate from PharmD in Saudi Arabia, he will take almost 6 years to be graduated. Then he will join an institution. At least 1 year training in this institution. After 1 year of getting this training in the institution, he will go to the States to take the PharmD from the States. This is another 3 years, 4 years, if he took it as an accelerated program from the States. So this is another 3 years. Then he will fail. This is a life example, I'm saying. He will fail to take a match with any residency program in the States. So he will come to Saudi Arabia. He will apply to the Saudi Commission. He will get acceptance in one of the residency programs, 2 years. Then he will get another acceptance for the R3. Then you will send him to take a fellowship for 1 year. How many years until now, Jamal?
عدينا 6 سنوات. عدينا
بعد الست سنوات يعني how many years?
لا عدينا 6 التانيين يعني كده another 6 years.
After all of those years he spent outside his institution, then he will arrive to your institution. What are you expecting the outcome? I believe, correct me, I'm not specialized in the residency يا جماعة. The residency program is designed that you will work in your institution.
Dr. Hakim, I think you need, you've just raised your hand. Yeah, if you can just give us your question, please.
Okay, it's a bit, thank you very much. Initially, let me thank Dr. Shinawi for the compliment he made. I also would like to thank the IHOP organization committee. I think there is a big change happening now. We are seeing many new faces actually presenting. In the last, let me say, decade, we always see the same faces in the presentations and the moderation. So thank you very much for this change. This is a good start. And also would like to thank Dr. Ahmed Al-Sagar for his wonderful presentation and his amazing conclusion. Now, I think we need to change the matter of mentality. It's not a matter of which program you are enrolled or you are graduate from. The mentality. Now, if we have those people who could look to the outcomes in objective way, very objectively. Now, we have the outcomes of the programs. It's not related surely for the program per se. Yes, we know that certain universities, certain programs, they have a higher percentage of people who excel in their career. This is a fact. But at least they say percentage. It's not a must that all graduates from program A, they will be the brilliant, and those will be graduated from program B will be the vice versa. Now, my comment is about changing the mentality. Is not matter of why it's MS or the residency. I mean, we could, myself, I am working at King Faisal Hospital. We have many of my colleagues actually, they are holding masters, and in the same place, we have many of our colleagues, they are graduates from residency programs, either from the kingdom here or from the United States. And everyone is requested to provide a certain objective by the end of the year. Each one has a certain duties that it need she or he need to provide by the end of the year. And according to these objectives, the pharmacist will get the rewards or the evaluation. Now, the issue is the kingdom here. We have it was actually in the last 2 years. I think we missed a very a chance, because we have graduates from the UK, Australia, the Kingdom, the United States, Canada. This issue actually you can view it very clear from our colleagues physicians. You don't see this problem actually when you look at from our physicians' prospect. All of them actually, when they are graduated, whether if the physician is holding MBBS or if the physician holding PharmD, at the end they are paid the same, and they are enrolled in a position in the hospitals according to this standard or minimal requirement or degrees that you need to practice safely and effectively. I mean, I find it very, to repeat, someone who costed the kingdom. Our budget around the College of Pharmacy, each student cost the kingdom around, let's say, $250,000 of Saudi riyals, and this graduate will be earning his PharmD. Then this personnel will be sent back abroad to the States to cost again the kingdom $500,000 Saudi riyals to reach to earn at the end a same degree. It is the same degree. It's a PharmD, for example, okay, or whatever the degree. Now, the issue is why we were unable to produce our own program, a hybrid program, as Dr. Mohammed just suggested, something to accommodate the MS and the residency program. Now, when we look at it from the other perspective, that we have, like, for example, the United Kingdom, they don't have a residency program, but they have clinical pharmacists. And the clinical pharmacists over there in the United States, by the way, in the United Kingdom, they have far privileges compared to their colleagues in the United States. For example, many of the pharmacists or the clinical pharmacists graduates in the United Kingdom, they could prescribe even narcotics. Those who cannot be prescribed even with a resident physician. On the other hand, their colleagues at the other side of the Atlantic, they cannot do this step. Now, it's not a matter who's better. It is the British or the US programs. It's not like this. Pharmacists, clinical pharmacists in the UK, they're doing a great job, and their colleagues all at the same time in the United States, they are doing a great job. And all of them, they're recognized as a clinical pharmacists. Each one of the clinical pharmacists in the UK have the path to grow till to reach, for example, a consultant position. And that's the same in the United States. Now, we missed this opportunity because we had the chance to send many of our students to the UK and the same time to the United States. But unfortunately, we were not unable to form in Arabic, بوتقة, to accommodate all of these graduates from different programs, and we could come with our own Saudi program that accommodates all of the personnel. Unfortunately, we lost this chance, and by viewing now the new leaders like Dr. Ahmed Al-Sagr, now he's a fresh grad and he's in a leader position. I think that now it's your time and your colleagues in this era to hold on as soon as we have this open-minded mentality that there's no program is better than the other, as soon as who's enrolled in the program will be the judge for himself, not for the program. Thank you very much. I'm sorry for making this comment lengthy a bit.
Just to wrap up this, I think we always follow the guidelines in our practice. We say American guidelines, Canadian guidelines, NICE guideline. So what we should have is a Saudi guideline for our teaching system. We can adopt the systems and get our own one, which is, I think, supposed to be made for Saudi Arabia service, not just to take graduates from one place and neglect the other. Thank you very much for your attendance. It's time, I think, for Asr prayer. And we are still there. Don't go after. And there's also an abstract competition waiting for the winners. We have winners for the abstract, inshallah. Thank you so much. See you, inshallah, after Salat al-Asr.
Thank you for your informative discussion. And now I'd like to invite Dr. Abdurrahman Al-Swaidi to thank our speakers. Dr. Ahmed Al-Sagr. دكتور محمد الشناوي. دكتور فخر الأيوبي. By now, dear audience, we will take a 10 minutes break, and after that we'll proceed to our last session. Thank you. To our last session, which is about pharmacy staff competency. And I'd like to welcome Dr. Ishtiaq Bajned to be our moderator for this session. تفضلي دكتور.
السلام عليكم. Today, this session is going to be about pharmacy staff competency. Our first speaker is Dr. Saleh Al-Anizi. He's a quality manager in the pharmaceutical care services in King Abdulaziz Medical City in Riyadh. He's also faculty member in the College of Pharmacy in King Saud bin Abdulaziz University for Health Science. He's an adjunct assistant professor at Al Ma'rifa and at Prince Sattam bin Abdulaziz University. He's a supervisor, surveyor in Sibahi in pharmacy. Please welcome Dr. Saleh Al-Anizi.
السلام عليكم. كده كيف الشو؟
هذا هو. طيب. هذا هو نفس العرض صح؟ اوكي خلاص. نبدأ من البداية؟ معك
السلام عليكم. أول شيء أنا والله حاب أشكر يعني الساينتفك كوميتي في IHOP للدعوة الكريمة ونتمنى لهم النجاح الدائم وكذا. My talk today about background requirement and regulation about the pharmacy competency. I will start with give the general definition of competency. After that, we'll talk about the core and structure of pharmacist competency and framework. After that, we go to that see what the challenges that may affect competencies of the pharmacist and what the rules of pharmacist in healthcare. And finally, I will close with the conclusion. This is a talk by John Maxwell. John Maxwell said that competency goes beyond word. It's a leader ability to say it, plan it, and do it in such a way that others know that you know how and know that they want to follow you. What are the definition of competencies? Competency is knowledge, skills, attitude, and behaviors that individuals develop through the education, training, and work experience. Competency in pharmacy practice play a key roles to ensure providing the highest quality and safest manner. Also, competency framework is a model that proudly describes performance excellence within an organization. What is the role of pharmacists in healthcare sectors? Pharmacists have a lots of roles in healthcare sectors, like pharmacists are drug experts. Pharmacists also can be decision making. Pharmacists can be a team leader. Also, pharmacists are supervising and managing work flow. Core competency framework. What is the aim of core competency framework? The aim is to reflect the practice of pharmacists in early stage, starting from hiring up to 3 years registered. There are 6 domains for framework competency. A number of behavior, أنا رحت كذا صح ولا خطأ؟ Okay. And attended that the framework would also be used to provide structure and guide for continuing professional development over the changing, demanding of pharmacist career. The domains, it's first one, the professional practice. Second one is personal skills, organization and management skills, public health, supply of medicine. Last one, safe and rational use of medication. Each 6 domains has a number of competency identified. We'll start with the professional practice. The first competency in the professional practice is practice patient-centered care, and also practice preference, practice legally, and practice ethically. Personal skills domain include leadership skills, decision-making skills, team working, and communication skills. The third domain is supply of medicine and include competency. First one, manufacturing and compounding medicine, manage the medicine supply chain, and review and dispense medication safely. Safe and rationale of medication, patient consultation skill, patient counseling skills, and review and manage patient medicine. Also provide medication identification and education. The fifth domain is public health, population health, health promotion, and research skills. Last one, organization and management skills include self-management skills, quality assurance, work management skills, and human resource management skills. A number of behavior statements are given for each competency to demonstrate how individuals who have the competency will be behaving in practice. Overarching the concept, the following list of competency for pharmacist and pharmacy technician. Pharmacist and pharmacy technician should be able to use a patient-centered care, focus on the patient need, value, and safety optimizing, practice in according with their jurisdiction and legislation, professional standards by law, guideline, and policies, are committed to lifelong learning, act as a mentor to promote the growth and development of professions, collaborate with the other and member of the healthcare teams, use the critical thinking and problem solving and decision making, take responsibility for their decision and provide leadership are appropriate, possess pharmacy specific knowledge, and hold the patient health and safety as a priority at all times. There are 9 categories of competency. The first one is the ethically, legal, and professional responsibility. Pharmacists practice within legal requirement, demonstrate professionalism, and uphold professionalism standards. Pharmacists are able to, first one, practice within the legal requirement, uphold ethically principles, manage actual and potential illegal, apply principle of professionalism, document activities of practice in compliance with the federal and professionals. Second one is patient care. Pharmacists in partnership with the patient and in collaboration with the other health professionals, pharmacists are able to, first one, develop professional relationship with the patient and obtain information about the patient, assess the patient health status and concern, determine the patient actual and potential drug therapy, implement the patient care plan, administer drug to the patient, monitor the patient progress, and assess therapeutic outcome. Third category is product distribution. Pharmacists ensure accurate product distribution that is safe and appropriate for patient. Pharmacists are able to dispense product and accurately that appropriate for the patient. This is mainly in inpatient and outpatient pharmacy. Practice setting. What's meaning of practice setting? Practice setting means the pharmacist oversees the practice setting with the goal of ensuring safe, effective, and efficient patient care. Pharmacists are able to, first one, optimize the safety, efficacy, and efficiency of operation in a practice setting. Second one, oversee pharmacy inventory to ensure safe, effective, and efficient patient care. Last one, oversee record keeping activity to ensure effective and efficient patient care. Number 5, health promotion. It means pharmacists are their experts to advance the health and wellness of patient, communicate, and population. Pharmacists are able to, first one, engage the health promotion and activity with the patient, participate in public health activity, and contribute the maintenance of the health environment of the public. 6th category is knowledge and research application. Pharmacists access, retrieve, critical, analyze, and apply relevant information to make evidence information decision within their practice. Pharmacists are able to apply knowledge, research skill, and professionalism, respond to question using appropriate strategies, apply relevant information to the practice. Number 7, communication and education. Pharmacists communicate effectively with the patient and the pharmacy team and other healthcare professionals. Pharmacists are able to establish and maintain effective communication skills, implement safe, effective, and consistent communication system, finally deliver and education session to individual or group. Intra and inter-professional collaboration. Pharmacists work in collaboration with the pharmacy staff and other healthcare professionals. Pharmacists are able to create and maintain collaborative professional relationship, contribute to the effectiveness of working relationship and collaborate teams, practice in the delivery of the collaborative health services, and accept and make referral for specific services. Last one, quality and safety competency. Pharmacists collaborate in delivering, implement, and evaluating practice and activity that promote quality and safety. Pharmacists are able to, first one, contribute to a culture of patient safety, contribute to continuous quality improvement and risk management activity, ensure the quality, safety, integrity of product. Last one, create and maintain a working environment that promote safety. Now, what's the challenge that may affect competency of pharmacists? First challenge is lack of support from hospital management, and also absence of clearly defined roles and responsibility for pharmacists. Also, the shortage of pharmacy workforce and staff turnover. Conclusion, competency in pharmacy practice play key roles to ensure providing that highest quality in the safe manner. The competency framework contains 6 domains: professional practice, personal skills, supply of medicine, safe and rational use of medicine, public health, organization and management skills. Thank you. This is my last slide.
Thank you, Dr. Saleh. The second speaker today is, in our session is Dr. Umayma Arab. Dr. Umayma Arab earned her bachelor's degree from the pharmaceutical science from King Saud University. She continued her Doctor of Pharmacy degree in the US and completed her postdoctoral degree training also in the US in ambulatory care. She held triple American board certification, pharmacotherapy, medication management therapy, and ambulatory care. She is the one of the holder of the MOH SSCP immunization delivery certification, and today she is going to talk about her experience with this. Please, Dr. Umayma Arab.
Hello, good afternoon, everyone. I would love to see more in the crowd to share our success story today about immunization-based, pharmacy-based program. This presentation actually is a product of the collaboration between the Ministry of Health and the Saudi Society of Clinical Pharmacy. Today in my presentation, I will review pharmacy-based immunization in Saudi Arabia through literature. Then I will describe the implementation of pharmacy-based immunization program and the setting of the training. Lastly, we'll indicate the program expectation and outcomes. So to begin with, we all know how vaccines are important. It helps us. It helps our new generations, our newborns to have a chance to grow healthy life and to eliminate infectious diseases where it was once widespread infections that led to complications and death at some points. It helped to reduce mortality. It helped to prevent infectious diseases. Also, stop the development of antibiotic resistance by reducing the use of antibiotics, which really is well known that when immunization is given, then we reduce the use of antibiotics. And lastly, it helps also you to travel safely and comfortably. And lastly, it also provides economic benefit by saving on the cost of treating those infectious diseases. So we all know that vaccine is important. It can be done through different healthcare professions, but pharmacists are repeatedly cited as a trusted profession. We are considered one of the most accessible healthcare professionals, and we have received extensive education and all that with the medication, and vaccines are part of the medications. So we are the people who should be educating, advocating for vaccines and administrative vaccines. So pharmacists are logical providers of immunization services due to their accessibility and role as medication experts and experience providing high-quality patient care services. Moving to the world, actually everybody in other countries are giving immunization training to their licensed pharmacists so they can provide widespread of immunization and help reducing complications of infectious diseases. Pharmacists' role in immunization services has evolved in the past 2 decades, let's say. Those pharmacists are available in North America, South America, Asia, Europe, Australia, and some countries in Africa. Here in Saudi Arabia, we are activating the pharmacist role to give vaccines. This program has been one of the major programs that we wanted to establish and activate pharmacist role, and the pandemic actually pushed us to do it as a priority. So in Saudi Arabia, I'm using here 2 different studies. The first one is really important. It asks about the pharmacy readiness and willingness to provide immunization. So this survey was done in 2012 by Al-Balkhi et al. This survey was completed by 139 pharmacists, where 55% of those who completed the survey actually showed their willingness to administer vaccines in a community pharmacy setting. And the benefit that they saw in this service, that they will actually help in the expansion of the rate of immunization coverage and help as they are available in the neighborhood. So accessibility is another major benefit that they saw while they actually expressed their willingness. In the second paper that was published in 2020, just before the pandemic, and that was by Al-Alola, 2020, they interviewed individuals in the community pharmacy where they actually asked participants if they're ready for receiving the immunization services from community pharmacy. They have been accepting in some of the surveys this immunization services provided by community pharmacy. Some participants actually expressed some concerns, and here listed are 4 major concerns. Community pharmacy, their current level and ability and skills in providing immunization. Second thing is the private area. They wanted to have private area for immunization. Third one is availability of female community pharmacists where they can provide the immunization. And last concern is the cost of immunization services, if it's going to be out of pocket or through insurance or by any other means. I like this study because they mentioned here that participants advocated for supervision of such services by the Ministry of Health and the standardization of community pharmacy staff. For that reason, the Ministry of Health has released, or you can say, passed this regulation. It was early in 2021. اشتراطات وإجراءات تقديم خدمات الرعاية الصيدلانية في الصيدليات. And I'm going to go in my presentation through some of these points that were mentioned in this regulation. I'm going to start with the journey. So early in 2021, the Ministry of Health has invited ambulatory care clinical pharmacists from different hospitals with different experiences, infectious disease clinical pharmacists as well. We all together written the scientific content of the program, the manual that we used for the training. Then it was ensured by the Saudi FDA to have the regulation and the laws implemented, such as privacy of the area, we can say anaphylaxis management, these kind of things. And then it was passed to the Saudi Society of Clinical Pharmacy. We actually started to implement the workshop. And then we took it to the Saudi Commission of Health Care Specialties for accreditation, and then it was finally implemented as training and certification program. In that manner, the immunization delivery certification was already within few weeks after the initial initiative was gathered. So now we have active role of the pharmacist in the community to give immunization. As I mentioned, we have gathered this information from high standard immunization protocols such as the CDC, the ACIP, WHO, and APHA. It has been created and developed based on high level of immunization standards to achieve proper vaccine administration and ensure safe and effective immunization. The training module consists of 9 major modules. It starts from general information down to the COVID-19 vaccines, and that was a major focus in our training modules. And it was accredited by the Saudi Commission for Healthcare Specialties by 8 hours. I have a snapshot here for the scientific content, and this is actually about the anaphylaxis management. It has the severity, how to manage it, and the type of allergic reaction that any pharmacist could encounter and how to manage it. In that manner, I want to mention also that in this regulation that was passed, these pharmacists are allowed to give vaccines to targeted groups. Those are 18 years old or older. Pregnant women, elderly, patients with, who are immunocompromised, chronic diseases, pilgrims, and travelers. Then they mentioned in this protocol or the regulation what type of vaccines that should be covered, and it's 9 major vaccines for adults, including the COVID-19 vaccines. The program consists of self-assessment questions, theoretical part, practical part where the hands-on training should be completed on site with assessment of training of for the training of injection and safe needle use, and lastly the post-seminar exam, which is the final exam, so they have to pass successfully 70% of the program to get the certification. And by the end of the program, they have to fill the survey, so we can actually make sure that the quality of the program is improving rather. Here I'm sharing just a few pictures of the program. When it started, it was live sessions, daytime, more than 8 hours a day, or evening hours. We did a few sessions here and there with the different hours. And then we moved to the recorded sessions. But at the end, and I will share this later also in another slide, how it is actually implemented in an electronic platform where everyone can just go and sign for the program. Now here are the trainers that we have in the program. Those are ambulatory care clinical pharmacists, infectious disease clinical pharmacists, all of which they have pharmacy-based immunization delivery course, either here or internationally. So clinical instructors were the people, the experts who trained our pharmacists on the hands-on training, and we have supervisors from the Ministry of Health. Locations, it was centered in Riyadh, then we moved to Jeddah and Dammam to expand and have more coverage across the country. Now I will share exactly the success story. Since March 2021, we have trained about 323 pharmacists, and in the major 3 cities where they actually practiced in their cities as well. So we're talking about Al-Ahsa, Al-Hafuf, Dammam, Tabuk, Hayel, Najran, Al-Baha, Jeddah. We had actually covered a lot of areas with those pharmacists who got the training with us. Those pharmacists actually gave up to 163,000 vaccines since we launched. This is really a huge number. They have, in this way, they have actually participated in the national program of COVID vaccination. This is the breakdown since we started. And I want to mention that the program is built and has been supervised by the Ministry of Health, the Saudi Society of Clinical Pharmacy, and the Saudi Commission for Health Specialties. And that makes the program really well established and regulated very well. So for documentation, I'm going to share also how documentation is happening for the immunization. 3 things has to be completed before vaccination is given through community pharmacy. First, pharmacy is licensed. Pharmacist is registered in the Saudi Commission for Health Specialties, and we have to have this certification of training completed. And the regulation that has been passed, patient consent should be there, explanation of vaccine offered, electronic medical system, space requirement, anaphylaxis emergency protocol, infection control, and specifying the working hours where they actually provide the vaccination in this community pharmacy. Here on the right side, you can see an example of a patient consent. And on the next slide, I have just examples of allergic reaction management. It has to be developed and implemented in the community pharmacy where they can react to any reaction. Most importantly, they have this protocol based on the severity and the pharmacy setting, and most importantly, to report it to the pharmacovigilance. For the documentation, there has to be the patient information, the vaccine information, immunization provider information, VES, or the vaccine information sheet for each vaccine that was given, and reporting any side effects that has happened, if any. And toward the end, we have to stay on top of this certification. It lasts for 2 years. It has to have a BLS or CPR active as well to have this certification active. So the practitioner also needs to be engaged in continuing professional development to keep up with the updates and the dynamic changes with the vaccination. With that, I end my presentation. Thank you.
Questions? I have questions for Dr. Saleh. So that was the basic competency. Actually, it's also new for me that any new pharmacist has to have a competency for the first 3 years, as you mentioned. So it's kind of an intensive program for the first 3 years of employment, so the pharmacist can be competent as pharmacist. Is that correct?
It's not really programs, but when you start as a new hiring, and for example, a Ministry of Health or King Faisal or National Guard, you will start as an outpatient pharmacist, a new pharmacist. You will take a lot of training gradually. Up to 3 years, you have finished everything. For example, in our hospital, in National Guard, we give the new hiring around 6 months or 4 months for orientation. He can start with everything. He take rotation even with the director of pharmacy. He take rotation with the quality management. He take with the IT. Should be he know everything. He know how to take our decision making. He have to learn how to do the project for improvement. How to use the automation. This is many things. The clinical information, it can be get it from anywhere.
Yes.
But some skills is difficult to take it from the book.
Yes.
From experience.
Yes.
This is not what I need.
Yes. So knowing that those competencies has very extensive competency. So even 6 months of, let's say, training, I don't think all staff will be able to conquer all those competencies. So do you think the pharmacy management, when they hire someone, has to have like a assessment for each one based on that competency? Like annually or every
6 months مثلا.
We should. I believe, by the way, ممكن دكتور سعد know me. I believe with the leadership. Leadership, everything. The good leader, he will give good work.
Yes.
A leader الممتاز, he can manage, assist his or her staff. كل شيء في الكومبتنسي list of competency this one ولا غيره أي حاجة. هو كل organization أو institute عندها ممكن تحتاج competency أكثر. يعني فور اكزامبل ممكن اطلع برا بس يا دكتوره بس دقيقه في موضوع بطلع به على موضوع الريزدنسي والكلينيكال فارماسي. يعني التريتمنت كله في هيئه التخصصات. التريتمنت كله في هيئه التخصصات. انا بامكاني يعني هيئه التخصصات اسوي كومبتنسي اكزام بعد للماستر سيرتيفايد. نفس الاكزام اللي ياخذونه الريزدنت اذا نجح فهو كواليفاي انه يصير ريزيدنت زي الناس الثانيه. This is هذا one of the competencies.
Yes.
By the way.
For Dr. Umayma, it was great presentation, great experience, and I'm really happy that we have something like this, privileging the pharmacist with a certification that gives them competency, that gives them knowledge, that gives them licensing. The first question is, do they have to renew it after 2 years? Taking the same course again, ولا في another way to renew it?
Well, thank you for your question. It is really important. We will have a mechanism for renewal. It's going to be different than doing the whole program again. It's going to be very simple in a manner where they either earn hours or retake the exam. Probably will come with a decision sometime soon. It's been only 8 months since we launched.
So that's great. That's the first question. The second question is, as an ambulatory care pharmacist, clinical pharmacist leading the network, do you have a planning for other competencies, certifications, like for example anticoagulation, or not just for clinical pharmacists, but I mean for everyone to manage anticoagulation, to manage let's say diabetic medication, any other medications?
So for training or certification, it is available internationally, and we would love the idea to be nationally as well.
Yes.
So whatever the need or the demand, we'll work with it. Probably there are many in the pipeline, but I'm not really sure what would be the first one though. These programs come in collaboration with the Ministry of Health, with the decision makers. So we'll see what's next.
Okay. Dr. Saleh, regarding, I've noticed as a surveyor for Sibahi, there are some competencies that is required, but it has no, from Sibahi and GCI, but it has no structured certificate existence, like for example, TBN certifications. Or they would say the staff has to have an annual certification or annual competency of sterile preparation, or for example hazardous medications, or even drug information. Those are statements in Sibahi that requires the pharmacist and the pharmacy technician to have those kind of certifications or competencies, but they are not existent. Like there is no official competencies like this. So how can we, as pharmacy leader, to meet this Sibahi criteria, one, and if we need to do something like this, how can we do it in real life?
Well, I agree with you. There is no clear competency for them, but I will explain to you. First, the important competency this after probational period, after 3 months, for the new hiring, it's mandating there is competency exam as a competency for the new hiring after 3 months to go to the work alone. Okay. Regarding to the IP competency, he can take any certificate from any approved center and renew it every year or every 2 years. By the way, there is a new standard from Sibahi. اسمه الأولويات الحكومية 10 standards no more 41 standard now there are only 10 standards. It's comprehensive standard by the way يعني. We did our trial last week to check it can be applicable for the hospitals. The aim from Sibahi to raise the bar for safety and quality. Not all the competency required like before, but there is new things is required.
The problem is with these the approved centers is there is no really approved accreditation for those centers, and some of them are really taking the chance. I would say to take to even يعني some of the certifications is like 9,000 or 6,000, and there is no regulation of what is the contact, how long the duration.
مشكلة المستشفيات والشؤون الصحية يتحملون المسؤولية. المفروض يروحون للمراكز اللي معترفة واللي سعرها أقل، لا يروحون للحاجات الغالية.
ما هي حتى اعتراف المراكز غير موجود، يعني ما في حاجة اسمها مركز معترف.
اللي يدور يلقى يا دكتور، اللي يدور يلقى.
هي هم زي السيرتيفيكيتس اللي حصلت في الاميونيزيشن. بتروح الناس بتعمل ابلاي فور سعودي كوميشن على اساس انه هو بروجرام عليه CME زور، بس في بعض الاماكن 9000 في بعضها 6000 يعني، وهذا يضطر المستشفى ان هي ترسل الستاف حقينها عشان يروحوا يعملوا certification. But this يعني why it's not gonna be يعني ليش ما اكون انا certifying body يعني، بس ما في لا في certifying body ولا في certificate. I think we need even مثلا دكتور محمد شناوي everyone here we need a regular pathway to do those kind of certificates.
I mean, further to what Dr. Saleh has mentioned, it's necessarily that our annual evaluation for any employee, that it mirrors their job descriptions and the competency that we want. So, I mean, and we should try to avoid those general evaluations, I mean, that usually, I mean, some institutions that they are using. You should evaluate your staff based on their job descriptions and the competence that you want them to be on. Okay. And that, thank you.
Yes, I do agree that there is a lot of variation that, or a lot of financial compensation that you need to pay. However, I believe any institution that it will require, for example, as a me, I need you to be trained in the sterile preparations. So it is your responsibility to go and pursue this for your employees. Asking them to pay for this, I believe this is
even on the institution part يعني 9000 is a lot ولا
طيب, an institution part, it is our responsibility. For example, for us, for the same program, we arranged similar to the vaccination program that with the SSCP. We have another program, again, more or less it's similar to the one to the vaccination program, but with the SPS, Saudi Pharmaceutical Society, and it will be done next month for the medication safety officers all over MOH hospitals.
Yes.
And I will be responsible for the payment for them.
Yes.
As an MOH.
بس هي المشكلة مو بس في البيمنت, it's for the standardization. يعني some of them will offer it for 1,000. Another one will offer it for 9,000. One is just 4 days. One is 2 weeks. فيعني there is no standardization whatsoever.
The difference here is an accreditation. So which program is accredited? Previously, before our vaccination program, we had another vaccination programs. However, it was not, as you are saying, it was different between one institution to another institution. Again now, if we give this example, sterile preparation programs, Every institution right now, they are doing their own program.
Yes.
And they are giving you certifications. It's totally different if you go to this program or to that program. However, what we are working right now, again, with another people, with the SSCP again, to have a standardized program accredited from the Saudi Commission for the Health Specialties. So by this, we can go to Sebahi and tell them, you need to give us or to certify the people based on a certification accredited from the Saudi Commission.
Yes.
Whoever is the provider,
Yes.
MOH, SSCB, another community, or anybody else. But it has to be accredited from the Saudi Commission.
Any question? Yes. Thank you all. And now I would like to thank our distinguished speakers.
Now I'd like to invite Dr. Mohammed Al-Shinawi to thank our speakers. لا لا الدكتورة أميمة عرب. الدكتور صالح العنزي. الدكتور اشتياق باجنيد. Dear audience, this was our last session. See you tomorrow, inshallah. And now we would like to invite you to take your lunch in the Horizon restaurant in the North Tower after passing the lobby. Thank you and see you tomorrow.